and we want to allow time for questions and answers. This is an informational hearing on two factors that are related, 340B and PBMs, Pharmaceutical Benefit Managers. And we will begin with a bit of a review of what we did in 2022 when we had a similar hearing. Julia, thank you.
Good morning, Chairwoman and members of the committee. My name is Julia Kofoid. I'm a research analyst for KLRD, and today I will be going over the report from the 2022 Special Committee on the Federal 340B Drug Program. This committee met October 20th and December 9th of 2021, and during these meetings, the committee received testimony on the background and history of the 340B program, including how stakeholders such as participating medical facilities, pharmacies, PMBs, and drug manufacturers work together under this program. Representatives of these stakeholders presented testimony on their experience with the 340B program, and legislators from 2 other states provided information on their experience passing 340B related legislation in their respective states. In addition, the committee received information about pertinent federal legislation and the relationship between Medicaid and the 340B program, and a briefing on 2021 HB 2260 and 2021 HB 2383. The committee ultimately had 2 recommendations. The first was to consider 340B specific legislation, and the second was for the Legislative Division of Post-Audit to perform an audit to better understand the impact of the 340B program in Kansas and on Kansas hospitals. And with that, I'm happy to stand for any questions, Madam Chair.
Are there any questions for Julia Committee? All right, seeing none. We are going to continue with our testimony, and first we have from Paragon Health Institute, Senior Policy Analyst Jackson Hammond. Jackson, welcome to committee. While he's coming up, members of the committee just want to tell you that the testimony is on the S drive and under pharmaceutical studies, under special committees, and in alphabetical order for the first day. Jackson, welcome to committee.
Mic is not on. Thank you. 340B being one of them, as well as drug pricing and other issues in healthcare. I would like to thank the committee for allowing me to speak today on the history of the 340B drug pricing program and its interaction with pharmacy benefit managers, also known as PBMs. This program is the 2nd largest federal drug pricing program in the country behind Medicare Part D in terms of overall expenditures, and is expected to overtake Part D in the next 5 years. The 340B program has had a profound impact on the landscape of American healthcare, in large part due to the significant growth of the program has experienced over the last 3 decades. These impacts include increased consolidation, higher drug prices, and increased health insurance premiums, and increased taxpayer dollars, spending of taxpayer dollars, excuse me. In this testimony, I will explore the history and growth of the 340B program, its impact on the healthcare landscape, and its interaction with other stakeholders in the health industry. The 340B program has its roots in the creation of the Medicaid Drug Rebate Program, also known as MDRP, in 1990. Prior to the creation of the MDRP, pharmaceutical manufacturers often provided their drugs for free or at a discount to a small group of safety net providers to help enable those providers to supply uninsured or underinsured patients with prescription drugs. However, this changed when Congress, seeking to lower prescription drug spending in Medicaid, created the MDRP in 1990. The MDRP included a best price provision that mandated pharmaceutical manufacturers give Medicaid the lowest price for a drug in the U.S. market, with no exemptions for charitable donations or discounts. The lack of exemptions caused charitable donations and discounts to safety net hospitals to dry up, In response to this government-created problem, policymakers attempted to provide a government solution. In 1992, Congress passed Section 340B of the Public Health Service Act. Section 340B required manufacturers to provide covered entities, also known as CEs, including qualifying hospitals and other specified providers, with discounted drugs as a condition of participation in the Medicare and Medicaid programs. As a congressional report on its passage noted at the time, 340B was intended to, quote, stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. The 340B discounts apply only to prescription drugs and biologics that are used in an outpatient setting. Orphan drugs do not qualify for 340B discounts. The Medicare Payment Advisory Commission, also known as MedPAC, has conservatively estimated the average value of 340B discounts to be roughly 22.5% of the average sales price of a drug. The Health Resources and Services Administration, also known as HRSA, who oversees the 340B program, estimated that 340B discounts typically range between 25 and 50%. In 2020, the Centers for Medicare and Medicaid Services, also known as CMS, estimated the 340B average discount to be 34.7% below the average sales price. The pharmaceutical industry estimates the 340B discount averages 59%. The Minnesota state government, which passed a bill requiring transparency in 340B, found that discounts average 51% for Minnesota CEs. This range of numbers is important to note because outside of states like Minnesota, which include Washington and Maine, that have passed transparency legislation, data on 340B discounts and spending remains largely inaccessible to everyone except CEs and HRSA. Only qualifying patients may receive discounted drugs, but the definition of a qualifying patient is so broad that any patient ever seen by a CE could count, as long as the CE maintains a medical record of that patient. As such, individual CEs frequently have criteria for who counts as frequently have different criteria, for who counts as a qualifying patient. Under statute, CEs include publicly owned and nonprofit hospitals that serve a large population of low-income Medicare and Medicaid patients and meet a specified disproportionate share, or DISH, adjustment percentage, a metric designed by the federal government that attempts to approximate the level of low-income patients who receive care from a given hospital. Federally designated DISH hospitals, freestanding cancer hospitals, and children's hospitals must have a DISH percentage higher than 11.75%. Sole community hospitals and rural referral centers are required to have a DISH percentage of 8% or greater, while critical access hospitals are not required to meet a specified DISH percentage. Other CEs, known as federal grantees, include federally qualified health centers, hemophilia treatment centers, and Ryan White clinics. CEs may contract with outside pharmacies, known as contract pharmacies, in order to provide drugs to their patients. All sites of a single CE are considered part of the main CE. For example, a hospital's off-campus outpatient department or satellite clinic would be considered a part of the hospital. Therefore, those patients could receive 340B drugs. There are no requirements for what CEs do with discounted drugs. They may provide them to the patient for free or a reduced price, though CEs, and hospitals in particular, frequently sell 340B drugs to patients for a profit. This latter practice creates a profit from the difference between the discounted price paid by the hospital and the price the patient pays, known as the spread. The spread is how CEs derive value from 340B, through buying drugs at a low price and charging patients and their insurers a higher one. While 340B discounts are prohibited for drugs purchased using the Medicaid rebate price, Medicare does not account for the 340B discount when reimbursing providers for drugs. The spread is particularly profitable when private insurance is paying. One report from the Community Oncology Alliance found that 340B hospitals charge private insurers 3.8 times their acquisition costs. There are no requirements regarding what CEs must do with any profits obtained through this spread. It is notable that one study analyzing Medicare cost report data in 2021 found that 69% of 340B DISH hospitals provide less charity care than the national average for short-term acute care hospitals. The growth of the 340B program. When 340B was implemented in 1993, fewer than 100 hospitals were enrolled. By 2005, there were 583 hospitals and over 2,400 CEs enrolled in total. By 2010, the number of hospitals had more than doubled, as had the number of total CEs. As of 2024, there are nearly 3,000 hospitals participating, over a 30-fold increase from the program's first year, and over 14,000 CEs in total. In the state of Kansas, there are 81 participating 340B hospitals. The program's most dramatic expansion began in 2010, going from a limited program worth only 2.1% of annual prescription drug spending to 14.7% of annual prescription drug spending by 2023. As noted by the Congressional Budget Office, also known as CBO, this spending increase has several factors outside of the growth of the overall pharmaceutical market, namely the integration of hospitals and off-site clinics, increased facility participation after the Affordable Care Act, known as the ACA, and the expanded use of off-site pharmacies. The vertical consolidation of independent off-site clinics by hospitals is well documented. Between 2007 and 2017, the percentage of physician practices owned by hospitals or health systems grew more than 20 percentage points. This consolidation has led to a 3.3% increase in prices for hospitals and a 15.1% increase in prices for physicians. This provider consolidation has driven and been driven by growth in the 340B program, which offers a lucrative revenue stream for hospitals. Some safety net hospitals have begun acquiring independent practices or building off-site clinics in wealthier areas to bring in more revenue from wealthier insured patients. As reported by the New York Times in its profile of Bon Secours Mercy Hospital, this has occurred even at the expense of indigent patients. The ACA contributed to 340B growth by significantly increasing the number of Medicaid enrollees. This enabled more CEs to meet 340B's DISH percentage requirements, which factor in the number of Medicaid patients to which a CE provides care. It also expanded the types of hospitals that qualify for 340B status. This includes sole community hospitals and children's cancer hospitals, among others. The ACA contributed to 340B growth by significantly increasing the number of, contract pharmacies have played a major role in 340B's growth. In 1996, HRSA and CMS issued guidance allowing hospitals without an in-house pharmacy to contract with a single external pharmacy. This was done to allow rural hospitals and smaller hospitals that lack the infrastructure for an in-house pharmacy to participate in the program. At the time, only 6 contract pharmacies existed. By 2010, almost 1,300 contract pharmacies were used by CEs. As of September 2024, there are 32,528 active contract pharmacies in the 340B program, an increase of well over 2,000% from 2010. See Figure 1, which is in the testimony. I also have copies of the figures in a folder in my backpack. The proliferation of these contract pharmacies, as well as the increase in CEs overall, has caused spending in this program to jump significantly over the years. In 2005, spending by CEs on 340B drugs was $2.4 billion. By 2023, spending had reached $66.3 billion, with hospitals accounting for 87% of 340B purchases. The rapid growth of the 340B program is not without consequences for patients and taxpayers. CBO found that the 340B program's impact on hospital behavior has resulted in greater federal spending due to increased healthcare consolidation, higher drug prices, and reduced rebates for insurers, among other issues. At least one study has also found that a higher presence of 340B providers is associated with higher insurance ACA exchange plan premiums. resulting in increased annual spending on federal subsidies for those exchange plans by over $2 billion a year. As Figure 2 illustrates, there are many touch points in the 340B system and many places where entities other than CEs can profit from the program. As noted above, CEs may profit from the spread derived from selling drugs to patients. Contract pharmacies can profit by taking an administrative fee from the CE's share and may also have additional charges paid by the patient at the counter, while third-party administrators that handle the billing, ordering, and compliance also take a fee. The Minnesota state government found that third-party administrators and contract pharmacies received 16% of gross 340B revenue paid to external parties. PBMs themselves benefit in multiple ways, through ownership or affiliations with contract pharmacies, as well as ownership of third-party administrators. One study by Avalier Health noted that, quote, 69% of contract pharmacies were associated with a PBM through either vertical integration or contractual arrangement. Insurance companies that own PBMs also benefit from the program. It is very difficult to understand the web of relationships and exactly how and how much each stakeholder profits from 340B because much of the necessary data to do so is not reported by CEs and other stakeholders. It should be noted that due to the rapid growth and subsequent entrenchment of 340B as a revenue generator, many hospitals have come to rely on the program. For some hospitals, typically small independent hospitals, revenue generated through 340B discounts is vital for survival. For large, quote, nonprofit, unquote, hospitals and health systems, however, 340B is simply another tool for profit maximization. 340B has transformed into a program where almost every stakeholder and middleman in the healthcare system benefits, except the patient. While 340B was intended to help nonprofit institutions, many for-profit entities generate revenue from discounts intended to help patients. The complete lack of data transparency in the program means that we cannot know who is making how much at what part in the supply chain. These problems are a direct result of a program that has grown much larger, much faster than policymakers initially conceived. Now, I will turn to what is ongoing at the federal level in terms of 340B reform. Senator Gothridge?
Yes, Jackson, if you don't mind, we'll take a break right there for questions and then.
Oh, happily, yes.
And just members, so that you know, we had testimony scheduled from our federal legislators. However, with some other things that are going on in DC, they sent some written and we're allowing Jackson to share because he's done some research along those lines as well. So we did receive written testimony. It's in your file from Senator Moran's office and from Roger Marshall's office. From Senator Moran's office, they had referred us to the website where they kind of talked about the purpose of the 340B task force. And they're working on things as we speak. So any questions for Jackson up to this point? Yes, Senator Owens.
Thank you, Madam Chair, and thank you, Jackson. So we're just talking 340B at this point. He's going to go on to talk about PBMs. Am I understanding that correctly?
They're kind of intertwined in the fact that PBMs are part of the 340B program. So yes, at this point, yes.
Okay. So Jackson, first question, does Paragon Health support or oppose the 340B program?
It's not necessarily a question of oppose or support, and I don't want to speak for the entire organization, but we view the program generally as something that it is. It exists. It has integrated itself deeply within the healthcare system, as I mentioned in my testimony. It's very important to some and particularly small independent hospitals' survival. As such, it has become what started out as a way to provide cheaper drugs to hospitals and therefore cheaper drugs to patients, has morphed into a de facto hospital subsidy program that if we pulled the plug on would create a bunch of problems, again, for particularly small independent hospitals. As such, what we look to is to reform the program to ensure that it is helping the patients it's intended to help in the hospitals and facilities that are seeing those patients, namely poor indigent patients, those who are uninsured or underinsured.
if I may. Thank you. Well, and I appreciate that further explanation, because as I read through and listened to your testimony, it would seem to me about 95% opposition to the program from the perspective that I heard. And so I just wanted to clarify, and your last statement, I think, was very poignant, that there are our smaller hospitals, our rural hospitals. What's your stance on 340B program within our FQHC, or our community mental health systems?
The FQHC and the federal grantees are, frankly, the least problematic actors in all of this. They are actually, hospitals do not have very many transparency requirements, if any. FQHCs have a lot. They have to say how much they're getting from 340B. They have to show where they're putting that money, how that spending is being used. So they have they're very different actors in this space. I think it's very important to them. I have frequently discuss, particularly with like Ryan White Clinic folks who work on HIV and AIDS issues. For them, 340B is critical lifeline.
Okay, thank you for that clarification. Thank you, Madam Chair.
Committee, other questions? Yes, Representative Reese.
Thank you, Jackson, for being here, but I don't know who you are. I've never heard of Paragon Health Institute, and I'd like to know a little, just tad bit more of what Paragon Health Institute is about, and what's Paragon association with PBMs and 340B programs?
So Paragon Health Institute is a nonprofit, nonpartisan think tank in Washington, D.C. We focus on, as our motto goes, reforming government and empowering patients. This goes across various different federal health care programs, Medicare, Medicaid, the ACA exchanges. We look at private insurance issues as well through ERISA and other laws. We focus on healthcare reform at the federal level, in short. Our relationship to PBMs and 340B, therefore, is as policy analysts. We also propose ideas for reform. I think that would sum it up appropriately.
Senator Murphy.
Thank you, Madam Chair. So you mentioned the FQHC stuff. In my district, I've got one large hospital that doesn't qualify, so they're not participating at all. Do have an FQHC and a small hospital that do participate, and it's very rural. My district is three full counties, and I do know that the FQHC has been put in a real bind over this, restricting the contracts. And so this sort of thing, and that's really what we're talking about here. We're not really talking about the entire program. We're just talking about the fact that they've restricted the contracts. I think you made the point early on that the whole purpose of this, and I've got your quote here, that is to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Is it doing that?
It depends on the actor. I think FQHCs and other federal grantees are very good actors on this. I know plenty of small and independent and rural hospitals that are also doing their best. It is, again, if it's keeping the doors open of that hospital, I think that would be considered reaching more eligible patients and stretching scarce federal resources. I do think there are many large system abuses of this program, particularly, I think, if you guys are not familiar with the Bon Secours Mercy Health Hospital, they are a health system that bought up Richmond Community Hospital in Virginia. The Richmond Community Hospital was an inner city hospital. It served very poor urban patients. It was barely making, if not constantly underwater on its margins. Its entire mission was that of what you would consider a nonprofit hospital's mission to be, which is serving people at the expense of its own profit line. Now, when they were bought out by Bon Secours Mercy Health, Bon Secours Mercy Health then used its 340B status, the Richmond Community Hospital's 340B status, to then expand into wealthier suburbs. This expansion, and I should say, making money off of the spread of this is entirely legal. It is, in some folks would argue, it is in fact the purpose of this. I'm not accusing folks who are making money off of the spread of doing anything illegal or untoward. This is common behavior. This is how hospitals derive value from that. But what they would do is they would buy up or build outpatient clinics in wealthy Richmond suburbs. This happened simultaneously as they were gutting services from the inner city from the main hospital in the inner city, using that extra revenue to, again, build out in the wealthy suburbs, gain more revenue through wealthier insured patients at the expense of poor indigent patients.
Well,
So those are the abuses that most concern me.
Yeah, that's a nice story, but it's Virginia. We're in
Yes.
Kansas.
Understand, sir.
Okay.
And again, we use that as an example because that's been an example with some of the 340B overuses.
Yes.
And it definitely has overexpanded its boundaries. You were saying that the profits, they're not required to have transparency on the federal level with what they do with the spread. Is that right?
That is correct.
I was told 3 years ago, and Jackson, I appreciate you being here, and I appreciate the studies that Paragon Institute does into the history of this, that they were to supposedly use this money for the community, services in the community initially. Am I right on that?
That is correct. That is understood to be the intent of the program. Because so the quote that I gave earlier on the spreading scarce using scarce federal resources, that was from the congressional report language that was meant to like show, hey, here's our intent of the program. Mm-hmm. It has remained vague enough that some folks will use stretch scarce federal resources, et cetera, to any funds that go to the hospital they consider as fulfilling that resource. Mm-hmm. As fulfilling that goal, excuse me.
And another thing that you said was anybody who, it doesn't have to be an indigent patient. They can make money off of any patient that happens to come to the hospital.
Correct.
If the hospital's considered a 340B hospital.
Yes,
Is that
ma'am.
right? Okay. Yes, Representative Proctor.
Thank you, Madam Chair. So I wanted to go back to something that you said in your previous exchange. You know, whenever we're talking about healthcare policy, most frequently when we're talking about Medicaid expansion, we hear, you know, rural hospitals and small hospitals and, you know, these underserved populations are going to benefit. But I think I just heard you say that like these big health systems, if they buy up those small hospitals, could use this benefit as well.
Oh, yes.
Yeah, so I'm looking at our conferees, and I don't see St. Luke's, I don't see Kansas, you know, University of Kansas Health System on here. Are big hospital networks in Kansas benefiting from this? Because I can't ask any of them because none of them are testifying.
I would be shocked if they were not. If they are nonprofit systems, they would be able to qualify. It would be unusual if they weren't. I can't say I have specific data, again, because the program is very much a black box. I couldn't tell you how much Kansas nonprofit hospitals were making off of the program.
And Madam Chair, if I could, what you talked at length about kind of how this program's expanded many-fold since its inception. What percentage of drugs that are sold here in Kansas would you say are being sold under this 340B program?
And Representative, if I may, and committee, Jackson was here to give us a history. Okay. We'll hear more about specific to Kansas a little bit later, but his purpose was to give a history of the 340B program.
Thank you, Madam Chair.
I appreciate it.
He may happen to know that, but that was not why he was asked to come.
Nationally, it would be 16%-ish. I would not be able to say, or excuse me, 14.7% nationally. I wouldn't be able to say for Kansas specifically, though.
Okay. Thank you, Madam Chair.
Absolutely. Yes, Senator Diedrich.
Thank you, Madam Chair, and thank you for reminding us why he's here. He just has so much knowledge. It's easy to ask him 100 questions. So again, let's just talk about Kansas, even though you may not have Kansas data, but you might be able to extrapolate this. So the phone calls that I receive from our hospital administrators, and these are not huge systems, are that they use any additional dollars that they might be able to recoup through the 340B program to help with the indigent patients that they see in their hospitals. And there are millions and millions of dollars of uncompensated care that our local hospitals provide. I'm just trying to determine whether or not your policy and analysis finds that to be an appropriate use of those dollars or an inappropriate use.
If those dollars are going towards indigent patients and to help pay for that care that for folks who cannot afford to, I would consider that an appropriate use of 340B
Okay.
dollars.
I just want to double check that because it sounded like for a minute that maybe I misheard you, that you were thinking that that is not appropriate.
I would not consider that inappropriate, ma'am.
Thank you. Thank you.
All right, Jackson, thank you. Would you now continue with a synopsis of what we know from what's happening on the federal level?
Okay. There have been, the short version of this, ladies and gentlemen, is that not a lot. 340B reform is constantly stymied. There are a variety of actors who make a lot of money off of this, and they don't like if the program changes because they're used to the way things work. However, at that point, in the House of Representatives, the most recent action was a bill presented by Representative Larry Bouchon of my home state of Indiana. He had proposed a lot of transparency measures, many of which you would find in the Minnesota bill they passed in 2023. That would require hospitals essentially to track how much money they're getting in 340B and what they're spending it on. On the Senate side, some of the action, there's a notable bipartisan 340B committee, or bipartisan working group, I should say, in the U.S. Senate. It's about 6 or 7 different members on it. And then they have proposed their draft legislation, which is not complete per se, but they have proposed kind of broad outlines of it. It's the Sustain 340B Act. This would do a variety of different things. It would limit frankly ban pharmaceutical companies from denying 340B payments to covered entities. It would also require covered entities to be more transparent in how much they're getting in terms of those payments, ideally where that money is going as well. It also would adjust, it seeks to, but has not proposed a definition for the qualifying patient, which is currently extremely vague and broad. I think, what else are we on here? I think that would be probably the 2 biggest pushes. This bill has not been introduced. It is, again, still in a kind of a draft mode. This was as of 2024. I am not aware of any updates to it at the time. The Larry Bouchon bill in the House, as I mentioned earlier, it got a subcommittee vote, which was, and passed out of subcommittee, which was the first time any 340B reform had done that in probably like 10 years. But it died in committee. That would be, I think, really the broad extent of where federal legislation for 340B reform is at. It takes a while to acculturate, particularly when you get new members, what the program is. They're not necessarily familiar with it. It's, again, a bit of a black box, so it's difficult to illustrate some of the problems with where all the money is going. It takes time. I'm sure none of you would be shocked to hear that the federal government is slow at doing things.
Committee, I would refer your attention to the documentation and the testimony that we received from Senator Marshall's office. It has legislation in the Senate that are referring to PBMs. One is Senate Bill 2973. Another is in the Senate Health, Education, Labor, and Pensions Committee, on which Roger Marshall serves, and that's Senate Bill 1339, PBM Reform Act. And then 1542, Delinking Revenue from Unfair Gouging Drug Act. And then there's another, Senate Bill 3330, a bill to require Secretary of Labor to conduct a study on the fiduciary duties of the PBMs. And then we have the Senate Commerce, Science, and Transportation Committee has Senate Bill 127, which is a PBM Transparency Act. Then we have the Senate Judiciary Committee, Senate Bill 527, Prescription Pricing for the People Act. And then legislation on 340B is listed right after that. Sustain 340B Act that was just mentioned. And then in the Health Committee, Senator Cassie's report on 340B reform. And then we also see the CBO report that's come out on the growth of the 340B program. And I believe that's it. So to get more details on what has been presented here, I would refer you to that. And thank you so much, Jackson. Do we have any questions on federal reform? Yes, Representative Ruiz.
Jackson, you've used the word reform several times, but not really defined what that means. What is, when you're looking on the federal side and they're looking at reform, what is that?
It can take several measures depending on what side of the ball you're on. When I talk about 340B reform, though, I am specifically referring to the first step is increasing transparency measures all around. This program is very much a black box. We should know what's going on inside of it. Beyond that, I think broadly, reform needs to address how spread pricing is used. And this is not original to my idea, but other reformers as well agree that generally the problems with this program come from the design and setup of the spread pricing mechanism of how that profit works. If we would like to create, and because this is a de facto hospital subsidy program, if we would like to create a proper hospital subsidy program, we at Paragon believe that while subsidies are distorting of the market, if we are going to give subsidies, they should be given directly and in clear and direct manners. Ultimate reform of the 340B program might look like something of a user fee on pharmaceutical companies. They'll pay in a determined amount every year, and that money will be portioned out depending on the a number of qualifying patients that each covered entity sees. So if you see more poor patients, you'd get more money, for example.
Thank you, Jackson. I would just say, from what I've seen going on in the federal level, the word reform just means change. How could we change the 340B program from what it is today? All different ways that they're looking at potentially doing that. But as you said, I think the greatest problem is the lack of transparency. And any other questions, committee? Yes, Senator Starnes.
Okay. Thank you, Madam Chair. So I'm trying to gather this all together, and it just seems like Big Pharma is wanting to continue to change these rules to increase their profits. Is that correct?
Pharmaceutical companies don't make any money off of this program. They would probably like to spend less on the program, although they themselves will admit this program is not going anywhere, and fighting on trying to abolish this program is not going to happen. What they would most like to do in my discussions with industry, they have said they would like to have a consistent and clear, determined spending amount that they're going to have every year. That would be their ideal. Right now, they really just want clear transparency and to ensure that there are things that aren't happening, like Medicaid duplicate discounts. This goes into, and I can get into this if you guys would like, the latest federal pilot program from the CMS's Innovation Center, which has pretty dramatically changed how payments are done, or at least on a voluntary and temporary one-year basis. We'll see how this goes moving forward. So I'm happy to talk about that if you guys would like.
Yes, I would like for you to address that.
Okay. So they have begun a 340B rebate pilot program. This comes out of the CMS Innovation Center. The Innovation Center has broad waiver authority to do demonstration programs, essentially experiments within Medicare and Medicaid to try and see how can we decrease spending while improving quality at the same time. Part of this, so through this, again, they can make a lot of changes to programs as that affect Medicare and Medicaid. So through the 340B pilot, what they are doing is they are allowing volunteering, so manufacturers can volunteer to set up their own rebate style program. They have to, essentially, the hospital will provide them data on the pharmaceutical drug, and to ensure that it does not interfere, where the Medicare part of this comes in and why CMS is involved, is with the maximum fair price of the recent Medicare drug price negotiations that were instituted in 2022. So to ensure that maximum fair that drugs aren't getting double discounts, they're not the pharmaceutical manufacturer does not give the maximum fair price discount to Medicare, as well as the 340B discount to hospitals. They require hospitals to submit data in this pilot program to the pharmaceutical company, who then provides them the rebate. They have to provide that rebate within 10 days, which is based on the current model that most hospitals pursue when they get reimbursed for 340B, is actually a little bit faster than they would normally get paid their 340B discount. So the goal is to ensure that hospitals are transparent on that they're not getting these double discounts that they're not allowed to have. Simultaneously, that pharma is very quickly getting the money back to the hospitals without delay.
Additional questions, committee? Oh, I'm sorry. Yes, Representative Carpenter.
Thank you, Madam Chair. So would it be fair to say that there is nothing out of the ordinary or nothing illegal about any spending of the profits from 340B program?
There is nothing illegal outside of unless they are getting a duplicate discount in Medicaid or there is drug diversion occurring. Those are the only two things where any spending through 340B would actually be illegal under statute. Otherwise, they can just receive the profits from these 340B discounts, and there's no requirement on what covered entities must do with them.
Exactly. So capital expense, equipment, whatever. There's
Anything.
no guideline whatsoever for the spending of the profit.
Correct, which is how the earlier Virginia hospital example, but hospitals around the country do this, particularly large hospitals. That's how they're able to buy out. They use 340B dollars to then buy out and expand into wealthier areas to then increase their 340B revenue.
Very good. Thank you for that, Jackson.
Yes, sir.
Senator Murphy.
Thank you, Madam Chair. So in this pilot, is the contract arrangement with pharmacies, is that changed or?
The pilot does not change the contract arrangement with pharmacies.
Okay, thanks.
Senator Fagg.
Thank you, Madam Chairman. Jackson, thank you. I was wondering on the 340 benefits, does it cover residents that live in our country illegally?
It would depend on how the hospital spends their money. It doesn't apply directly to those individuals necessarily. The money stream is difficult to root out. I want to be careful with what I'm saying. I don't want to mislead or leave out stuff. So because money is fungible, any of the 340B profits can be spent as the hospital pleases. If they spend that money on patients who are here illegally in the country, then that money would be being spent on folks who are here illegally.
Thank you.
Thank you very much, Jackson. And seeing no further questions, you will be here in case something comes up, and we can call on you.
Thank you, Madam Chair.
And I, again, want to say this is a federal, 340B is a federal program, and PBMs are regulated on a federal level. And now we're going to go next in our presentation will be Dr. Robert, and tell me if I'm pronouncing this correctly, Popovian?
He's not on virtual yet.
Yeah, oh, he's not on virtual yet.
He's not there yet.
He's not there yet. Will you tell me when he's on and we can go to him? Thank you. Then we will go to Dr. Maselli, who is here from Do No Harm, and Stanley Goldfarb from Do No Harm testified to the 340B task force last week, and I asked Dr. Maselli if he could share with us that testimony.
Appreciate it. Chair Gossage, Vice Chair Sutton, and members of the committee, thank you for the opportunity to testify today. My name is Kurt Maselli, and I serve as Medical Director of Do No Harm. Do No Harm is an organization of medical professionals and concerned citizens devoted to keeping divisive and unscientific ideology out of the practice of medicine. Our mission is to defend the timeless standards of medical excellence against divisive political trends that undermine patient trust and health care. Today, I speak to you about the interplay between the 340B drug pricing program and large hospitals in Kansas, particularly as it relates to the fungible nature of dollars supporting diversity, equity, and inclusion initiatives. The 340B program, as we've heard, enables hospitals, clinics, and other healthcare providers in Kansas and other states to purchase outpatient medications at discounted rates. And these hospitals then provide medications to eligible patients, as you've heard earlier. And importantly, these savings go to the hospitals, not to the payers or to others, with the intent that the hospitals use those funds to extend limited healthcare resources to the patients they support. The 340B program is itself a public privilege granted by Congress to safety net hospitals. And nationwide, it started with just a few hospitals in 1992 and now numbers over 2,700 qualifying hospitals. And we've heard just previously how the spending has grown significantly over the past decade. This benefit is not a right, but a conditional arrangement funded by manufacturers' obligation to offer reduced prices in exchange for Medicaid access. Participation comes with the duty and intention to use these savings transparently and support patient care by providing essential care. Yet, instead of focusing on curing disease and prioritizing access to care for all patients, many hospitals are squandering these fungible resources of savings on ideological experiments. They've embraced contentious and counterproductive DEI initiatives, along with its accompanying bureaucracy, to infuse day-to-day operations with ideological goals. Every dollar put into DEI is a dollar not invested in charity care, expanding capacity, or strengthening staffing. This shift undermines hospitals' core mission and is a betrayal of it, diverting time and resources that could be spent on healing and saving lives. Specific to Kansas, the University of Kansas Health System, the largest system in the state, reaches patients across many, many areas. On its website, the health system proudly refers to its culture of equity in healthcare, complete with a prominent reference to the Human Rights Campaign Healthcare Equality Index, a scorecard for measuring hospitals' compliance with various tenets of gender ideology, a political ideology that promotes medical transition of youth with gender dysphoria. This includes HEI training steeped in critical social justice, like decolonizing gender, how mental health care providers can break out of the binary. It also includes requirements for a hospital's electronic health record to capture a patient's anatomical inventory. Additionally, the HEI mandates that healthcare benefits for employees must provide baseline coverage that includes puberty blockers for youth. Summit together, and the University of Kansas Hospital achieved a perfect 100 in 2024, excuse me, obtaining the status of leader. On its website, it notes this intrusion of ideology into healthcare as one of its national accomplishments. Moreover, the University of Kansas Health System has also promoted equity in cancer prevention, labeling disparities between mortality rates in Black and white men and women as a social justice issue. Unfortunately, disparities in healthcare do exist. However, framing them in a manner like this is misleading and counterproductive. It results in attributing disparities to racism and diverts from medicine's mission of healing, and it puts it towards a social justice agenda. This is terribly divisive, and it ignores the fundamental fact that we must improve healthcare for all people. Cancer in particular knows no bounds. It doesn't care about one's race or creed or gender. Spending precious resources on social engineering diverts from medicine's mission of providing quality health care for all. The approach is evident, again, at the University of Kansas in recent years with the naming of associate directors for cancer workforce equity, which aim to diversify cancer research workforce and provide equitable cancer care. It begs the question, should the purpose of cancer research be workforce diversity or treating and curing disease? I'd argue that merit needs to be the driving factor, whereby top talent, regardless of background, is leading the charge against one of humanity's deadliest diseases. Redirecting focus from scientific rigor into ideological representation risks slowing progress, diluting excellence, and ultimately failing patients from all demographics who depend on these breakthroughs for their survival. Identity politics has also impacted the specialty of maternal health, where the hospital system seeks equity for pregnant people. A blog post from a couple years ago noted that while preeclampsia affects 2 to 8% of pregnant people, it is more prevalent in the Black community. The why, the blog continues, gets back to racism. Yet there's no credible evidence.
Can I have a point of clarification, please?
Yes.
I'm trying to understand what this has to do with 340B.
This was the testimony that related to Kansas that was given to the 340B program or the 340B, so I'm sure he will tie it in.
Okay,
Thank you
thank
for the
you.
question.
Reducing the explanation to racism not only creates a false and divisive narrative, but also misapplies resources by ignoring medical issues such as high blood pressure, diabetes, cardiovascular disease, and obesity. And this often leads to training on implicit bias and anti-racism. Within this framework, healthcare professionals are told that their implicit biases are contributing to disparate outcomes, and they're effectively accused of perpetuating racism unconsciously, regardless of intent or evidence. And this is not only true that we've seen in the University of Kansas Health System, but also Stormont Vale Hospital and other hospitals in Kansas. These events offer a place to discuss implicit bias so participants can be aware of the societal and interpersonal impacts. But again, medicine, which relies on rigorous evidence-based analysis of specific conditions and treatments, we see that implicit bias is being treated as a sweeping problem, though unproven, which needs to be addressed through equally sweeping solutions, such as trainings that were previously mentioned. It was popularized by the implicit association test, which claims to reveal unconscious bias by assessing reaction times to paired concepts, with quicker responses in one direction, suggesting a more favorable perception. However, it is unclear that these reaction times are actually measured by the implicit association test, actually demonstrate any reliability or validity. It is these concerns that we see that ultimately are concerned with the fungible nature of the 340B program. All too often, DEI advocates attribute outcomes and disparities to systemic bias and racism, ignoring key medical factors. Their policies emphasize identity over merit and expertise that is essential for delivering top-quality health care. These efforts rest on the false assumption that healthcare professionals are inherently biased and our hospitals are mired in bigotry. I'd argue the contrary. America's doctors and nurses are compassionate, devoted professionals who serve all patients with unwavering commitment. Their tireless efforts during the pandemic are just one example of their deep dedication to care rooted in empathy and integrity. The impact on patients is quite significant when we look at these programs. When healthcare professionals are increasingly told that implicit bias drives disparities and that pairing doctors with patients of the same race improves outcomes, they're looking at evidence that is terribly weak. My organization, Do No Harm, has found that 5 out of 6 systematic reviews, including one on addiction treatment in 2024, showed no benefit in health outcomes based on racial concordance. Promoting this approach risks reviving racial divisions, implying that Black patients should see Black doctors and white patients should see white doctors. That's segregation, and it's not the path to better health care. Dollars directed towards these initiatives are not only wasteful, but harmful. What all patients want is skilled, compassionate treatment, regardless of their provider's race. And likewise, all individuals, all patients, regardless of race, background, or circumstance, have equal worth and deserve the physician's utmost care.
Dr. Maselli, thank you so much. You have, at the end of your testimony, that so you have some understanding through Do No Harm that 340B funds are being used for this purpose?
Well, Senator, I appreciate the question. Thank you. The concern is the fungible nature of the 340B program and where those dollars may go. And as we heard in the previous testimony, it is a black box. And any of the resources that are within the program could be used for many different things. And one thing we do see has been a rapid expansion of DEI initiatives throughout hospitals, again, across the country, not necessarily specific to Kansas, but throughout our nation. And that's where the concern becomes. And I think that also leads to the concern for the need for transparency in programs that allow individuals, that allow legislatures, that allow citizens to see where money is going, what it's being used for. Again, the intent of these programs is a noble one. It's to help people who are in need, and it's important for us to make sure that that intent is followed through.
Thank you very much. Any questions, committee? Yes, Representative Ruiz.
I really take, I am appalled that you're here. You've come to our committees before for the Health and Human Services Committee 2-3 years ago, and many in the committee felt that what you were dictating or what you were saying, there wasn't all truth to it, and we didn't like the fact that someone's coming out of Kansas, coming and talk to us about our Kansas hospitals who are doing fantastic work. And you know, the fact that University of Kansas, and I don't know why you guys are constantly focusing on University of Kansas, but in order for them to get some funding, they have to have demographics. They have to show the poverty levels around. And just because they have that information doesn't mean that they're biased towards it. So I don't understand what all this has to do with the 340 program, and I wish you hadn't been here.
Representative Oropezzo.
I would like to echo my colleague across the way sentiment. And in fact, I wish I could have said it and restate it as eloquently as former House Representative Dr. Epley stated the last time your organization was here in our presence, because he did quite a justifiable job in defending our programs here in the state of Kansas, as well as our medical programs, nursing programs, et cetera. And I wish I had written it down to some extent, I had no idea this is going to be part of it. I too have an issue with that. How does this tie into 340B? And that connection was not made. And two, am appalled at your references and condemnation of our educational here, establishments and hospitals here in the state of Kansas. Thank you, Madam Chair.
Thank you for being here. Yes.
I just wanted to say I appreciate the comments that have been shared. I think that's really important. And likewise, I think there are many good things that hospitals are doing throughout the country. I would just urge, and our organization certainly looks toward, how do we make medicine better? And how do we make healthcare better for all people and to continue to advance it? And so I appreciate the sentiment that was shared, but also would look toward the transparency that can help us continue to deliver exceptional healthcare for all people.
And Do No Harm is an organization of 30,000 doctors. Thank you very much for being here. And we do have Dr. Popovian on virtual. Dr. Popovian, are you with us?
Yes, sir. Can
All right.
everybody hear me? Okay.
Yes, we can hear you. Thank you.
Excellent.
Please continue.
My name is Dr. Robert Popovian. I'm a visiting health policy fellow at the Pioneer Institute. Pioneer Institute has been studying the 340B issue for the last several years. We have a tool online that is available to anyone, and the tool is really populated through the data from HRSA, which is an agency within Health and Human Services, and the RAND Corporation. We have been following every state level data regarding contract pharmacies, charity care by hospitals. We've also been able to geomap and even tell you as state representatives within your district how many contract pharmacies there are, where the locations are, who the contract pharmacies are, and who are the hospitals and clinics that are 340B eligible. So a few things to highlight on the Kansas side. One, PBM ownership. The top 5 contract pharmacies in the state of Kansas operating, that means that they have the most contracts, are PBM owned. They're not independent pharmacies, they're not chain drugstores. These are PBM owned pharmacies that operate in the state of Kansas. Revenue capture. As stated by the report from Minnesota through the transparency, as well as was confirmed by Senator Cassidy through his investigation in the Senate side, the reason that these PBM-owned pharmacies line up and try to be involved in the 340B program is reimbursement. They get paid 16% margins on every drug dispensed in the 340B program. This is 16% of a $1,000 drug or a $100 drug or a $500 drug. This is very different than the $10.52 that they get paid for dispensing a Medicaid or most commercial plan drugs. So that's why these pharmacies are lining up to be part of the 340B program, and specifically the PBMs. Geographic mismatch. Nearly half of the Kansas pharmacies are in affluent neighborhoods. These pharmacies that are within the state of Kansas are not in neighborhoods that are indigent or underserved. We've basically been able to geomap it based on income data from the state of Kansas. Out of state contracting, the top 5 hospitals in the state of Kansas, 61% of their contract pharmacies are outside the state of Kansas. They're not within the state of Kansas, and most of them are PBM contracts that they own. And charity care. Hospitals within the state of Kansas actually do less charity care than the national average. And this is data that's been basically provided to CMS through the hospitals. So this is not some data that was made up or modeled. This is actual data. Future research that we intend to do, and we're going to include it on our tool, is comparison of for-profit versus 340B hospitals regarding Medicaid, provision of Medicaid patients, charity care, as well as whether or not they take care of uninsured patients. So far, the data doesn't look good. 340B hospitals do as much charity care as non-340B for-profit hospitals across the country, and we're going to be able to dive into it based on state-level data. Happy to answer any questions that you may have, but our tool is available for anyone to go in and take a closer look at what's going on in the state of Kansas and across the country.
And I don't see in your testimony, oh, yes, I do. There is the link there. All right,
Yeah.
thank you. Thank you so much. Committee questions. Senator Owens.
Thank you, Madam Chair, and thank you for being here, Doctor. Question, so you're the second person that has referenced the transparency legislation out of Minnesota, and so that seems to be kind of a common theme. With transparency legislation in Kansas, do you believe that is necessary?
I believe that every state should have a similar legislation. By the way, it's not just state of Minnesota. Indiana has passed similar legislation, and state of Massachusetts has it in the docket to be passed. It's going through the system. I believe every state should do that first before they do anything else, because that will provide you an ability to see how much revenue are hospitals bringing in through the 340B program, and how much revenue are they putting out in form of charity care, what type of charity care, as well as the margins that they're paying these contract pharmacies. And one thing to also note, and I forgot to mention, I've reviewed contracts by PBM-owned pharmacies versus independent pharmacies that are, locally owned. The independent pharmacies get nowhere the margins that these PBM-owned pharmacies get. And the reason being is that they have a monopoly or an oligopoly. And it will be important for you all to understand that before you delve into any kind of legislative process.
Very good. Thank you for that. I only mentioned Minnesota because, again, it was specifically mentioned by you and a previous speaker, and I'm glad to know that there are other states. So thank you very much.
You're welcome.
Senator Diedrich.
Thank you, Madam Chair. Thank you for being here. I do have just a couple quick questions, and it really kind of piggybacks on what Senator Owen was asking you about charity care. What do you think or not what you think, you probably have the data. What is the national average on charity care? You say we're below that.
Yeah, it's abysmal. Actually, it's for the 340B hospitals, the charity care percentage of their operating expenses, which is their revenue, is 2% or 2.12%. We have the exact data on our website. And again, I want to reemphasize, this is coming from the RAND Institute, which gets this data from CMS, which is then provided, the CMS gets this data from the hospital. So this is their own hospital data that they're providing. In Kansas, it's lower. The hospitals on average are lower than the national average, actually.
Do you know how much lower? I just don't have access to that data.
I will be happy to send, let me see if I have it. Unfortunately, I don't have it in front of me, but I'm happy to send that to you all.
One more, Madam Chair.
And share it with you. But it's
Thank
in
you.
our tool. You can go take a look at it, and you can take a look at each individual hospital charity cares too.
Oh, thank you. Thank you for that. Also, I have a quick question about the contract pharmacies. You say that in Kansas, it's the geographic mismatch piece that most of our contract pharmacies are located in affluent neighborhoods. So geographically, 57% of all the population in Kansas is located in our 5 largest counties. So do you think it might be a factor of who can support those pharmacies? And that's why
Possibly.
they're located in more populated, possibly affluent areas?
Possibly. There is a reality of pharmacy desert, especially in rural communities and in poor neighborhoods. That is absolutely a possibility. But what it is, the reality is that in Kansas, the contract pharmacies that have the most contracts are PBM owned. They're not even in the state of Kansas. They're operating outside the state.
Okay, thank you.
Yes, Representative Proctor.
Thank you, Madam Chair, and thank you, Dr. Popovian, for being here today. So from the data that you've collected, are you able to tell us how much of the kind of 340B savings is passed through to customers that are getting prescriptions from qualifying facilities versus how much is going back to the hospital? I'd be interested in knowing that number.
Yeah, it's very little. Directly passage of savings to consumers or patients is about 1.4% of the patients who get those savings directly passed on to them. The other 98+ percentage of patients don't get anything passed back on to them directly. This is not our data. This has actually been published by other institutions. We don't have access to that information, and that's why the transparency report is so important, because that will help us to then look into exactly how much are patients getting at the point of sale with regards to the savings that have been sort of garnered by the hospitals.
Madam Chair, could I follow up? So if they're getting 16, if the pharmacy is getting 16% reimbursement on those drugs, then basically 84% of what the consumer is paying is going straight back to the hospital. Is that correct?
And then only about 1.4% of those patients nationally are getting those savings, correct? So, yeah, the problem is really, and the reason that you have so many PBMs and involved in this business model is because of the margins that they're getting paid. They're getting huge reimbursement for dispensing these medicines.
Dr. Maselli, I have a question for you. I know that it's stated in Senator Marshall's report that Senator Cassidy put out a report in the 119th Congress recommending and requiring covered entities to provide detailed annual reporting on how their 340B revenue is being used and ensure direct savings for patients for what you're addressing right now. Do you know of any legislation or any movement on the federal level to require this form of transparency? Oh, did I? Oh, I apologize. Dr. Popovian, I thought maybe your mic was off or you couldn't hear me. And you're thinking, that is not who I am.
Sure, if you were asking
And
me
my
the question.
apologies, Dr. Maselli.
That's-
Yes, so do you know of any movement? I know that there are some states that are moving in this direction. Do you know any movement on the federal level on this federal program to require transparency?
Yes, there's both a House bill that Representatives, excuse my name, Harshberger, who's from Tennessee, who's a pharmacist herself, as well as Buddy Carter, who's from Georgia, who's also a pharmacist, have introduced because they've asked me to look into the legislation. And then there's a Senate version of it that's going through as well, trying to create more transparency. But the other thing that they're trying to do is define who is a patient. And that's one of the things that is very important. And going back to the previous question, is that who's benefiting from this? The biggest problem with the 340B program is that it doesn't have a definition of a patient. It defines an institution. So anytime a patient walks into that institution, whether they're fully insured, Medicare patients or anybody else, the institution can take advantage and get the 340B discount and then go ahead and bill the insurance for a fully reimbursed version of it. So that's another issue, that there is no definition of a patient in the 340B program.
Yes, Senator Owens.
Thank you, Madam Chair, for letting me ask the doctor another question. So, Dr. Popovian, as I'm pulled up your website, pulled up the kind of key points in Kansas one pager that you put out, which is pretty interesting. Maybe I'm not quite following this contract pharmacy. So it says 61% of the 340B contract pharmacies for Kansas hospitals with the most contract pharmacies are out of the state. So first question is, help me understand what a contracting pharmacy is. Apparently there are 222 of them under the University of Kansas. So what is that contractual relationship? Who are those pharmacies? And then I have a question about understanding how the University of Kansas benefits from a contract with a pharmacy in Hawaii, for example, which is listed as an example.
Yeah, that's the biggest question that we always ask institutions, why they have so many contract pharmacies. And this is the biggest thing that will come out, hopefully, if you do a transparency legislation, is to ask these institutions to justify the number of contract pharmacies. A lot of times when you look at it, And that 61% that we state is the top 5 hospitals in the state that have contract pharmacies that are outside the state, right? So those are only for those top 5 hospitals. And nobody understands exactly. We've talked to a lot of CEOs of hospitals, and they blame the contract pharmacies because what happens is that the contract pharmacy, like for example, Express Scripts comes to them and says, look, we have one of your patients that we have coming to our hospital, to our contract pharmacy. You have to sign up with us. But not only that, you have to sign up with all of our affiliates as well. So that's what they end up doing. But there's no good explanation. And the best example I have is in Illinois. If you're familiar with Chicago, there are 2 large hospitals. There's Cook County and Rush Memorial. Cook County is a county facility that takes care of poor, underserved patient population. Rush Memorial is in a very affluent neighborhood. Rush Memorial has over 200 contract pharmacies. Cook County has 1. While they take care of almost the same level of patients, and their revenue model is almost identical. Rush Memorial makes more money, but it's not significantly more. Same thing applies to other states. I can name you in California and New York State. So it is an unknown why certain hospitals need to have so many contract pharmacies while other hospitals can manage the same level of patient population with very limited number. And when we've talked to the CEOs of these hospitals, they blame the contract pharmacy model that they basically come in and ask for it. And if you look at it, the hospital is really paying the contract pharmacy for dispensing of these drugs. The contract pharmacy and the hospital have the contract between them. And it's not the state or the federal government or anybody else. So it's an unknown. And that's why one of the questions that we always ask is that why do you have so many contract pharmacies? And we have no idea.
If I may, again, I'm just trying to wrap my head around this. So University of Kansas, let's say hypothetically, has a contract pharmacy, let's call it Honolulu Pharmacy, for example. They have some kind of contractual relationship because there's a patient in Hawaii that is a University of Kansas patient, and they go to that pharmacy to get their prescription filled, and then that is done at a discount that then goes back to the University of Kansas? Am I understanding that correctly?
That is pretty much it. Yeah,
Oh.
and that is correct. What you're thinking through is correct, and that's when we ask them, can you tell us who that patient is? And by the way, this Hawaii pharmacy is infamous. They have contracts with almost every large institution in the country. So it's an unknown why there's so many hospitals that contract with this pharmacy in Honolulu. And you're correct. It's supposedly that's the theory, right? But it's an unknown.
Okay.
Exactly.
Thank you for helping me understand that.
Before I go to the next question, initially, when 340B was created, Dr. Popovian, isn't it true that they were allowed 1 contract pharmacy, and now it is expanded to, it could be hundreds? Is that correct?
That is 100% correct. And the problem with the 340B program started with the Affordable Care Act, frankly. Because what the Affordable Care Act did is 2 things. Number one, they removed the cap of 1 contract pharmacy. They said you can have as many contract pharmacies as you please. And if you look at our data, there's an inflection point that happens in 2011 where you see this contract pharmacies just explode over time after 2011. The second thing that the Affordable Care Act did is to redefine who can be a 340B covered entity as a hospital. Initially, the covered entity had to be a disproportionate share hospital. That means they had to basically admit certain percentage of Medicaid patients to qualify. The Affordable Care Act redefined that, and it included several other definitions into what qualifies you as a 340B entity. So both the covered entity numbers and the contract pharmacy numbers disproportionately started increasing after the passage of the Affordable Care Act. And you see that very clearly in the data.
Thank you, Senator Murphy. Senator Fagg.
Thank you, Madam Chairman. Doctor, thank you for your presentation. This kind of falls back to the question of actually how much reaches the consumer, which Representative Proctor asked. Is there any way that you know what percentage is taken up by the middlemen, such as a PBM?
I think it's about 16% on average. 16, depends on, the Minnesota report says 16%, the Senator Cassidy's report says 13%, so you can say between 13 and 16%. And that's extremely high for dispensing of a medicine. Just to put it in context, Kansas Medicaid reimburses pharmacies for dispensing a medicine a $10 dispensing fee. If they dispense a $1,000 340B drug, they're making about $160, about 15 times more.
Senator Murphy.
Thank you, Chair. Thank you, Doctor. When I've talked to pharmacists and all like that, they all say they get the 1050. I haven't talked to a single one that got more. And when you talk about the 1.6%, I believe it was for what is reaching the people, does that include, say, when a hospital, say, takes care of indigent pregnant women, or maybe build a wing that adds service or keeps an FQHC open? Does your figures take that into account?
So that's a great question though you ask, because this is only for overall, right? The 1.4% of patients that directly benefit from 340B. It doesn't include the FQHCs, or it may include FQHCs and everybody else. Now, I want to make sure I put this out there. FQHCs and the clinics have a lot of requirements with regards to how much money they take in and how much money they put back into the community. Hospitals don't have that requirement. And in fact, I believe that FQHCs are the good guys here, and they should be protected. The hospitals are the problem. The hospitals really take in a lot of revenue. Nobody knows how much. And we at Pioneer, we've tried to FOIA this information from HRSA, and their response to us was that the hospitals, we have the data, but the hospitals refuse to share that with you. So I think they have to be forced of how much revenue they take in and how much revenue they put out, and specifically what they're putting it out for with regards to charity care. Again, I can emphasize this more, even strongly. Clinics are not the problem here. The clinics, the FQHCs do a great job. They take care of our indigent patients, and they need to be protected. And they take the revenue in, and there are federal requirements of how much revenue they have to put back into the community. Such requirements do not exist on the hospitals.
Okay, and if I may, one more quick one. Are there some prescriptions that cannot be had just at any old pharmacy?
Certain prescriptions, like specialty medicines, that they have to be shipped, but this is where I was talking about, like certain hospitals, large hospitals, manage to take care of their patients, even though they see diverse patient population, through a very limited number of contract pharmacies, while others have to have hundreds of them. And it just doesn't make sense, and they cannot explain why they have that. The other thing, the $10 dispensing fee that you mentioned, you're absolutely correct, because you're probably talking to this the dispensing fee that the independent pharmacies get, even through the 340B program. They don't have the leverage to have the contracts that the PBMs can negotiate with these hospitals. Therefore, that's why you see the discrepancy in this dispensing fee.
Okay, thank you.
Representative Sutton.
Thank you, Madam Chair. Doctor, you mentioned the Minnesota study about the reimbursement rate of 16%. In preparation for this hearing, I was trying to find out the various reimbursement rates, particularly amongst 340B, but also looking more broadly across the industry, and I wasn't able to come up with that. In your testimony, and I don't have it in front of me, do you have the link to that Minnesota study? I would love to review that data, because 16% seems a little bit outside of what I was seeing, even though what I had was not very specific. And so I'd love to get more specific information.
So the Minnesota report, I'm happy to share the link. I didn't put it in my testimony, but the link is available. And Minnesota is supposed to release their second report within the next few weeks or days. It's coming out, and actually expanded it because one of the things that Minnesota didn't do with regards to the revenue generation was they were only looking at hospital administered drugs and not the infusion drugs that happen in their clinics and everything else with regards to the hospitals. So they are collecting that data as well in the second report. So they've expanded it. So the revenue model is going to be significantly higher. And the 16% is stated as payment to what they call a middleman. Okay, it's not specifically to contract pharmacies, but that's the only middleman there is, right, with regards to dispensing. I would also encourage you to take a look at Senator Cassidy's report that specifically looks at contract pharmacy, this reimbursement.
Now, as far as, if I could continue, as far as a middleman is concerned, would a group purchasing organization or a PSAO all qualify as a middleman, perhaps?
You know, if you look at overall data, even in the PBM models that have been created, you're absolutely correct. Middleman has a large definition. They can be wholesalers, they can be pharmacies, they can be physician offices, they can be hospitals, all these things, right? But generally speaking, when you look at middleman, let's say for every dollar a pharma company sells today in the marketplace, 50 cents goes to the pharma company and the other 50 cents goes to the middleman, what we call middleman in the supply chain. The supply chain benefit of that 50 cents, about 90% of it goes to the PBMs or insurers. The other 10% is dispersed between wholesalers, pharmacies, so on and so forth. But you're absolutely right. The definition can be. So that's why I think that going between 13 and 16% of what Senator Cassidy says and what the Minnesota report is where the reimbursement for contract pharmacies ends up.
Okay, so middleman's a little bit vague, and it could be almost anything. And could you also go into when you were talking about your percentages there? I got a total of 125%. So I think I missed something somewhere.
Which one are you talking about?
When you're talking about where the revenue goes from dispensed medication, from pharma to end user, you said 50, 50, 10, and 15 or something?
No. So if you look at the national data, right now in the United States, every time a pharma company on average, and these are all averages, I want to make sure you understand that. On average, if I'm a pharma company and I sell a drug that is priced at $1, out of that $1, I get 50 cents back in revenue. The other 50 cents from that medicine sale, the price, goes to somebody in the what we refer to as middleman or supply chain. And that supply chain is made up of wholesalers, physicians, pharmacies, all these other entities, hospitals, insurers, and PBMs. Out of that 50 cents, what I was trying to say is that 90% of that 50 cents that goes to the middleman or the supply chain ends up in the insurer or the PBMs. And so
I would love to find the data on that because that doesn't match anything that I've seen.
I'm happy to share the reports that are out there, and it's very much agreed upon that supply chain, the supply chain or the middleman. Think about it. We spend about $770 billion annually on drugs. About $350 billion goes back into the middle, goes back as concessions back, whether it's to rebates, fees, anything. So that's a very well-known data that's been captured over the last several years. And that number has been growing.
Excellent. I look forward to looking at that data.
If you could, please, you said you have a link to that. If you could send the link to the, and it was the, I think Minnesota was what you were referring to?
Minnesota,
yes. The Minnesota study. And then also, if you wouldn't mind following up, if that comes out in a few weeks, and sending that to committee as well.
Absolutely, happy to. And I can also, I can also send a link about what percentage of patients actually benefit directly. That's been studied, and that's important also because that was a question that was asked.
Yes, thank you so much. And Representative Ruiz.
Thank you so much for your testimony and answering so many questions here. Have the pharmacies, do the pharmacy companies agree to any kind of program changes to gain access in order to sell more medications?
I'm not clear exactly what you mean. Are you,
If I may, Representative Ruiz, I think when you're saying pharmaceutical, are you talking about pharmaceutical manufacturers? Are you talking about pharmacists? Are you talking about PBMs, pharmaceutical benefit managers, in your question?
It would be the contract pharmacies.
Contract
yeah.
pharmacies, thank you.
yeah.
Pharma
So
company.
your question is whether or not contract pharmacies agree to be a contract pharmacy to gain access to patients?
Or they'll agree to any kind of changes in order to continue to access.
Well, it depends on the contract pharmacy. I think contract pharmacies that are independent pharmacies, frankly, that are there are contract pharmacies that are independent pharmacies. They will probably want to keep the model as it is, want to change it. Now, the majority of these contract pharmacies are PBM owned, and their revenue model will be significantly impacted if you start like capping their reimbursement fee, for example. My suggestion to most of the states is that if you want to really fix the problem, reimburse contract pharmacies for dispensing a 340B drug the same level you reimburse a Medicaid drug in your state. So cap it at $10 instead of a percentage. And you will quickly see that a lot of pharmacies will drop out as contract pharmacies, and you won't see the Honolulu pharmacy phenomenon and all these like 200 contract pharmacies for Kansas and everything else, because right now the incentive is, and that's why they're lining up to be contract pharmacies, is because it's very lucrative.
And the second question was, the whole piece about the charity care. And what, is there a definition that you've seen of what qualifies as charity care?
That's another problem we have in this model. Nobody has defined what is charity care, so it depends on the hospital that reports it. That's why initially we were thinking of, going to, for example, hospitals and trying to get their charity care individually. But we decided against that, and we went to the RAND Institute, RAND Corporation. They take the charity care that's been reported by the hospitals to CMS, and then they clean it up, and we take it from them and publish it in our website. So that's a great question, though. There is no definition of charity care, and that's another problem with this whole thing, is that a lot of times hospitals can define charity care as bad debt or doing like a flyer or something to raise awareness or even advertising. And that's not charity care in the reality. And we need to have better definitions of charity care in the United States as well.
Okay, thank you.
And I think, and if I understand correctly, some of the reforms that they're working on with the 340B task force is defining what is charity care.
That is correct.
Senator Diedrich.
Thank you, Madam Chair. Thank you so much for being here and answering so many of our questions. It's been very helpful. So I just have a quick question about CMS. You've used their data to answer many of our questions, and which is fine. I'm just wondering, does that mean then that you have a high degree of confidence in CMS data?
But this is why we're using it, because it's the data that the hospitals furnish CMS, right? So I don't want to be blamed by hospitals to say, you're making up data. I'm just basically saying, look, this is the data you gave to CMS. So if your charity care percentage, for example, is much higher than what is, then you're providing that to CMS. Don't come and blame me for putting that number out there publicly. And that's why we're doing it. It's not because I believe or have 100% confidence in the CMS data. And then the other thing that we're doing is that we're using RAND as the buffer, because they take the CMS data and they clean it up. And then what I didn't share with you is that they ask hundreds of questions in addition, RAND does, that we have access to that data from the hospitals. So they try to clean it up as much as they can. But at the end of the day, the reason we rely on the CMS data, because I don't want to be blamed by the hospitals to say, well, my charity care is 6% and you put in 2%. my thing is, that's what you reported, this is what I'm putting in there.
Fair enough. Thank you.
Committee, I also would refer you to the PDF of the testimony that was given by Dr. Popovian. There is a link there, and if you click on the link, there is a state report. And so when you click on that state report, you'll see one specific to Kansas, 340B in Kansas. It has key points, it has charge graphs, et cetera. It's a one-pager. And again, taken from CMS data. Any other questions? Yes. Senator Starnes.
Thank you, Madam Chair, and thank you, Doctor. I'm referring back to the geographic information that you had regarding disparities. And I'm concerned about our local pharmacist as well as, and I'd heard the same thing that Senator Murphy heard on the $10 amount as far as local pharmacies. And concerned then, how do you suggest we meet the needs of affordable and reliable pharmaceuticals being distributed in rural areas? Because they want to keep things local, they want to help things stay local, and these disparities are very concerning. So your thoughts on that, please.
You're asking a great question, and I agree with you. I think that there needs to be this differentiation in reimbursement to keep independent pharmacies whole and healthy and in their communities, because that's how they're going to help patients. That's up to you all to determine what that level is, but I do think that there needs to be a differentiation in reimbursement. What I will also say is that because of this discrepancy in reimbursement of PBM-owned pharmacies, and this was highlighted in the FTC reports that came out last year, the two FTC reports, as the PBMs grow stronger and their specialty, especially their specialty pharmacy business and their dispensing business gets stronger, what they end up doing is they end up buying out these independent pharmacies or running them out of business, actually. And that's what the FTC says. So there's two things you can do. Number one, I believe that you need to probably have a differentiation in reimbursement in rural community hospitals and also pharmacies to keep them whole and keep them healthy. At the same time, you need to prohibit from these PBM-owned pharmacies from making a 16% or 13% or 10% or much higher percentage dispensing fee, because as they get richer, they buy out these independent pharmacies, and these independent pharmacies go out of business. And this was highlighted very clearly in the FTC report that came out.
Senator Owens.
Thank you, Madam Chair, and you're just a wealth of knowledge, Dr. Popovian. So again, thank you for being here, and thank you for continuing to answer our questions. So looking at this from the drug manufacturer standpoint, do drug manufacturers see this as a loss of revenue to them? I mean, it seems like some of what we're talking about is an angle for them to try to make more of that 50%. Are you seeing data that suggests that in amongst your studies?
So this is the thing with the drug manufacturers. I have to put all my cards on the table. I think that the 340 program is an essential program that needs to stay, needs to be protected. A lot of times, a lot of institutions rely on the 340B. I was part of one of the institutions, the county hospital in Los Angeles, that desperately needed, because 99% of our patients were uninsured that walked through the door. The problem is that it's gotten out of hand. And the reason it's gotten out of hand, partially because somebody asked a question, I can't remember who, but it was the Affordable Care Act that sort of put it in this trajectory of getting it out of hand. The pharma companies don't have a problem participating in the 340B program, and I believe that they should participate and they should contribute to it, as long as that revenue is actually going back to the community and to the patients. And in addition, that there's transparency of how much revenue is being brought in and how much money is being put out. The other important thing to note here is, as the 340B program has grown exponentially, This has also created an environment where the hospitals get richer and they start buying out independent practices. And this is where you see that the reduction in independent practices, whether it's the physicians or the specialists like oncologists and so on and so forth, because they create more revenue for these hospitals to buy them out. And at the end of the day, what happens is that then you reduce access for patients because you have less independent physicians practicing in rural communities or in local communities, and also specialists like oncologists.
So you see in part what changed in the ACA empowering the consolidation of 340B related entities to the detriment of local communities and lower income citizens. Is that a fair statement?
No doubt about it. If you look at the data that we have on our site, ACA was the inflection point. ACA did two things that I mentioned. It removed the cap on number of contract pharmacies, and then it redefined what hospitals can be 340B programs. That started the number of hospitals participating in the program, and then it also increased that level. So it did two things. Number one, it empowered more PBMs and retail chain drugstores to get involved. And as they got richer, they start buying out these independent or forcing these independent pharmacies out of business. And the same thing happened on the hospital side. As they got richer through this 340B program, they start buying out independent practices and specialty practices, and they start driving out physicians out of business.
All right. Thank you very much. Again.
Dr. Dr. Popovian, thank you so much for being here. And it's time for us to move to our next presentation. And Brooklyn was planning to be with us. Her flight was delayed and then basically canceled last night, so she is going to be virtually. And Brooklyn, are you on WebEx with us? She is. Brooklyn Roberts is the Senior Director of Health and Human Services Task Force with the American Legislative Exchange Council. She is going to be sharing with us, some of the questions that were asked of Dr. Popovian were regarding what have other states done, and she's going to address that with what's going on in other states, what they've done, and what they're considering doing. Brooklyn, thank you for being with us. I'm sorry you couldn't make it in person.
I'm sorry too. And thank you, Chairman Gossage and members of committee. Thank you for the invitation to be here today. I am here today testifying on behalf of the American Legislative Exchange Council. The American Legislative Exchange Council is America's largest nonprofit, nonpartisan organization of state lawmakers dedicated to the principles of limited government, free markets, and federalism to offer nonpartisan research and analysis. So today I'm going to talk about one of the largest federal programs that most Americans have never even heard of, but that impacts all of us at 340B and its impacts on states, taxpayers, and the American healthcare system. The federal 340B program, as you know, was created with a straightforward mission to provide steeply discounted drugs to safety net hospitals and clinics that serve large populations of uninsured and low-income patients. The purpose of the program was to fix an unintended consequence of the Medicaid best price statute, which had led to an increase in drug prices for many safety net providers. Unfortunately, despite noble intentions, the program has, as you've heard today, exploded into a money grab for hospitals, pharmacies, and pharmacy benefit managers, encompassing up to $66.3 billion in prescription drug sales now. I have written and discussed the 340B program and the need for reform often over the last few years. And in talking with state legislators, there are a few common misconceptions that I'd like to address first today. The biggest and most common myth is that 340B program doesn't cost taxpayers any money. And I'd like to talk a little bit about the ways that this program increases the cost of prescription drugs to states, employers, and taxpayers. First, the 340B program encourages the consolidation of healthcare providers, which reduces competition and drives up costs overall. Consolidation in the healthcare industry has exploded, especially among providers. Hospital systems' acquisition of independent physician practices has become a common practice over the last 30 years, and the vast majority of academic research shows that it's led to higher prices for patients. This type of vertical integration gives providers more leverage in negotiations, encourages them to charge additional fees, for example, facility fees, and can bring the child facility under the umbrella of the 340B covered entity, allowing them to purchase and profit from 340B drugs. According to a newly released report from the Congressional Budget Office, the 340B program is one of several factors that incentivizes the integration of hospitals and off-site clinics. Second, research has showed us that 340B covered entities are more likely to prescribe more expensive drugs and have higher price markups on prescription drugs. In addition to consolidation, the Congressional Budget Office report found that the 340B program is driving up costs for the federal budget by incentivizing clinicians to prescribe more drugs and higher cost drugs. A study in the New England Journal of Medicine found that price markups at the 340B covered entities were more than 6 times higher than those at independent physician practices. And a report from the North Carolina State Treasurer found that 340B hospitals in that state billed the state employee health plan an average markup of 5.4 times their acquisition costs on oncology drugs. And that's 84.8% higher than the average markup among non-340B hospitals. The 340B program incentivizes hospitals and other providers to favor higher cost drugs, and this kind of perverse incentive structure drives up overall spending on prescription drugs. Reductions or eliminations of common discounts on 340B drugs result in increased costs for taxpayers and states. As you know, governments, employers, and payers lose common rebates and discounts on 340B drugs. Pharmacy benefit managers, insurance companies, Medicare, and Medicaid typically negotiate rebates with drug manufacturers on the list price of prescription drugs. 340B drugs are often excluded from rebates because they're already sold to the provider at a steeply discounted price. Most contracts prevent double dipping when it comes to discounts. So as a result of this, lost rebates, employers, patients are paying higher prices for drugs. A 2024 IQVIA study showed that drug costs for self-insured employers and their workers were 4.2% higher than they otherwise would have been without the 340B program. So I say all this to say that there's a lot of misinformation surrounding the 340B program and who's actually bearing the costs. I've talked with a lot of state legislators about the ways the 340B program is actually costing taxpayers, employers, and states money. In recent years, state legislators have come under a great deal of pressure, as you probably know, to support the expansion of the 340B program. And there's been a lot of well-intentioned but misguided legislation on this program. Primarily, these involve mandates to force prescription drug manufacturers to sell drugs at 340B prices to contract pharmacies. And we've seen 30 mandate just in 2024, or 2025 actually, sorry. There were at least 30 340B mandate bills across the country. So ALEC Action, which is the 501c4 sister organization to ALEC, has opposed this type of legislation. First and foremost, the 340B program is a federal program, and we believe that any mandates requiring the sale of 340B drugs to contract pharmacies should come from Congress. As you've already heard today, I'm sure the term contract pharmacies is not part of the legislation that was created, the 340B program. And essentially, state mandate legislation is expanding the 340B program past the legislative parameters, the federal legislation that created it. So we have opposed these types of mandate bills across the country. However, we do believe that there is room for state action on 340B, and the role for states in this really comes with bringing more transparency and accountability to the program. This year, Indiana passed legislation, and it required more transparency and accountability for the 340B covered entities. So Indiana's SB 118 requires 340B covered entities in Indiana to submit data about its participation in the program to the state, including but not limited to the aggregate acquisition cost for all prescription drugs obtained under the 340B program, the aggregate payment amount received for all drugs obtained under the program, the aggregate payment made to pharmacies under the contract to dispense drugs obtained under the 340B program, and perhaps most importantly, how the 340B program, how the 340B covered entity uses any savings from participating in the 340B program, including the amount of savings used for the provision of charity care, community benefits, or similar programs providing unreimbursed or subsidized care. So as I mentioned, the 340B program now accounts for $66.3 billion in prescription drug sales across the country. And the problem is there's little to no transparency or accountability as to how much facilities earn and how that money is actually being spent. Legislation like Indiana's SB 118 gives states and taxpayers insight into the amount of revenue derived from the program and the amount of revenue contract pharmacies receive from the program, and perhaps most importantly, how that revenue is spent. So I will close with something that I recently read in the New York Times. It kind of drives home the program and how detrimental it can actually be to patients. The New York Times article tells the story of a cancer patient who went to a 340B hospital in New York for treatment. The list price of the drug that she was given was $2,700. The hospital charged that this patient had private insurance. It charged that patient's insurance company $22,700 for the drug. In the end, that patient was left with a $2,500 hospital bill. That was more than half of her monthly take-home pay. So sadly, this kind of story is all too common across the country, and a lot of what we're seeing with this program. So with common sense federal reforms and more transparency brought from the states, 340B could be a great program again, and one that would support our safety net hospitals and help them really stretch already strained budgets. But as it stands, it's exploded far past its intended parameters and is all too often abused, and taxpayers and states are bearing the costs. So I wanted to thank you guys again for the invitation to testify today, and I'm happy to answer any questions.
Thank you, Brooklyn. Were you listening to our earlier presenter regarding Minnesota?
Yes, I caught part of Dr. Popovian's.
Okay, are you familiar with that legislation? And I'm wondering how that is different than the Indiana legislation, if at all.
I'm not familiar with the Minnesota legislation. I can tell you that the Indiana legislation goes beyond any in terms of transparency and accountability. It goes far past any other legislation that I'm aware of.
And my concern and what I've heard is that in talking to our federal legislators, oftentimes, as you mentioned, we have people that come to our office and they have great appeals and they say, but I know I get that, but we need you to do something. The worry is doing something could interfere what the federal government is already doing and or needs to do, in that 340B is a federal program. Could you address that?
Repeat that again. Can you?
Yes.
There was trouble with the audio. Listen, sorry.
That's all right. I'll talk a little slower. So if the fear is that if something is done on the state level, it can interfere with what they're trying to do on the federal level because it's already done in a particular state in a different way.
I mean, I think our position is that really reform ideally would come from the federal level. That's where it's a federal program, and that's where reform should come. I think states, have been asked by various stakeholders in this to act. And if states are going to act, then I think that the best way that they can take action and do something is to find out where the money comes from and where, or how much money is actually being earned and where that money is going, and whether it's actually benefiting taxpayers and patients in that state. But I think federal legislation obviously would preclude any state action.
Representative Carpenter.
Thank you, Madam Chair. So are you familiar with this Indiana legislation? Who managed this information, or who was responsible for this information in that bill? Do you know?
It was a special committee, I believe, that was formed in the legislation.
But I mean, how did the bill, who was responsible for collecting this information and compiling it, I think, in that state? Was it the Department of Health and Environment, or?
It's the Department of Health, yes.
Okay, very good. Thank you.
Senator Owens.
Thank you, Madam Chair, and Brooklyn, thank you for that information. So just two questions. First, do you believe, as we've heard from at least one other presenter, that this consolidation issue was increased due to the ACA being passed under the Obama administration?
I do. I think 340B is one of the largest drivers of it, but yes, I mean, I believe that the ACA in various ways has encouraged that consolidation.
Okay. And the next question. So I totally agree with the idea of transparency and data collection. When we have all of the information, we can make better laws without question. But I think in my mind, it has to be more than just the hospitals. Do you know any of these, the states that have passed this transparency legislation that are able to garner any data or force the hand of PBMs and or pharmaceutical companies to provide data on 340B as well?
Indiana is really the only, in terms of 340B, Indiana is only the only legislation that I'm really familiar with, and that does not target, it targets primarily hospitals that are participating in the program. But I think that transparency in terms of PBMs is a very needed reform.
Okay, well, thank you for that, because I agree. You've got to have the entire picture. Thank you.
Representative Reese.
Hi, thank you for your presentation. I'm really concerned about our rural clinics and rural hospitals, of course. And in your testimony, you talk about hospital systems, acquisition of individual physician practice as has become a common practice over the last 30 years, and the vast majority of academic research shows it leads to higher prices for patients. Is there any thoughts about that maybe some of these acquisitions are because we lack physicians in our rural areas, and that hospitals are actually able to, when they do an acquisition, they're actually saving the practice, and then they're continuing to provide services in those communities, and without that, they wouldn't have anything?
I think that there are a lot of factors that are driving the vertical integration and the acquisition of these practices. It is not solely 340B, but I think that 340B is one of perhaps the largest drivers of that kind of type of integration. In terms of rural clinics, I mean, I can't speak to what's, in terms of physician shortages in rural clinics. That's not something I can speak to.
So do you have data for Kansas that shows that this practice of hospitals acquisition some of the physician practices, that it's not due to the 340B, or it is due to the 340B?
The data that I have is nationwide and not specific to Kansas.
Okay, so it's kind of misleading then. If you don't, I mean, this statement alone just is a bit misleading because we don't have data to really show that how this is happening in Kansas. And for my knowledge of what's going on in Kansas, it's saving some of these practices because we can't have, we don't have physicians going out there, and especially they're not accepting Medicaid. So that's part of the ACA piece there too. So, second question. So my second question is, I have been seeing, this is more has to do with the PBMs. I've been seeing advertising on TV. They're quite clever advertising about trying to explain to the general public what a PBM is. And have you seen those? And I'm just kind of wondering, I'm assuming the pharmaceutical companies are behind it. And I'm wondering about how much, that advertising is compared to the pricing, the 340B pricing discounts that are passed along to the 340B entities.
And Representative, she can answer that question. However, I think that question might be better asked for some of our afternoon folks.
Okay.
That will be that were directly from those organizations.
Okay, thank you.
Did you have an answer, Brooklyn?
I mean, I think that's best asked of the pharmaceutical companies or PBMs. I'm not an expert on their advertising practices.
Senator Diedrich.
Thank you, Madam Chair. And my question actually kind of mirrors what Representative Ruiz had asked, because I represent a county that's a medical desert that has no doctors, pharmacies, clinics, eye doctors, dentists. So my concern when I read that statement that that you felt that we were harming our taxpayers by allowing or encouraging or, in some way enticing hospitals to expand and offer clinics and physicians greater opportunity to provide their services to our communities that have no medical professionals. That was quite concerning to me because I don't know how else we could do it if we don't allow expansion into, and I don't serve on public health and welfare. Do you know, Madam Chair, and I'm not meaning to put you on the spot, you just might know this. Do you know how many counties in Kansas out of the 105 have no physicians or clinics or, like my county, Wabunsee County, is a medical desert. Do you know how many are like that? I don't really know that.
I think that would be a good question to ask our afternoon speakers.
Okay. So that really is my concern. I mean, I just don't know how that is harming our taxpayers when we are providing the opportunity for additional services to, again, remember, 57% of the population in Kansas lives in 5 counties. So I just think we're doing a disservice to our rural counties, even though a county 30 miles from us and we're the 5th largest county, Shawnee, where we are right now, is, a medical desert. So, but it is rural. So I guess that's my concern. I just want to make sure that in looking at this data that we're not drawing the wrong conclusions. So thank you for all your information. It was very beneficial.
Just to clarify, I'm not saying that vertical integration is bad. I do think that there is data that shows that it is leading to higher costs for patients, and largely because that's in some ways, and not in rural areas, but in some places that is reducing the amount of providers and reducing competition in those areas. But my position is not to say that vertical integration is bad, but to say that 340B is driving vertical integration in a way that is, causing harm to the 340B program.
Thank you for that. I think my point, and you just said it, is that we are driving out competition, which raises costs. You don't drive out competition when there is no competition. I mean, there is absolutely no services provided in many of those counties. So that kind of was my point. Thank you, though.
And in my own personal experience, if I may, Senator, is that, and we'll hear some testimony this afternoon, when a hospital is going to open in a particular area, they don't necessarily have to be affiliated with one of the large hospital associations. And the doctors that I've spoken with, and some of you may have your own experiences, but doctors that have gotten out or retired early because their only way to stay open because of reimbursements. And that's typically from Medicaid, Medicare, and quite frankly, the 340B program, that they were being paid less, and the only way for them to survive might be to go under a hospital. And the way our system works now is that for the same procedure, for the same medical code, a hospital or a clinic, primarily a hospital, can be paid more for that same code than they would for that a doctor could order for that same code. And they are given a facility fee on top of that. So the thinking was, if you come into our facility, and again, someone can address this afternoon, come in under our umbrella, we're going to pay you the same amount that you would have received before, hey, maybe even a little bit more, because we're going to get paid more for you to do this procedure. And therefore, hey, it benefits both of us. And so there are some doctors that have already gotten out early. Whether that was partially because of 340B, I cannot answer. Any other questions, committee? Thank you so much, Brooklyn, and sorry about your flight situation. I know that's happened to you again early. And we appreciate you. And next we will go to Trent England. And Trent, are you with us? Thank you for being here. Trent is the founder and executive director of Save Our States.
Thank you, Madam Chairman, members of the committee. It's a pleasure to be here. Good morning. It's, thankfully, this is somewhere I can drive to, which makes it even more of a pleasure. Before I start my testimony, I think I should say, just in light of some of the conversation, while I'm going to be critical of the 340B program, I'm not against subsidizing, supporting rural health care, rural health providers, right? That's an important issue. I think that the purpose of my testimony and really my position here is that we shouldn't be forced into a false choice. That if we want to support these important providers, we have to embrace 340B. So that's sort of my gloss, I guess, on what I'm about to say. I am Trent England. I'm the executive director and founder of Save Our States. I think I've interacted with some of you before because we work on some election issues. I created Save Our States originally to defend the Electoral College against the National Popular Vote Interstate Compact, and we've gradually expanded with a focus on state policies that are important to our federal structure or get after the interplay between state and federal governments. Obviously, this is one of those kind of issues. The most basic fact about the 340B drug price fixing program is that it is a big government anti-free market policy that was created by a liberal Congress and shaped into its current form by the Obama-Biden administration. Today, 340B functions as a subsidy for big and often woke hospital systems. It funds consolidation where hospital systems buy up smaller providers, and it subsidizes the woke agenda, and I'm going to demonstrate that in a moment. Conservatives are asked to support all of this in exchange for much smaller revenue benefits for rural providers. Thankfully, the Trump administration is not a cheap date. Neither, it appears, are conservatives in the U.S. Senate. President Trump is pushing forward with 340B reforms while the Senate is investigating the program. Ultimately, 340B is federal law augmented with federal regulations, and I think state legislators should not rush to codify protections or signal support for a broken federal program. As we've heard, in the early 1990s, Congress created 340B as a subsidy for a small group of sympathetic healthcare providers. Those covered entities can purchase outpatient drugs at deep discounts. They were not required to pass that savings along to patients. And as an aside, if we step back and think about healthcare in the early 1990s and think about who these clinics were treating, right? I think it's hard to prove this, but my intuition as I've read about the history of this program is that a lot of these patients were not going to be paying their bills, right? And so the clinics providing these drugs or the hospitals providing these drugs were, you know, they had a cost. They had to buy the drugs. They were going to pass them on to patients. They weren't going to be paid, right? This is part of charity care. And so the government's stepping in and saying, well, drug manufacturers, we want you to sell these at a lower cost so the hospitals lose less money. That all changes when you have the majority of these patients covered by some kind of health insurance, right? All of the sudden, and I'm going to get to some evidence in here that shows how this works, a medical provider can make a lot of money if you have insurance paying the full freight for these drugs, right? And so instead of the program preventing hospitals and clinics from losing money, all of a sudden it becomes a cash cow. The Obama administration, as has been described already, changed all this, expanding 340B to include major hospital systems and allowing covered entities to use an unlimited number of contract pharmacies. The Pioneer Institute, which testified already, well, I'll just skip over their data. You've heard their data already. The massive growth of this government program comes at a cost. Actually, it imposes a variety of costs on patients, employers, and taxpayers. Just to summarize, there's some evidence that 340B increases the use of covered drugs. That makes sense. If certain drugs yield windfall profits, it creates an incentive to prescribe those drugs versus other drugs or to prescribe those drugs versus non-drug treatments. It also displaces normal drug rebates, which can directly raise the price for patients or their insurers, imposing a cost on employers, including on the state self-insured plan. The estimate that I've seen for Kansas is that this imposes a cost in the private marketplace of about $55 million and to the state self-insured plan of about $14 million. But 340B also subsidizes the woke agenda. The windfall profits from 340B have become a subsidy for woke medicine and woke advocacy. This includes Planned Parenthood, which is a 340B beneficiary. The far-left Reach Healthcare Foundation, which lobbies in Kansas for, quote, abortion rights, reproductive health, and gender-affirming care, close quote, supports 340B and has indicated support earlier this year for Senate Bill 284. Some hospitals and clinics are explicit about how 340B subsidizes their programs. And I have several quotes here. We'll come back to Kansas, but as you might imagine, healthcare providers in blue states brag about this. They don't brag about it in Oklahoma. They don't brag about it in Kansas. They don't want anyone to know, but they do want people to know in other states so we can find the evidence from those places. A sexual health clinic in Pennsylvania explains it this way, quote, if you're a patient with health insurance and you purchase your medications at a participating Walgreens pharmacy, you'll be helping us obtain discount pricing thanks to a federal government program known as 340B. The price difference offered by the 340B program goes directly to our healthcare provider, our healthcare center. A similar clinic in New York on its website lobbying against 340B reform credits the program with subsidizing transgender services. Quote, loss of even a portion of 340B savings would adversely and disproportionately affect our LGBTQ plus populations. Our transgender population would also be severely impacted. Our transgender care program has grown 89% since 2018, which seems to imply that they're crediting that growth to the 340B revenues. A clinic offering sex change services in Illinois explains that 340B subsidizes drugs for illegal aliens. Quote, the 340B program helps our patients, regardless of immigration or insurance status, obtain medications at low cost. If you have insurance and you use our 340B pharmacies, you will see no difference in your payments, but every dollar you spend goes to help someone in need. Kansas 340B facilities also engage in woke medicine, including the University of Kansas Health System, which is, I mean, again, it's hard to get all the data, but appears to be, as far as I can tell, the largest beneficiary of 340B in Kansas. It's certainly one of the largest, if not the largest. And their website makes clear, quote, the University of Kansas Health System in Kansas City offers a multidisciplinary approach to gender-affirming medicine, also known as transgender medicine. We aim to assist people who identify as transgender, transsexual, gender variant, gender nonconforming, and gender questioning. Close quote. Of course, Kansas providers will never connect the dots between 340B profits and woke medicine. The design of the 340B program places no limits on how these funds are used, nor does it require any transparency. Nevertheless, windfall profits flowing into woke institutions will always subsidize the woke agenda. The 340B program, to conclude, is broken. The Obama administration expanded it beyond its original intent, turning it into a subsidy where the biggest hospital systems reap windfall profits. While the program was designed to hide the cost, there is no free lunch. Patients, employers, and taxpayers all pay more because of 340B. Meanwhile, the program has become a subsidy for the worst kinds of activism in medicine. Big hospital systems are desperate to preserve the Obama-Biden status quo. They want conservatives in the U.S. Senate to stop asking questions. They want to shut down the Trump administration's reforms. To do this, they hope that red state legislatures will embrace the existing 340B program. The best way to do that is to focus not on the windfall profits of big hospitals, but on the much, much smaller benefits derived by rural providers. And as I said at the beginning, rural providers who have a real case and who have real needs, right, there are things that I think we need to do in states, again, like Oklahoma where I live and in Kansas, but I don't think that they include embracing 340B. The first rule of medicine is supposed to be to do no harm, and it's a good rule for public policy. Embracing 340B in its current form is a mistake. If rural health facilities need help, then help them, but helping rural medicine need not come at the cost of helping big, woke hospitals even more. Glad to take any questions.
Thank you for being here, Trent. Any questions? Yes, Representative Proctor.
So thank you, sir, for your testimony, Madam Chair. So can you expand, because this kind of gets back to the first question I asked today. This is supposed to be for small rural hospitals that are struggling to stay open. How is it that University of Kansas Health System ends up the largest beneficiary in the state for 340B?
So, yeah, that's right. I mean, initially this was created for disproportionate share hospitals and clinics, right? These FHCQs. And that's the way it worked until Obamacare. The Obama administration added some other categories of hospitals that can participate. I don't know which category University of Kansas falls into, but that's where you start seeing all of these giant hospital systems. You know, I know in Ohio, Cleveland Clinic participates as a rural healthcare provider because they do have facilities right in rural areas, and so they get into the program that way. And then once they're in, they're in. So yeah, that's, you know, as Pioneer Institute testified, and I do encourage you to look at their data, you just see this inflection point when Obamacare takes effect where all of a sudden all these hospitals, you know, are able to join the program.
Madam Chair, if I could follow up, do you have any data on how big this program is in Kansas and what percentage of the total 340B benefits is going to the University of Kansas Health System?
I don't have that data, and I don't know. There's really good data on Cleveland Clinic because they're one of the providers that the Senate investigated, and so they put all that together. I've looked around trying to find exactly that. I can't find any public data that shows that, and I think that one of the things that the Cassidy report identifies and that other folks have mentioned is there's no obligation to report that. And so, yeah, I don't think there's any place you could just go and find that. You may be able to ask, you know, I suspect that you all could ask them for those numbers and they would probably provide them to you.
Last one, I promise, Madam Chair. So if they're the biggest beneficiary in the state for 340B, why would they not want to come in and talk to us about the program? I mean, why are we only hearing from small hospitals and small clinics and small pharmacies?
So, and I should say, I'm assuming they're the biggest because we know they're one of the biggest providers in Kansas, and they have by far the most contract pharmacies. So, you know, if I was designing their lobbying strategy in the state of Kansas, right, I would tell the University of Kansas, who puts on their website what I just read, not to send a representative, right, because they would probably be asked questions about what I just read. And I would design that lobbying strategy to bring in rural providers from y'all's districts who have, again, a sympathetic case to make, right, a case that I personally am sympathetic to, and have them present that argument and sort of say, hey, look, we don't, you know, if you're in rural Kansas, you're probably not doing any of those things I just read about, to their great credit. The problem is when you look at, if you get all that data for Kansas and you look at who benefits the most, none of them are going to be at the top of that list, right? The top of that list is going to be people who do the kinds of things that I just read about. And I just don't think we should be forced into a false choice of, helping them a lot more so that we can help some people who really need it.
Additional questions, committee? Senator Owens.
Thank you, Madam Chair. Trent, so a lot of interesting information in there. A couple of quick questions. Do you support the complete elimination of the 340B program?
So, no, I think that what you've heard already is right? I suspect I'm not the only one here who, looking back at the history, would never have done it that way, right? But prudence is an important principle. And I think that it would be imprudent today to just pull this program away, right? What we need transparency, we need more controls. Hopefully we can drive it back towards its original scope. And, maybe at some point we'll actually, shift the way healthcare works so that we have more competition and more rural providers, lower barriers to entry, and all these things that we know would make it a better marketplace. But no, I mean, as things stand today, it is a program that needs to go on existing for the sake of some of these smaller providers. We just have got to, we've got to fix what the Obama administration has done.
Okay, well, thank you for clarifying that. Thank you, Madam Chair.
Representative Ruiz.
I thought I heard you a minute ago say that you don't really know very much about the University of Kansas.
I mean, I know I know what I've read. I know what I've researched. Yeah.
What do you know?
What do I know about the University of Kansas?
Yes.
I know it's a major university in Kansas with a major health system in Kansas. If you could be more specific, I'd be glad to try to answer your question.
Do you know where it's located?
Yeah, I know it's located between here and Kansas City. Yeah.
Okay. So it's in the primary hospital system is in Wyandotte County, one of the poorest counties in the state. And they have a lot of locations, as you've already said, and primarily to low-income areas or rural hospitals or rural communities that lack health care. So they may look like they are a gigantic hospital system because of the number of locations, but without talking about the people that they serve, and as you call them, a woke hospital, this woke hospital has saved thousands of lives and has provided millions, not even thousands, millions of care that is uncompensated. And part of it is because the federal government has been able to provide funds for them to be able to serve some of the most poorest communities. And they're not just communities of people of color. We're talking about rural areas that people of color are not in the predominant there. The 340B absolutely is a life-saving program for them. I just kind of wonder what your real goal is here by making your presentation.
Well, I would agree with much of what you said about the University of Kansas and other similar medical systems. It's why it's such a tragedy that they have been co-opted by this absurd woke agenda that's so harmful to so many people. It would be wonderful if they would focus on their core medical agenda and serving people in need. So I think we agree, perhaps on some of that.
And I would
totally
just
agree with what you just said.
Representative Ruiz, the hospitals will be speaking later this afternoon. Do we have any other questions? Yes, Senator Murphy.
Thank you, Madam Chair. It seems like we've kind of maybe wandered off of the real core question here, I think, in a lot of ways. Ultimately, what we've got is we've got a federal program that everybody's agreed to, whether they like it or not. And one side of it has just decided to change the rules. In other words, they've pulled back. In other words, the contract pharmacy has been a thing that's been going on for quite a while. Since what, 2010? Correct?
Yeah, 2011. Yeah, 2011.
Right, 2010, 2011. So what we've got here is we've got people who've arbitrarily just said we're just not going to play by those rules anymore. And is that their place to do? Or whose responsibility is that?
Senator Murphy, could you clarify the question? I mean, up here, we're like, who's changing what rules?
Well, the pharmaceutical companies are the ones who are pulling back, saying, well, we're not going to honor contract pharmacies when they had been.
So again, this is a federal program, and we could reach out to our federal legislators about them not honoring their the 340B contract, I would assume.
Well, the federal courts have spoken and said it's our responsibility.
We'll talk about that.
Okay.
Thank you.
I mean, if I may,
Yes.
Madam Chair, I mean, there is litigation on that question of what, and you've seen various manufacturers say, we're concerned about how this program works and whether there's fraud in 340B. I think one of the pieces that gets overlooked and that I think should be talked about in that regard, at least, is that the way accountability is designed into 340B based on the federal regulations is that it is outsourced to the manufacturers. And if you look, I actually printed it out because I just find this helpful, interesting as regards some of these state bills. If you go to the HRSA website and you look at the 340B administrative dispute process that's created by the federal regs, for a manufacturer to file a complaint, they have to do their own investigation first. And if they don't do that, then their complaint isn't to be considered, right? So all of this has been outsourced to manufacturers. And, I'm not here representing manufacturers. They'll talk later. I don't even know what they have to say about this. I've just read the federal regs on my own. I've read all these state bills. And if you have state legislation that says that manufacturers can't ask for documentation from PBMs, pharmacies, whatever, or PBMs can't collect this information on behalf of manufacturers when the manufacturers want it. If you break that, it's easy to characterize that as these manufacturers are kind of going out and being mean, and I'm certainly not saying they're not serving their own interests. But the federal government has told them the only way we get accountability in this program is if you go out and do that. And so if a state steps in and says, you can't do that, if you discriminate against these covered entities by asking for documentation when they purchase through this program, we're going to treat that as insurance fraud. What you're saying is, we're going to shut down the only accountability mechanism that's in the CFRs for 340B. So I just think we have to be careful about that, right? I'm not particularly sympathetic to drug manufacturers, although you can understand their concern in a program like this, right? We can understand the incentives for double discounts, for applying, for sort of, applying this program maybe where it doesn't belong if you're making windfall profits off of it. But I think, even setting their interests aside, we've got to be very careful that we don't short circuit the way that the accountability is designed into the program right now.
And also, if I could, Senator, the pharmacist will be speaking later this afternoon, and maybe they could address that, give us a better understanding. Thank you. Thank you very much.
Thank you.
And next, we're going to move to Eric Turek from the Kansas Department of Insurance.
Good morning, Madam Chair, members of the committee. Eric Turek from the Kansas Department of Insurance. I am the Director of Government Affairs. Pleased to speak with you regarding the implementation of the Pharmacy Benefit Manager Licensure Act. The Department of Insurance is responsible for effectuating the act, and since 2023, all pharmacy benefit managers in Kansas have been required to be licensed with the department. But before, and you have my written testimony, won't be reading from that directly. But before I talk about the current law, I'd like to speak to what came before that. That was the Pharmacy Benefit Manager Registration Act. In 2006, Kansas enacted that act, and it required that all PBMs register with the Department of Insurance. The application process outlined in that act required two things. It was a $140 application fee, along with some general contact and business information about the PBM. And all renewals, or all of the registrations were valid for 1 year, and the renewal period outlined in the act was or the renewal date was March 31. During the 2022 legislative session, I know a few of you on this committee were here at the time, there were parties that came together and proposed what was considered a compromise bill. That was the Pharmacy Benefit Manager Licensure Act. I do want to be clear that the department was not involved in those negotiations, and the department was not consulted on the language. But nonetheless, the department has still carried out the letter of the law. At the bottom of the first page of my testimony, you'll see, again, what the law requires. It requires the department to license PBMs. The $140 application fee was increased to $2,500. Am I good? Oh, never mind. The $140 application fee was increased to $2,500. The general contact and business information was still required, along with a template contract between a PBM and a pharmacy. And also a dispute resolution has to be included in that, along with a network adequacy report. The department, shortly after the enactment, the department promulgated regulations concerning the network adequacy report. That's KAR 40-1-54 that outlines the requirements for the report. The entire licensure process is on our website if any of you want to view that. All of the information that's required for the initial licensure is also required for the renewal. And currently, you'll see on the second page, there are 53 PBMs licensed in the state of Kansas. You'll see before that there were 53, 41, and then when PBMs were required to be registered. As many of you know, the department accepts complaints from the public on a number of entities that we regulate. We do accept complaints on pharmacy benefit managers. Since 2023, so over a 2.5-year period, almost 3-year period, we have received 209 total complaints regarding pharmacy benefit managers. I will say, I'm surprised none of the conferees have previously talked about this. Perhaps the future conferees will after me. But I know that a lot of the issues concerning pharmacy benefit manager practices, like spread pricing, patient steering, some other examples I'm sure some other folks will get into, those are the crux of the complaints that we receive. And the Act as written does not speak to any of those issues. We are, the Act does not speak to those issues, and that's really all I'll say about that. In 2023, and shortly after the enactment of the Licensure Act, it came to the department's attention that there was a specific section that we deem a loophole. It's Section D of KSA 40-3821. It basically says that if you are a pharmacy benefit manager and you are also a registered third-party administrator, the Licensure Act does not apply to you. And we introduced 2 bills during the 2023 session in an attempt to repeal that section. Those did not receive hearings. I will say that the department does believe that this was a remnant from the Pharmacy Benefit Manager Registration Act. This section was present in the 2006 language. Again, we believe that section may have existed at one point for expediency of, or I guess, the section really existed probably just to avoid redundancy. Back in 2006, again, the only information that was submitted to the department by the law was just the basic contact information and the business information. That was relatively in parallel with third-party administrators at the time. Third-party administrators are now licensed by the department except a very small section of third-party administrators who are registered. That reference statute has changed drastically, and so we would ask if the legislature chooses to advance on PBM legislation, we would ask that that loophole be closed. In closing, I'll just say that the department continues to effectuate the Pharmacy Benefit Manager Licensure Act. We're happy to provide information whenever needed.
Thank you very much for being here, Eric. And just to clarify, explain the loophole again.
Sure. So in KSA 40-3821, Section D, it states that if you are a PBM and you are also a third-party a third-party administrator who is registered with the department, the act does not apply to, the PBM is not required to comply with the act.
And you're saying that that is a loophole, and you want it to where if they are both, they are still subject to complying and being licensed as a PBM?
You know, at one time, there were similarities between registration of the two entities, but now, you know, there are new requirements under the Act that third-party administrators do not have to submit to the department, like, PBMs are very specialized, and we would like to see that eliminated.
Okay. And any questions, committee? Yes. Representative Carp.
Thank you, Mr. Chair. Madam Chair. Eric, thank you for being here. So do you have a copy of the contract?
Representative, there are template contracts that are submitted with the application to the department. I don't have any of those template contracts with me. What I can do is that, and I wouldn't be able to give an actual template contract. What I can do is I can go back to the department and ask for a redacted version of a template contract.
And that's what I mean.
Yeah.
Just a copy of a blank
I can
contract.
talk to them about
And
it
then,
anyway, yeah.
Madam Chair, can I? So how many folks have changed to TPAs versus PBMs over this period of time, taking advantage of the loophole?
Well, you know, we have, I think we have over 400 TPAs in Kansas. The grand majority of them are licensed. Some of them are registered. You know, it's unclear to the department who exactly would or falls under this this loophole. At least one at the moment. Back when we introduced this legislation, at least two.
A couple have avoided
licensure completely.
Licensure completely by becoming a TPA.
Yes.
Okay.
Or by virtue that they are a TPA.
All right. Thank you very much for that clarification.
Representative Ruiz.
I'm not clear what a third-party administrator is.
Sure. So a third-party administrator, a third-party administrator is one who carries out the benefits for an insurance contract. So as state employees, we belong to the state employee health plan, although the third-party administrator is the company that is on your insurance card. They're the ones who carry out the benefits. A pharmacy benefit manager is more specialized than that. They carry out they administer the pharmacy benefits along with a couple other duties, like establishing networks, formularies, things like that.
That's okay. Maybe I can help. So let's say that you are self-insured and we'll use the state of Kansas as an example. Typically what they will do is they will hire a third-party administrator, and they are the ones who will get the insurance company you're going to work with. Maybe they'll go out and they'll shop various insurance companies. There's also reinsurance that insures insurance companies. Then they would have a PBM that they would hire. So the TPA is the one that it may say Blue Cross on your card, but that's not necessarily the third-party administrator that's overseeing the project. And you typically see a TPA, a third-party administrator, for self-funded plans. And so one could be a PBM and a TPA, but he said that, you know, of the 53, there are only 2 that have filed for both. They are under different rules of what they have to do and what they're allowed to do. Does that help? Okay. You bet.
Madam Chair, I want to clarify.
Yeah.
Not that there are 2 that are both.
Oh.
Well, I guess
I misunderstood.
There are PBMs who are also TPAs, and there's no issue with that. But there are some, because there are fully licensed TPAs, there are also registered TPAs. But for those who are also registered TPAs, it's just 2 that, or I'm sorry, it's just 1 that is avoiding licensure. It's potentially others.
As a PBM.
Yes.
Okay, it's a TPA that is also a PBM, but they're avoiding licensure.
Because of the loophole.
Because of the loophole.
Right.
And we know of 1.
Right,
at
the
this
moment.
Point. At the moment.
Yeah.
All right, thank you. Other questions, committee? Oh, I'm sorry. Yes, Senator Owens, you told me, and then I just immediately forgot.
That's quite all right. It's all the TPMs, PBMs, ABCs, and XYZs have got us all confused. Eric, so as it relates to this, it seems like while we have a licensure act, we don't have a tremendous amount of oversight authority over a PBM. One of the questions that I have is if they're required to provide a template, is there any oversight to ensure they're actually utilizing that template and their contracts actually match the template that's provided?
That's a great question. I think if we received a complaint concerning that's a great question. Could you repeat that one more time? I'm sorry.
Yeah, absolutely. So that's all right. More acronyms. So one of the because it seems like the PBMs don't have a tremendous amount of oversight, right? We license them, but beyond that, we're not really watching them closely. We have a lot of laws regulating them, right? But they are required to provide you with a template contract, a copy or a template of what what contract they're utilizing with the local pharmacies. My question is, first, does the insurance department actually compare actual contracts utilized to the template contract provided? And then based on what your reaction was, I don't see how a pharmacy could ever file a complaint if they don't have access to the template to see whether it's the same as the contract.
That's a great question. Two great questions. Number one, does the department compare the template contract with the actual contract? I'll say that the statute does not speak to that, and it does not, I'm not aware of the mechanism in statute that would allow the department to do that. Concerning complaints filed with the department and the ability, I guess, for the pharmacy to compare, I'd have to talk with our team to see how that would work. I've reviewed a number of the complaints that we've received. I don't believe that has come up. I'd be happy to talk with you about that more.
Well, I appreciate it, because what's the purpose of getting a template if we're doing nothing with it other than filing it, right? My assumption is we're receiving that template to ensure that the contracts they're offering are in compliance with what little state law we actually do have. But if there's no oversight and pharmacies don't have access to the template and we don't have access to the actual contracts, then really receiving a template serves zero purpose. So thank you, and we'll talk more about that.
You mentioned 200 and some complaints and how really do not fall under the purview of the department. Could you state again what the bulk of those complaints were?
Sure, and I'm confident that a lot of the conferees after me will speak to these in more detail.
Yes.
But the Pharmacy Benefit Manager Licensure Act, again, I want to be very clear, this was not the language proposed by the department. It does not speak, I'm sorry, so the complaints are relative to a lot of the issue. When you investigate issues concerning PBMs, they tend to be regarding reimbursement rates, patient steering, spread price. I mean, there is a laundry list. I think that the conferees after me are better suited to speak about those issues in general, but the complaints that we receive are about those, and the Licensure Act does not.
So we know what the department is not overseeing as part of their regulation. Can you tell us what they do oversee as part of regulation?
Sure, absolutely. We ensure that the information that is submitted to us follows the Licensure Act as outlined in statute. The network adequacy report, we do ensure network adequacy. If I have a sample, I have the form with me that the PBMs must complete. If any of you want the copy, again, it's also on our website. That's the prime crux of the regulation.
And by network adequacy, you mean making sure that they have enough pharmacists within their PBM?
And there's a separate statute within that network, yes. And there's a KSA 4607. That's the and those thereafter. Those are the statutes that pertain to network adequacy. We do ensure that their networks are adequate, and so in layman's terms, it ensures that patients do not have to travel onerous distances to pharmacies.
Okay. And the rest of the oversight is federal, correct? Because we don't have regulation on the state level through the Department of Insurance, but somebody oversees the PBMs, and that would be federal. We'll hear about that. You're right. We'll
Sure.
hear
Well,
about it.
and I know that there has been some legislation introduced at the federal level to govern or regulate PBMs regarding Medicare Part D. But I think that some other minds might be able to shed more light on that.
Thank you so much, and we do have some other questions. Senator Fagg.
Thank you, Madam Chairman. Eric, thank you for your presentation. I kind of wanted to go back to a little bit of basics. Can you give me what your definition of a PBM is? And then the second part of this, is there any way to define a PBM which gets maximum benefit to local hospitals and pharmacists?
Thank you, Madam Chair. KSA 40-3822 defines pharmacy benefit, but what it defines pharmacy benefit manager and what it is not. Some individuals have called pharmacy benefit managers middlemen. I won't speak to that. I'm sorry, your second question was pertaining to hospitals?
Is there any way to define a PBM which gives maximum benefit to local hospitals and pharmacists?
I think that those are substantive discussions that the legislature should have.
Okay. Thank you very much. That was a good answer. Huh?
Representative Sutton.
Thank you, Madam Chair. I'm pretty sure I heard you say Department of Insurance a little bit ago, by the way. I'll correct you on that one this time.
You can.
No, Eric, wanted to follow up. You said that you summarized kind of what the complaints that you've received are. Is the department able to investigate those at all to see if they do match up with the contractual obligation or if something has gone astray?
So I want to rephrase your question. And so you're asking if with complaints that are alleging certain practices that are not spoken to in statute, you're asking if the department can go to a regulated entity and ask for information about a non-statutory violation?
Not necessarily. One thing that you could check out, though, and actually what I'm asking is, can you check out to make sure that the offending agency or company is meeting their contractual obligation with the aggrieved party?
Can you give me an example of a contractual obligation that's being violated? I'm...
Okay, I'm a pharmacist. I'm complaining about the PBM and saying that they didn't reimburse me at the right rate or something along those lines. And the question is, can you look at it and see if that's accurate, if that meets their contractual obligation?
It really depends. Again, statute doesn't speak to what you're referencing. What I can say too is when we have received complaints concerning reimbursement rates,
do you investigate them?
We do communicate with the company or to the PBM, and we do receive a response. Typically, it is either this falls with outside of the department's jurisdiction, or this involves an ERISA health plan, which doesn't, which falls under the jurisdiction of the USDOL.
Gotcha.
Yeah.
Okay, very good. Thank you.
And for those in the audience that aren't aware, we just recently changed the name at their request to Kansas Department of Insurance. So if somebody slips and says Kansas Insurance Department, that could happen. And do we have any additional questions, committee? Thank you so much for being with us, Eric. Now we're going to move to Michael, and I will say we're running a little bit ahead of time. So if any of our afternoon folks are here and would like to speak, please let us know, or let Gary, can you raise your hand? Oh, I don't think he heard me. Okay, maybe let Elizabeth know. If you could let us know if you would like to go this morning, or this morning instead of the afternoon. I'll just say, is there a raise of hands of somebody who would like to go this morning rather than this afternoon? Not seeing any. Okay, then we will move that to this afternoon. Mike, sorry, thank you for your patience, for that bit of housekeeping. Please proceed.
Okay. Good morning, Madam Chair, members of the committee. My name is Mike Michael. I am with the Department of Administration and the Deputy Director for the State Employee Health Plan. Here today to kind of give a broad overview of our medical plan and our pharmacy program for the state employees enrolled in the State Employee Health Plan. So we'll jump to slide 2 that's titled Plan Highlights. And so the medical coverage for active state employees is administered by Aetna and Blue Cross Blue Shield of Kansas, offering 4 plan options. By offering both Aetna and Blue Cross and Blue Shield of Kansas, members have a choice of provider networks, and both have national networks. All medical plans include prescription drug coverage through CVS Caremark. Both Aetna and Blue Cross and Blue Shield offer the same comprehensive benefits for all the medical plans. The member cost share varies for the deductible, coinsurance, copays, and annual out-of-pocket maximums, depending on the plan the member elects. The member cost share for network medical services and their prescription drug benefit combine to reach the out-of-pocket maximum on each plan. All medical plans in full or designated preventive care services received from a network provider. Next slide, please. So this slide shows a broad overview of Plan A of the deductible, coinsurance, and the out-of-pocket maximum. And Plan A is a traditional preferred provider organization plan, and PPO plans have a network of participating medical providers and hospitals which are preferred and have lower member cost sharing. The member will pay less if they use providers that belong to the plan's network. However, members have access to use non-network doctors, hospitals, and providers, but will have additional costs. Member cost sharing includes the deductible, coinsurance, and office visit copays until the member's out-of-pocket maximum is met. Then the plan will pay for covered services at 100% of the allowed charge. Prescription drugs are not subject to the plan deductible, but do have coinsurance, which will be shown on the next slide. And the network and non-network deductibles, coinsurance, and out-of-pocket max accumulate separately. So this slide shows the Plan A pharmacy benefit design. And so members on Plan A, they have first dollar coverage, so no deductible for prescription drugs subject to the appropriate coinsurance tier for the drug they've purchased. The plan's preferred drug list is posted on the State Employee Health Plan and the Caremark website. Coinsurance amounts paid by the member apply to the overall network out-of-pocket maximum. Once the overall out-of-pocket maximum has met, the plan pays covered drugs at 100% of the allowed charge. Plan A is the only plan that offers enhanced benefits for diabetes and asthma medications with coinsurance caps on the member's out-of-pocket expense. Medical costs share on claims from network providers and pharmacy costs all accumulate toward the member meeting their out-of-pocket maximum network. Members on Plan A who use specialty medications may use the Prudent RX program to obtain these specialty medications at no cost to the member. And there's a slide regarding this program a little later in the presentation. Our next slide is on Plan J, and the same layout with the deductible, coinsurance, and out-of-pocket max. So Plan J meets all federal requirements for employees in this country on a J-1 visa, and it's also available to all state employee health plan members to elect. Members are responsible for the allowed charges for any covered services until the deductible is met. Once the deductible is met, the member will pay coinsurance until the out-of-pocket maximum is met. After the member meets the out-of-pocket maximum, the plan pays for covered services at 100% of the allowed charge for the remainder of the plan year. The member's cost share from the medical claims and pharmacy costs accumulate towards meeting the network out-of-pocket maximum. Members' cost share from the network and non-network deductibles, coinsurance, and out-of-pocket maximums accumulate separately. This slide shows the Plan J pharmacy benefit. So members on Plan J are responsible for 100% of the allowed charge for prescription drugs until the deductible has been met. Once the deductible has been met, members pay coinsurance for their prescription drugs until the annual network out-of-pocket maximum is met. The coinsurance depends on the coverage tier for the drug received, as shown in the chart. Medical costs share on claims from network providers and pharmacy costs all accumulate toward meeting the member's network out-of-pocket maximum. After the out-of-pocket maximum is met, the plan pays for covered drugs at 100% of the allowed charge for the remainder of the plan year. Members on Plan J who use specialty medications will be able to use the Prudent program to obtain these specialty medications at no out-of-pocket cost to the member. Next slide is on Plan C and Plan N. So Plan C and Plan N, they're qualified high deductible health plans, which means they meet federal requirements for a health savings account. The health plan offers a health savings account and a health reimbursement account, and the monthly premium is typically lower with these plans, but the member pays more of the health care costs before the plan shares costs with the member. For covered services, members are responsible for the cost of care until the deductible is met, except for designated preventive care services when received from a network provider. The deductible for members enrolled with single coverage is $2,750. For all other levels of coverage, employee plus spouse, employee plus family, and employee plus children, the first deductible will be $3,400. The other covered members would need to meet a combined deductible of $2,100 to reach the total annual family deductible of $5,500. Once the deductible is met, members are responsible for the coinsurance amounts until the out-of-pocket maximum is met. Once the out-of-pocket maximum is met, the plan pays for covered services at 100% of the allowed charge for the remainder of the plan year. On Plan C and N, the network and non-network deductibles, coinsurance, and out-of-pocket maximums accumulate separately. This slide shows the Plan C and Plan N pharmacy benefit design. So for prescription drug coverage, members on Plan C and N are responsible for 100% of the prescription allowed charge until the deductible has been met. After the deductible is met, members pay coinsurance until the annual network out-of-pocket maximum is met. And the coinsurance applies depends on the coverage tier for the drug received, again as shown in the chart. Medical cost share on claims from network providers and pharmacy costs all accumulate towards meeting the member's network out-of-pocket maximum. Once the out-of-pocket maximum is met, the plan pays for covered drugs at 100% of the allowed charge for the remainder of the plan year. Members on Plan C and Plan N using specialty medications can utilize the Proven Rx program to receive these drugs at no cost after they meet their deductible. Our next slide is the prescription benefit. So the cost of the pharmacy program is included in the medical plan rates. The preferred drug list is the same for all plans. Member responsibility varies depending on the plan selected. The preferred drug list is posted on the health plan website, or members can set up an account at caremark.com and see the preferred drug list and other tools, including the check drug cost tool, to determine coverage and cost under the plan. Regardless of which plan is elected, the prescription cost will be lower if a member uses a generic or preferred brand name drug. There is an optional home delivery for prescription drugs available through CVS Caremark. Benefits are the same as when a member uses a retail pharmacy. Specialty and biotech drugs are available exclusively through the CVS Caremark Specialty Pharmacy, and Caremark has a specialty pharmacy located in Lenexa, Kansas. The Caremark Specialty Pharmacy will coordinate patient care with the provider and arrange for medication delivery. And then our last slide is on that Prudent Rx specialty medication program. And that's available only for specialty medications, and participation in the program is voluntary. So Caremark partners with the Prudent Rx to save the plan and members money on specialty medications through the voluntary program that utilizes manufacturers' non-need-based copay assistance programs to pay part of the cost of the medication. A member's advocate from Prudent Rx assists the member in enrolling into available manufacturers' copay assistance programs. Plan A members will benefit by receiving their specialty medications at no cost all year, since the copay assistance program pays on their behalf. Plan C, J, and N members will benefit by receiving their specialty medications at no cost after they meet their deductible. As Plan C and N are qualified high deductible health plans, members must meet their deductible first, since they have the health savings account or health reimbursement account options. Plan J has a health reimbursement account and follows the same design. If a member chooses to opt out of the program, then the 30% coinsurance will apply for the member's prescription drugs. And with that, I will stand for any
Mike, thank
questions.
you so much for that thorough understanding. It's an honor to serve as a commissioner on the employee plan for the state of Kansas. My specific question was, we have heard that when we have a 340B program, that the employer plans, the private employer plans, the group employer plans, and this being probably the largest employer plan in the state of Kansas, could be affected by that. Do we have any reason to believe, or is there any way to determine if the rates are higher in an employer plan because of 340B reimbursements being lower?
I would need to take that away and get some information for the committee to make a determination.
Thank you so much. I would appreciate that.
Sure.
Thank you. Any questions, committee? Seeing none? Yes. Yes. Yes, Senator Diedrich.
Thank you, Madam Chair. I needed some thinking time. So do you get many complaints about the ability to access someone, your prescriptions, or any issues with the 340B program, with the PBMs, is there anything that comes to mind that?
In the 340B program, I'd have to go back and take a look. As with any of the programs with as many members as the State Employee Health Plan serves, there's always someone that, may have an issue that we will look into them to see what's going on for them. But specifically to the 340B,
right. May I ask, is it 80,000 plus?
Yes, it's 80,000 plus members.
Members?
Yes.
Okay, thank you.
So we have thank you so much.
Sure.
For coming to committee, and appreciate you getting back to us on that.
All right, appreciate it.
I've asked if Andrew Weens could come, because as we're talking about employers, like for you to address the employers and how they could be affected by the PBM's 340B, anything that you could share with us.
Yeah, thank you, Madam Chair, members of the committee. My name is Andrew Weens, and I'm testifying today on behalf of Kansas Employers for Affordable Health Care. I appreciate the opportunity to testify on employer-sponsored health care cost as it relates to PBMs. And before I start, I just want to say that our organization doesn't have an opinion on or a position on the 340B issue. So much to your chagrin, I'm sure I don't intend to address that issue, but we'll talk about PBMs largely. So just want to start off by talking about kind of the state of employer-sponsored healthcare. According to the last couple of CEO surveys that the Kansas Chamber put out, and I think it's maybe 300 or so Kansas CEOs that responded to those, managing healthcare costs was cited as the second and third most important factor for business profitability. So Kansas business CEOs see that as a big issue in growing their businesses. And then you probably saw a couple weeks ago, a recent Wall Street Journal article talked about U.S. businesses facing the biggest health insurance cost increases in the last 15 years. After already steep boost in recent years, coverage is expected to surge about 9.5% next year, which is, those are large numbers. And you probably heard this from some of your constituents back home. So I think the takeaway there is businesses in Kansas are struggling to sustain coverage, current coverage. And so that being the case, I know we're not talking about specific legislation, but I think it's notable that there is kind of a push to consider legislation to impose new regulations in the healthcare industry. And the proposals may be well-intended to help certain folks, but I think that over-regulating PBMs will unfortunately drive up the cost of care, and that cost has to be borne by Kansas businesses. Employers are the payers for healthcare, so they're largely going to be bearing the costs if there's any subsidy of certain industries in the healthcare space. So a couple points I'd like to make about PBMs as it relates to employers. Employers use pharmacy benefit managers because they save employers money. Kansas businesses, labor unions, public employers, including, as you just heard, the State Employee Health Plan, and you probably also know CanCare utilizes a PBM. They rely on PBMs to manage prescription drug benefits. And PBMs save money by negotiating price concessions with manufacturers. They encourage the use of generics or lower cost brand name drugs. They try to reduce waste and help patients adhere to their medications. And I have some statistics in my written testimony. According to independent studies, PBMs save payers and patients an average of $1,040 per person per year. And estimates show that maybe or around $800 million in the CanCare program are savings through using a PBM. So I think that restricting PBMs will erode those savings and leave employers holding the bag, essentially. You'll also remember when Mr. Turek testified, he said there's, I think, 53 PBMs licensed in Kansas. Another point I'd make to you is that employers have choices in who they use to manage their pharmacy benefits. I think nationwide it's closer to more than 70 full-service PBMs. There's also, you've probably seen stuff in the news about this the past couple of years. There's different pricing models. You can get an administrative fee-based or kind of a cost-plus model. The quote-unquote transparent models are out there. So in healthcare policy lore, if you like your plan, you can keep it mantra. Didn't exactly work out as intended. But I think with PBMs, if you as a plan sponsor don't like your PBM, you certainly can choose a new one and choose a model that works better for you as an employer or saves you money or whatever your priorities are there. Something else I'd bring up, and again, it's a bit hypothetical. We haven't seen legislation yet, but some proposals under discussion might set government-mandated price floors for pharmacy reimbursement, maybe mandating a minimum profit margin. We've seen those type of bills in other states, and I think government, excuse me, I think government price setting rarely works as intended. It certainly is usually intended to help a certain industry, a certain player in the market, but it creates distortions, and I don't think those are things that we should pursue. Those are policies that we should pursue. And last but not least, on the PBM issue, I would say someone has to pay for mandated provider profits. So if there is some kind of a mandate on provider profits, whether for pharmacists or pharmaceutical manufacturers or whoever in the industry, in the healthcare space, someone has to pay for that. Money doesn't grow on trees. It's likely going to be borne by the employer. And certainly some of those costs are passed on to employees as well. We've seen premiums go up for employees across the state too, but largely those are picked up by the employers. And I will note too that this policy issue is a little bit challenging because like some other issues you face in the State House, it's a concentrated benefit and dispersed cost problem. So all the benefits or most of the benefits are going to a certain player in the industry or a certain group, and they might be a vocal industry that you see at T-ball games and eggs and issues breakfast in your district, but the costs are dispersed across most of the employers that pay for healthcare in Kansas, which makes it challenging for you. But I just think our ask to you on behalf of Kansas employers is that you would defend the competitive marketplace and empower Kansas to make informed choices about their health care. And with that, I'd be happy to stand for questions.
Any questions, committee? All right. Representative Carpenter.
Thank you, Madam Chair. Andrew, thank you for being here. So we've heard a lot about transparency. So what do you think about that? Is there room for transparency in the PBMs?
Thanks, Madam Chair. Thank you, Representative. I appreciate the question. I think I'm pro-transparency. I think we're all pro-transparency. But what does transparency mean in this case? And I think we've seen, kind of watching some of the federal legislation that's been percolating and, largely hasn't been passed yet, but has been discussed in the past few years. Transparency could mean that other industry players get to see contractual terms between, private market actors. So I don't think that's a good thing where we as a government are saying that these PBMs have to share their contractual terms with everyone, because what does that do? Well, it really will probably push out the smaller PBMs that maybe have different pricing models or kind of a different cost plus or administrative fees or whatever their pricing model is. I think in large part the larger PBMs, I think it would be a bad thing to have the government inject themselves into those contractual agreements. And I think the smaller PBMs in large part would be the ones that would be hurt by that. And I think it would reduce incentives for negotiating rebates and getting price concessions for employers. So I think depends what you mean by transparency. I don't know if that's as clear as mud, but I tried.
Thank you for that. So I'm an employer and I want to see which PBM is going to provide me X drug. I've got an employee that has a cancer drug that costs this. Do I have the ability transparently look at what one PBM would charge versus another, or all of them, because I'm shopping them for the plan. That's kind of what I'm talking about. I'm shopping and I'm trying to save money, and I've got this employee that's on a high dollar drug. Do I have the transparency to go see what that's going to cost across the PBM spectrum or not? That's kind of what I'm talking about.
Yeah, thanks, Madam Chair and Representative. I think there is already that capability in the marketplace today. I think it's not as easy as, going to a website and seeing, here's the 70 choices I have necessarily. But I think kind of through an RFP type process, putting it out for bid or a competitive response to a request for information, you can, as an employer, dictate kind of what your priorities are. If you want to go for the highest savings, you'll certainly have options there. If you want to go for a more like a fee-based, where you're like, I don't want any kind of spread pricing or rebate things going on that you get to keep. I just want to pay you, a fee, and you guys handle everything else. Those are options that you can request as part of like a competitive bid process.
And I would just add maybe, in that if you're a small business, you're probably going to contract with United or Aetna or Humana or a TPA that's going to bring in another carrier, and you really don't have a say who your PBM is. It's whatever PBM that they use. And so, but they can tell you how much the drug would be with that PBM. So it's kind of folded into the whole package. But yes, you're right. If they're a large employer and they're doing self-funded, and they can talk to the TPA about, we would like to do an RFP on various PBMs, which is exactly what the state employer plan did. Our employee plan, and came up with 3 from the RFP and chose to renew CVS.
Yeah.
Do you have any, I should have asked this of Mike when he was here, is he still in the room, with the state employee plan? He left. There wasn't exactly a lawsuit, but CVS had to pay to the state of Kansas $14 million, and it came down to a question of what's the definition of rebate, because the employer is supposed to receive the rebates. That was settled, and they're paying that back, and was saying nobody's really at fault, it was definition. Can you just tell us what we've seen as far as PBMs and the rebates that go back to the employers? Have there any of the employers in Kansas that have complained about that, or does that seem to be working well?
Yeah, thanks, Madam Chair. A couple things. I think, one, I believe the representative for the PBM Trade Association is speaking later, so he's a lot more knowledgeable about kind of the PBM industry than I am. I obviously represent employers. I think different employers, to your question, different employers have different priorities, and some of them prefer, again, to have more of a, you pay cost plus a percentage, or you have kind of an administrative fee model, and some of them want, the largest savings that can be mustered through rebates or otherwise. So I think there's different priorities, and again, as you mentioned, especially the larger self-insured companies can kind of make those priorities known with their TPA.
And in representing, I guess, some of the businesses in Kansas, my question is, have we heard any complaints about we don't feel the rebates were paid properly, or anything with the PBMs that they've selected? I'm not aware.
Yeah, I have not heard anything like that.
Coming from employers.
Yeah, I mean, I think you could go out and find those kind of complaints if you did a Google search from certain employers, probably. But what I would reiterate to you is there are options. If you don't like your PBM in general, you can go out and get a new one. So.
Okay, any additional questions? Yes, Senator Owens.
Thank you, Madam Chair, and thank you for being here, Andrew. If the title wasn't the Employers for Affordable Health Care, I thought you were here on behalf of the PBMs today. So let's talk about this for just a second, if you would. Isn't it really true that really there are 3 main PBMs in the state that do about 80% of the business?
Yeah, thanks, Madam Chair, and thanks, Senator. Yeah, I do represent employers in this space, but they all use PBMs. So that's why I wanted to testify today. I think, the vast majority of the market is about 3 PBMs, maybe 70%. I don't know the latest numbers. Although I'd say that's not a lot different from, if you're shipping a package, FedEx, UPS, DHL. If you're going to a grocery store and in your town. You know, or if you have a grocery store in your town, you know, there's not that many players in a lot of areas, or I guess a few players make up the majority of the market, but I don't think that leads to any kind of monopoly pricing, if that's kind of what you're implying.
Sure. So to some extent, I would say that, well, inherently it does. It's just not really fair to say you have this broad range of choices when you really have three that control the industry. So, but following kind of along that same line though, do your employers actually get to see like that prescription-based data on a granular level to know that, for example, a PBM is, you know, that's contracting with a pharmacy might be requiring them to sell a drug at a loss? And do your employers support that type of a model?
Thanks, Madam Chair. Thanks, Senator. I don't know that most of them have access to that granular level. I think most employers want to provide their employer-sponsored coverage at a price that's keeps them in business, keeps them as, you know, active money-making players in the economy, whatever industry they're in, and also provides a good benefit for their employees as a retention tool, you know, as a health tool to help their employees and their families. So I think in a lot of different industries, there are probably certain products that could be loss leaders or that you don't make a lot of money on, but there are other products that you do. And so I think I guess I would like to hear from folks on the pharmacy side if, you know, if there's a list of products that they don't make money on, what about the list of products that they make lots of money on? Because I'm sure it's a mixed bag.
Sure. No, and I appreciate that's part of why we're here is to have the discussion so that we can ask questions of both sides of that equation. I'm just willing to bet, as an employer myself, there's probably a lot going on that your employers aren't aware of in this space. But I'll absolutely respect that they're trying to make a profit. They're trying to take care of their employees. They're trying to do everything that they can as well for themselves and for their businesses. So thanks, Andrew.
Thanks, Senator.
And if I could just clarify, having worked with all those, many employers on their health insurance, that if you are self-funded or partial self-funded, you do get much granular information about, but it's more on an aggregate level. Yeah. We spent this much on medications, the most expensive ones were this or that. Yeah. You had 2 employees that you spent this much on medications, it cost the employer X, but no, not down to this with this pharmacy or, yeah, you know, wherever, but they do give. However, if you are fully insured, you're only going to get a statement next year. Well, there was a lot of utilization, your rates are going up 14%. Yeah. So small employers really don't have access to that data. Yeah, right.
Yeah, and Madam Chair, if you'll allow me, I would say, to your point on the self-funded thing, I think you probably do hear about specific granular level cases when there's a really high utilizer. If you have someone who's really sick and using a extremely expensive specialty drug, for example, that's probably going to be something you drill down on because as a self-funded, you know, payer, you're liable for those costs, and it can get very expensive very fast for certain diseases.
See that, like in the state of Kansas, oftentimes your TPA, if you're self-funded, is going to negotiate with an organization that is a PBM, if you will, not for all of the rest of the drugs, but maybe specifically for those very high-level specialty drugs. Yeah. Any other questions for Andrew? Seeing none, we're right on time for lunch. So committee, we have about 15 minutes for you to grab your lunch, take a restroom break, and then we'll start back up at 12. And the lunch is in the us and associates for the lunch today. And this is for the staff and the members only. We're ready to reconvene. We're going to start with our first speaker, Matthew Schmidt. If someone could close the outside doors.
Thanks for being the expert here.
Oh.
This is a tough
Yeah.
issue. See you, young man. I'm not used to sitting for this long. No kidding.
I think the door closing will give them an idea that we're, yeah. Again, if I could have your attention. Conferees, we did not know till all of the presentations and testimonies were in. And you can see on your agenda. So to allow time for everybody to have the same amount of time, these will be timed. However, there will be a total of 10 minutes. That would include questions and answers. So if you're willing to stand for questions, we recommend that you stay right around 5 minutes. And then that does give 5 minutes for questions and answers. Committee, if there is time at the end, we may call up some other folks. But to allow time for each one, we will time it for the 10 minutes. And we're going to begin with Matthew Schmidt, who is the CEO of Health Ministries Clinic. Thank you for being with us.
Good to go. Chair and members of the committee, thank you for the opportunity to speak with you today. I will seek to be concise. I might not even use my whole 10 minutes, who knows, about an issue under which I feel passionate. For context, again, my name is Matthew Schmidt, and I am the leader of a community health center that serves Harvey County and surrounding communities. I am proud to be from Kansas, to live and work in Kansas, and to seek to make Kansas a better place to live. The 340B drug pricing program was created by Congress with a very simple and powerful intent to allow safety net providers like community health centers to stretch scarce federal resources so we can reach more patients and provide more comprehensive services than would otherwise be possible. By design, this program accomplishes these gains without the use of additional taxpayer dollars. It is not a grant or a handout. It is a tool designed to make federal investments and state investments go further with direct benefits to the taxpayers. At our health center and in centers like ours across Kansas, 340B savings are reinvested back into health care. These funds allow us to provide discounted medications to uninsured and underinsured patients, expand medical, behavioral health, and dental services, and make sure that people living in rural and underserved areas can access the care they need close to home. In many cases, 340B savings are what makes it possible to keep our doors open in communities where no other provider is willing or able to serve. For taxpayers, the benefits are clear. Every dollar saved through 340B reduces the need for additional federal and state spending. By helping patients afford their medications, we prevent costly emergency room visits and hospitalizations. By supporting access to preventative care, we reduce the long-term costs of unmanaged chronic diseases like diabetes, hypertension, and heart disease. In short, 340B is a program that saves lives and saves money. I'm most qualified to speak about my experience in Kansas. In community health centers throughout Kansas, this program is working exactly as Congress intended. It is transparent, accountable, and targeted to providers who serve our most vulnerable neighbors. Weakening or limiting 340B would not hurt large corporations. It would hurt real patients, real families, and real communities across Kansas who rely on the access and affordability it provides. If you have not done so already, I would invite you to come see for yourselves how we utilize this program to benefit Kansas. On behalf of the patients and communities we serve, I urge you to support and protect the 340B program. Doing so ensures that federal resources continue to be stretched wisely, the taxpayer dollars are used responsibly, and that Kansans in every corner of our state have access to health care and the medications they need. Thank you.
Mouthful. Senator Owens.
Thank you. I knew my question was coming up, so I didn't take a mouthful. Thanks for being here, Matt. Matt is the leader of health ministries there in my community, and he and his team do a truly fantastic job with our community health center. My question, Matt, is tell me how pharmacy benefit managers interact with the FQHC and the 340B program in the FQHC model of which you're operating. What role do they play, especially since you have your own in-house pharmacy?
Yeah, I mean, I think from our angle, what we're most interested in is any solution or anything that keeps the dollars going where they're supposed to be going. And so we want to, make sure that we have the we're able to provide those medications to people at a reduced cost, but then also, as the program is intended, any savings that we're able to generate through that we're able to cycle that back in to services. I always tell people I'd love to have everybody come down. I'd love to show you firsthand what we do every day with those services. We're actually very proud of what we're able to do. And so anything that gets in the way of that is something that I would have a question about. And so anytime that we have issues with pricing or preferential pricing, or that they try to treat us differently in some respects than they would another pharmacy, would be an example, again, of what we would have an issue with or what we would have a question about. With this idea, again, being we're trying to make sure that all of the money that is possible is going to the places where it's most needed.
And if I might follow up, so again, not trying to put you on a spot, but are you currently, or have you seen any changes over the last few years that are reducing those benefits? Or are you here simply in a proactive means that says, just don't change anything from our perspective, it's going great?
Yeah, and it gets complicated too, because we have both manufacturer issues and we have PBM issues. I think, some of the things that we would say that we're seeing more on our side, and some of these come from the manufacturers. It's not just the PBMs, but the limiting of contract pharmacies. So efforts to restrict how many resources we can bring to bear. So like in our community, and I think this plays out differently in different areas. So it might be that if you're in a more rural area with fewer pharmacies and you have that restricted down and you're not able to use contract pharmacies, you require people to potentially not be able to use a pharmacy that's in their town, that they have to go out of town or out of community. It may seem odd to people in Newton that you would think that we would want to keep all of that business for ourselves. We run our own pharmacy. We have our own pharmacy. We're active supporters of ensuring that we also have the ability to contract with other pharmacies. We have some tremendous pharmacy partners, some of whom are here today. Sandy Keeker is a pharmacist in our community. And they're tremendous partners to us, and we want to be able to use them. We want our patients, they do great work in our community. They're very helpful, and we want to be able to bring to bear those resources also for our community. So when we see either manufacturers or PBMs doing things that would restrict our access to be able to provide, we're all about access. I mean, that's what we do. I mean, it's about access to healthcare. So anytime anything comes along that seems to restrict that, even an example like this where it may not feel like it's our best interest, we want to be able to provide access. We know we're not the right solution for everybody, and to do things like that. There's also issues that come with how the drugs that are sold to us are priced, and I think there's some discriminatory pricing that occurs and happens with that. We'll see that. You'll see that occurring. There are states that have drafted and passed legislation that seeks to take action against this, and you see the pricing's different. It's not the same. They're getting better pricing than we're able to get here.
Representative Ruiz.
Thank you, Madam Chair. Thank you, Matthew, for your presentation. And I don't know if you can quite answer this, but, you know, have seen that you also have your own in-house kind of pharmacy, knowing that psychotropic medications are so extremely expensive, and if we, and maybe this is a question for the pharmacist that'll come up later, the cost of an antipsychotic, and then what the actual cost is to the patient.
You're asking me what that is? I don't have every single price locked in my head, so that will be, and it is also confusing too, because it's not an exact, so it's not like there's always a 20% discount, always a 25% discount. It's kind of on medication by medication, and manufacturer by manufacturer on that. But again, I think for us, it starts off, the most powerful starting point for us is we serve our network, Community Care Network of Kansas, so the FQHCs in the state. We serve 40% of the uninsured, 25% of those on Medicaid, and currently around 1 in 9 or 1 in 8 in Kansas, depending on how you want to do the math about that. And the drive for that is to ensure access to health care. There are so many reasons for that, but it does no good for us to provide the access to that, to get them there, to get them the diagnostic tests, to get the lab tests, to have them do the doctor's appointment, and then get to the point where they said, here's what you need to do, and say, sorry. That's out of reach. And so I think that for us, the most powerful starting point for 340B is it allows us to close that loop and to ensure that we have those medications. The second thing about that, though, and again, this is not this is what the program was intended to do, was any savings that are generated come back. So specifically on behavioral health services. So we have psychiatry in addition to primary medical and dental. We also employ psychiatry and have clinical therapists on staff. And some of those services we provided, they're operated at a loss. And so part of the reason we're able to do that is that we're able to take any savings that are generated and use that to, again, stretch and expand the services that we're at.
I'm afraid the 10 minutes is up. Thank you so much. And we understood from previous testimony that you do have to, you are required to give transparency on how you use the 340B money.
Absolutely.
Is that correct?
Yes, as a community health center,
And do you
that is true.
also provide information as to the number of patients that received the reduced cost? How many of those were actually considered low-income patients? Because a 340B person can be anybody.
Right, correct. Yes, those are numbers that we track.
And those numbers you do track and you do share.
Yes.
Thank you so much. Next, we have Bryant Anderson with Prairie State Health Center. Welcome to committee.
He's taller than me. Yes. And Madam Chair, it's Prairie Star Health Center, but that's okay. I'll answer to anything.
Afraid in our agenda it says Prairie State. I'd never heard
Okay.
of that, so we will
I
change
haven't
it to
I haven't
Prairie
either.
Star,
Okay.
not pointing at anybody in particular.
Yeah. Okay. Okay. So my name is Brian Anderson, and I am from Hutchinson, Kansas. I represent Prairie Star Health Center. I'm the CEO there. And so I just want to thank all of you, the chair, the members of the committee, for the opportunity to speak before you today. So Matthew focused a lot on the value of the program, and he focused on, essentially its purpose. I would like to clarify what it is that Kansas Rural Safety Net providers are asking of our Kansas legislators. This is necessary because big pharma's trade associations and others who parrot their talking points have intentionally introduced irrelevant details and misleading information in order to confuse the issue. But Big Pharma knows they can't win if we stick to the issue. So what is the issue? Kansas Safety Net providers have simply asked for 340B contract pharmacy arrangement protections requiring drug manufacturers to ship 340B drugs to contract pharmacies without conditions. The only relevant thing that matters is, do states have the authority to regulate drug delivery? And the answer is yes. Both HRSA and the courts have reiterated that states have the authority to govern drug delivery. In fact, there are now 20 states that have passed legislation protecting 340B contract pharmacy arrangements. It is also important to make legislators aware of what the irrelevant and misleading information is that Big Pharma's trade associations and others are perpetuating concerning the contract pharmacy issues, so that they can be dismissed out of hand. To do this, I will reference the article entitled "Hawkins, Don't Expand 340B in Kansas Without Real Reform," written by Kansas House Speaker Dan Hawkins. In the article, Speaker Hawkins states that in Kansas, there are some lawmakers flirting with a policy in direct opposition to President Trump's efforts to lower health care costs. In referring to the 340B program, he further states that this program is good for woke politicians. The truth is, President Trump hasn't made any statement either way concerning the 340B program. But the 340B program actually aligns with his policies. Trump's policies have thus far targeted Big Pharma, and he has made it clear that he believes Big Pharma and PBMs are to blame for high drug costs. In stating a Big Pharma talking point, Speaker Hawkins says that some Kansas lawmakers want to expand the 340B program. This is simply not true. Safety net providers are only asking for 340B contract pharmacy arrangement protections that restore drug shipments without conditions. Safety net providers are not asking lawmakers to expand the 340B program, as that would fall under the federal government's authority, not the states. The state can only regulate drug delivery. Speaker Hawkins says 340B has strayed from its original intent. If you go to phrma.org, you will see that the speaker is simply parroting what Big Pharma wants people to believe, which is that the 340B program was only created to provide access to more affordable medicines. By doing that, they can claim that the use of 340B savings on anything more than affordable medicines is abuse of the program with the intent to boost bottom-line profits. Speaker Hawkins continues that talking point in the article when he says that the program is riddled with abuse. Instead of putting money back in patients' pockets, hospitals often pocket the savings for themselves. The truth is, the 340B program is about far more than just affordable medicines. It was enacted in 1992 with broad bipartisan support. Congress clearly stated that the program is intended to provide additional resources to safety net providers, including affordable medicines, so they can stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Kansas safety net providers make no apologies for using 340B savings to create access for mental health, oral health, medical, vision, low-cost medicines, and many other services. For more than 30 years, the 340B program has made it possible for millions of Kansans to gain access to discounted drugs and comprehensive services that they would not otherwise be able to afford. Speaker Hawkins also says that Planned Parenthood uses 340B program savings to provide a backdoor subsidy for abortions. Members of the committee, there is no Planned Parenthood organization in the state of Kansas that has access to the 340B program. I invite each one of you to search the OPICE database to verify that. You will find that Speaker Hawkins is not telling the truth. Speaker Hawkins says that there's cost shifting. He claims that the 340B discounts that manufacturers give raise prices elsewhere, meaning families outside of the program end up footing the bill and the prescription drug costs keep rising because of this. There is no credible, unbiased study that shows the 340B program causes drug manufacturers to raise their prices elsewhere, causing families outside of the program to foot the bill. Finally, the speaker says the 340B program is anti-free market. The 340B program is actually based on free market principles. Under the free market principles, drug manufacturers voluntarily agreed to offer 340B prices to safety net providers in return for their overpriced drugs being covered under Medicare and Medicaid. No one forced Big Pharma to agree to this arrangement. They agreed to it because they wanted access to massive taxpayer-funded markets. Now they want to renege on their agreement to provide 340B prices to rural safety net providers, but they still want to maintain access to the Medicare and Medicaid market. There are two other statements not in the article that also should be addressed. Big Pharma claims contract pharmacy arrangements are to blame for the increased costs in the 340B program. That's blatantly disingenuous. The truth is, There are four main drivers of the increasing cost to the 340B program. One, an increasing number of scripts per patient due to an aging population with more chronic conditions. Two, an increase in new drug introductions coupled with a shift towards more treatment options. Three, PBMs collecting illegal duplicate discounts. Duplicate discounts are a $25 billion problem. Drug manufacturers and drug manufacturers charging U.S. purchasers of drugs up to 1,000% more than they do purchasers in other countries, resulting in larger 340B discounts, which inflates the cost of the program. Plainly stated, there are a lot of common sense reasons why the 340B program continues to grow, but contract pharmacies are not the cause. Contract pharmacies simply serve as a distribution channel to meet increasing demand for drugs and to improve access. Even with contract pharmacies, some patients in my county, Reno County, still drive 40 miles to gain access to their medications. The 340B drug pricing program amounts to just 5% of the $1.6 trillion pharmaceutical industry market revenue. Drug manufacturers also say the 340B program increases the cost of employer-sponsored health plans. The truth is, drug manufacturers provide drug rebates to PBMs as an incentive to put higher-cost drugs on the payer's preferred drug list. PBM and drug manufacturer rebate gamesmanship results in cheaper biosimilars and generics being excluded from health plans. Research by CIVHC confirms that prescription costs for payers and patients continues to rise in spite of the use of rebates to provide for financial relief. The study points to rebates driving increased use of higher-cost brand and specialty drugs. The 340B program is not the cause of increasing cost to employer-sponsored health plans. Imagine the savings for employers if Big Pharma and PBMs acted in good faith and put the lowest cost drug alternative on the payer's preferred drug list. Members of the committee, none of the above claims made by Speaker Hawkins and Big Pharma's trade associations are relevant to the request from the Kansas Safety Net providers for 340B contract pharmacy arrangement protections. None of them. Further, their claims are not truthful. Please don't let Big Pharma confuse this issue. The noise they are using to muddy the waters has nothing to do with our ask and is out of your control. If there are problems with the 340B program, the federal government will have to address them. But when it comes to contract pharmacy arrangement protections, that is under your authority. I live in Kansas. I run a health center in Kansas that employs Kansans, and I'm standing before Kansas legislators asking for your help to protect the Kansas safety net. Kansas safety net providers do not have millions of dollars to hire hundreds of lobbyists to spin the truth, nor do we want to spin the truth. We represent the same people you do, and we also want what's best for them. Big Pharma multinational corporations do not. Respectfully, members of the committee, the Kansas safety net is fragile. You know this. Without 340B contract pharmacy arrangement protections, the safety nets will collapse, leaving many vulnerable Kansans without low-cost medications and access to comprehensive health care services. Contract pharmacies are not the problem. They are the solution. Please join the 20 other states who have enacted contract pharmacy protections to ensure that rural Kansans will continue to have access to care. Thank you for the opportunity to speak before you.
Committee, I'm afraid that is the 10 minutes, so there won't be time for questions, but if you could stay around.
Yes, I will.
Okay. And next we have Paul Schifferl, I hope. And that's with Citizens Health and the KHA Kansas Hospital Association.
Thank you, Madam Chair, and you were very close on the last name. That was very good.
What is it really?
It's Schifferl.
Schifferl, okay.
Perfect.
Thank you.
Well, I want to thank you all for giving me this opportunity to speak to you today. My name is Paul Schifferl. I'm a pharmacist from Colby, Kansas. I work at the Critical Access Hospital, Citizens Medical Center, and most importantly, we provide 340B consulting work for 46 critical access hospitals in the state of Kansas. We also have a total of 60 covered entities that we provide this consulting work for across 6 different states. So I can promise you this is never where I thought I would be when I started my career. I started out just like a normal pharmacist who was mixing chemo, going on rounds, attending meetings, and then one of the things that got thrown on my plate was to try to manage the 340B program at Citizens Medical Center. As I learned more and more about the program, one of the things we started is what we call our cash card program. This is where we're able to take our 340B discount and directly pass it on to a patient. We had set this up for months, and we had had many patients already utilizing this program, when one day something changed that was really big for me. Citizens Medical Center had a patient who was transferred back to our hospital. She had nearly died of a blood clot, and she was prescribed an oral medication that she would need to take for the next 6 months. It was going to cost her $600 to get this medication, and she simply could not afford it. So what she was going to have to do was come in twice a day for the next 6 months and receive painful injections at Citizens Medical Center to treat this blood clot. We were able to get her the medication she needed for just $10, and we did that by using the 340B discount that we had. This seemed like just any other patient we had already done this for, until she showed back up at the hospital and delivered me this thank you note that I've kept in my desk for the last 5 years. So I'm going to read it to you now. CMC staff, Paul Schiffrell, Brandy Work, Chelsea. I don't have the right words, but I'm more than thankful for your caring and help to make my situation a lot easier to handle. I've been so full of mixed emotions and scared. You all have made a big sigh of relief. Thank you for finding me the program for my medicine. Even when I read that today, it's still kind of emotional for me, and it changed the path of my whole career. It was enough that I was brave enough to start reaching out to our neighboring hospitals and see if they needed help with their 340B program, and it turned out a lot of them did. It's also what made me brave enough to come and speak to you all today. And so through that, what I can tell you, again, I know most of your questions this morning, we had these presentations about what was happening all over the United States. I can speak to you what's actually happening in Kansas because we're doing and managing the program at so many of these hospitals. So nearly every one of the hospitals that we're at has a cash card program established just like this. The few that don't are directly related to manufacturer restrictions. I'll give you an example of a hospital that is within 2 hours of Colby. Let's say that they have Pharmacy A and Pharmacy B, and this is a real example, I'm just de-identifying it. They're both independent pharmacies in town, and the hospital has had to make their designation that Pharmacy A will continue to get the 340B pricing. That means every patient at Pharmacy B is out of luck, unless they transfer their prescription to Pharmacy A. The hospital just can't force patients to do this. It's very dangerous, it's irresponsible. As a pharmacist myself, not being able to see a full medication profile and then filling a medication where I couldn't check for side effects or interactions is something that I wouldn't want to be put in the position of. And unfortunately, that's what's happened to a couple of the covered entities that I work for. I also don't want to make it seem like every drug the savings is passed on to patients, because that's not the truth. It's not something that we're hiding behind. We do generate revenue from 340B claims. What we do, particularly at Citizens Medical Center, but you could apply this to all 46 critical access hospitals, is we operate things that operate at a loss. So for example, our long-term care facility, our child care services, our mental health services are all subsidized from savings that are generated from the 340B program. One of those questions this morning was surrounding charity care and bad debt. I can tell you transparently that Citizens Medical Center has never earned more money from the 340B program than we've had in charity care and bad debt. And to my knowledge, none of the hospitals that I work for have ever earned more on their 340B program than they have in charity care and bad debt. So then you start to wonder, why are we subsidizing these hospitals? Maybe it's just bad business practice, but that's not the case either. Hospitals don't operate like a normal business. We just can't cut expenses. For example, if we have a patient show up at our emergency room, we have to provide service for them whether they can afford to pay or not. Another example is if you look at the medication I was talking about that we were able to get the patient for $10, there's another manufacturer who makes that same type of medication in the same class. It's also been priced at $600 for the last 8 years. There's no competitiveness. There's no race to the bottom. If you look at insulin, that seems to really be in the news. Brand name insulin used to be made by multiple different manufacturers, all priced around $500 to $600. Now that there's a generic on the market, it's priced at $80, and there's multiple lawsuits suing these companies for price fixing. We simply don't operate in a free market environment, and that's why we need programs like this to be able to keep our doors open. What I thought I would do now is just address some of the questions that were asked this morning that you guys never really got a straight answer on. So one of those questions was, why does KU Med have so many contract pharmacies? I don't work for KU Med, but I think I can actually answer that question. Colby, for example, we have one Walmart pharmacy in Colby. I'm required to register 7 contract pharmacies on the HRSA OPS website because the way that Walmart works is they may ship medications out to a central fill location who fills it and sends it back to their pharmacies. That skews the number. It looks like Colby's contracting with 7 contract pharmacies that aren't even in our state. That's not where our patients are going. That's just a requirement based on how these pharmacies are set up. Same with the example of the pharmacy in Hawaii. There are special dispensing pharmacies that are the only pharmacies in the United States that can access limited distribution network drugs. They're spread out through the entire United States. Of course, KU is going to be seeing these patients who require very specialized treatments, so their patients are getting mail-order drugs from all around the United States. The location is not claiming that they have Hawaii patients or anything like that. That is why they have so many contract pharmacies registered. Another thing that we heard a lot about was the woke agenda, trying to tie 340B to something that seems completely unrelated. I think you could easily spin that on their head and say, who makes the medications for these types of things? Oh, it's drug manufacturers. Oh, well, they now have more savings when we restrict contract pharmacies. It must be 340B that's funding this manufacturing. I decided to go ahead and look up Eli Lilly because they were the first drug manufacturer to impose restrictions. On their website, celebrating our differences, sharing our success. Diversity, equity, and inclusion is the backbone of our workplace culture. You can find this anywhere. That has nothing to do with 340B, and so I really want to just point that out to you all. We've heard manufacturers want transparency. We need more transparency. FQHCs are the good guys. Well, we've had 2 FQHCs come and talk to you, and the manufacturers are restricting them too. It's nothing to do with we want transparency. It's we want more money. We've heard about in 2010, we've expanded this program. That's where it really blew up. KU was participating in this in 2007. All of the critical access hospitals that I serve were added to this program in 2010. So I can tell you that I'm very thankful for what happened then. Integration. 5 hospitals I work for in Kansas, Gove County, Republic County, Caldwell, Plainville, Minneapolis, have all purchased their clinic. They did this not because of 340B, but what I've heard, the stories that I've heard is these providers were having to spend so much extra on liability insurance. They were struggling with PAs. They were under reimbursed. By purchasing these clinics, that kept healthcare in these places. It wasn't some big outside entity purchasing this private clinic. It was the local hospital. One thing that's interesting in these is these restrictions have been around for the last 4 years. We had someone testifying about insurance costs, and he wasn't able to identify if 340B made a big difference or not. I think you would notice that the cost went down over 4 years if it was directly impacting how much you're spending on insurance. I think we heard some jokes up here that it's going up 14% every year. These restrictions have been in place. We haven't seen insurance decrease. So with that, I'll wrap up and give you time for questions. I know this is a very complicated program. I understand you're hearing tons of different sides and tons of different feedback, but I think it's really very simple for you all. I hope the question that you ask yourself is, what do we think will benefit the most Kansans? That money is going to go somewhere. Either manufacturers are going to continue restricting contract pharmacy and they're going to keep those dollars, or they're going to come to the hospitals here. I don't think it's a far stretch to say that other hospitals are operating just like the 46 hospitals I work for, and they are passing those on to patients. I don't know what manufacturers have necessarily done for Kansas. I don't work for them. But I do think that this program means a lot to our rural hospitals. So with that, I'll open it up.
Thank you so much, and that's 10 minutes.
Okay, perfect.
Thank you. And next we have Melissa Hall with Susan B. and Allen Memorial Hospital.
Thank you, Madam
Welcome
Chair.
to committee.
Thank you very much for allowing me to speak today on the importance of 340B. So I'm Melissa Hall, the CEO of Susan B. Allen Memorial Hospital. We are an independent PPS hospital located in El Dorado, Kansas. We serve Butler County and the surrounding counties. The majority of them are to the east, north, and south. We staff for about 20 patients, and we offer everything from OB services, inpatient, orthopedic services, and ICU. We just recently qualified for 340B. This approval was an integral part of our hospital's strategic plan. I want to share just a little bit of our financial story. So the past 2 years, I've been actively working with my team. We were on the verge of closing, to be just very transparent about it. So for the last 2 years, we have worked extremely hard to lower our cost and improve our revenue. We routinely only have about 30 to 40 days of cash reserve on hand. We've only seen our supply, equipment, and contract staffing rise. Our reimbursements have remained stagnant. Our staff wages have not increased in the past 3 years. Currently, we are not subsidized by any local property tax. And without additional funding source, truly our hospital's to the point of we wouldn't remain open. We have to find another way. We still finished our year with a negative operating margin. So we're on the brink of we have to find a way. So qualifying for 340B truly is that difference maker for us. Though I tell this story about my hospital, and it's hard to tell, and it's probably even harder to hear sometimes, but the sad part is we're not alone. I'm not the only hospital that has the exact same story in Kansas. The 340B program will truly only help us break even without asking for property tax increase. My last point I want to discuss about the 340B program, and probably the most important to me, is currently, so we haven't even initiated our 340B. We just qualified. Our first time we could have started using it was the 1st of July. We're still implementing that program. So currently today, I unfortunately routinely, on a weekly basis, have to hear from my pharmacy team that we are not able to serve our own community members. So our patients present to our outpatient infusion clinic with a doctor's order, and the medication true cost is more than the reimbursement that we receive on it. So our team has to work hard to try to find a location where they can be served, oftentimes resulting in our patients driving 40 to an hour, 45 minutes to an hour away from us. Unfortunately, sometimes this even results in our patients maybe start that care, but they cannot prolong the activity of that drive. The burden that comes with that is too much for them to handle. So some of them result in not receiving a medication at all. Please understand it's not by our choice that we wouldn't serve them, but we have so many other areas in our hospital that truly just don't cover the cost of their own. We can't willingly do that on an outpatient service. I hope today that you will choose for 340B savings to go to local hospitals and community pharmacies instead of pharmaceutical companies. I'm happy to answer any questions at the appropriate time.
You allowed time for questions. Committee, are there questions for Melissa? Yes, Representative Ruiz.
Thank you for your presentation. And you said that your program's going to start?
Yep.
Okay. How long did it take to
Okay, well, so
apply and all that?
So the application process, so there's only certain times that you can even apply, and then you get your approval for that, and then you have to start at a certain point. And so we did technically qualify for July 1st. Unfortunately, our hospital experienced a cybersecurity incident in July, and so we were not able to build all the interfaces that needed to happen. So, but we are back on track now and starting that process.
Yes, Representative Carpenter.
Yeah, thank you, Madam Chair. So in full disclosure, Melissa is in my town of El Dorado, Kansas. So anyway, thank you for being here.
Thank you.
I'm just curious, Melissa, do any of your patients that come there, you said you are built for 20 patients. How long have you been in practice, or how long has the hospital been there?
So we opened in 1931. We actually have 48 beds. We're licensed for 48. Because of nursing shortage, we truly only can staff for 20.
Can staff for 20.
Yep.
but you've been open since the 1970s. Okay.
So 1930s.
Oh,
1931.
Oh, I'm sorry. I thought you
Nope.
said 71. Forgive
Nope.
me.
Yep.
And do you know if any of your patients use mail order for their medications?
I could not answer that. I'm
Okay.
sorry.
Yeah, no, that's perfectly all right. Melissa, thank you so much. Oh, we have another question. I apologize.
Thank you, Madam
Senator
Chairman.
Fagg.
In full disclosure, that's my hometown. I was born in that hospital. We got- and
Well, 1931
where I was
it
somewhere in
is.
there. So I want to keep that place open.
So we were all ready to pounce on that 1931 when it came to Senator Fagg. Melissa, thank you for being here.
Thank you.
Next, we have Matt Morrison with Oriad RX.
Good afternoon, Madam Chair and committee members. I appreciate the opportunity to discuss PBMs with you today. I guess that's what we're discussing today, right? You know, mainly the point I'm bringing across today is that reform is absolutely needed on the state level. I'd like to introduce the company that I represent here today. We are Transparent PBM, where I serve as the Chief Executive Officer. Oriad RX was built and established here in Kansas in 2018. We were founded by 4 pharmacy owners, including myself. Our business was designed to serve health plans in a transparent and honest manner without restricting members' access to essential care. We're growing rapidly, and we process prescription claims for hundreds of health plans here in Kansas. To be clear, my testimony relates only to PBM reform. We really have no direct connection to 340B. Oriad RX is providing proof that reasonable and relevant contract terms result in lower net prescription prices. Our health plan clients have saved hundreds of millions of dollars over the past 6 years, sparing many of them from certain insolvency. Part of our core mission also includes letting patients choose where they seek care, keeping more healthcare dollars right here in our great state. Now, it might seem a little weird that a PBM like ours is advocating for PBM reform, but I'm going to put this blatantly, we're not one of them. Traditional PBMs have implemented tactics that are failing patients, health plans, and pharmacies alike. Oriad RX is represented here today because we believe in transparency and fairness, and our sole purpose of existence is to replace a model that's failing everybody. Let's address traditional PBM strategy, which often hinges on negotiations that supposedly lower prescription drug costs. While these tales of cost reduction sound promising, they're merely a chapter in a much longer and convoluted story. In my experience, these negotiated discounts are almost never passed on to health plans or patients in whole. Instead, PBMs employ opaque tactics like price spreads, retroactive discount or rebate retention, and patient steering. All too often, these strategies are not used as a cost-saving strategy for health plans and consumers, but rather a mechanism for inflated PBM margins. The issue is exacerbated by vertical integration. When insurers own PBMs, which in turn own pharmacies, the incentives become severely distorted. Vertically integrated entities leverage these arrangements to increase the gross cost of prescription claims, to capitalize financially, and also skirt federal minimum loss ratio guidelines. All evidence that I've seen, and I've looked at millions and millions of claims over the last 6 years, I've witnessed the fact that the data points to insurers and administrators are no longer incentivized to offer the lowest net cost options. Instead, they push pharmaceutical manufacturers to raise list prices and prioritize high-cost brand options that generate larger rebates, benefiting the PBM's bottom line. PBMs are also preying on non-affiliate pharmacies for greater profits, particularly targeting independently owned pharmacies. These small businesses are struggling to stay afloat amid unchecked market leverages and unfair contract prices. Both independent and chain pharmacies are closing at an alarming rate, and any claims to the contrary are blatantly false. More than 107 retail pharmacy locations have closed in Kansas in the past 10 years, and many communities have been left reeling from those losses. In summary, if you believe the current prescription pricing system is fair and works for everyone, then inaction is appropriate. But if you believe in if you believe that patients and health plans deserve better, if you agree that Kansas-owned pharmacies should have an opportunity to compete and deliver care, Then as CEO of a Kansas-based transparent PBM, I urge you to act on PBM reform. Thank you for your time today, and I'm happy to answer any questions you might have.
Senator Owens.
Thank you, Madam Chair. And point of clarification and then a question. So this says you're CEO of Oriad RX, but also with the Kansas Pharmacy Association, or are you just here on behalf of Oriad?
So I'm a pharmacist by trade, 2009 graduate of KU Pharmacy. I own second generation owner of Gibson's Pharmacy in Dodge City. Me and 3 other independent pharmacy owners started Oriad RX back in 2017, 2018. That is now my primary job. I act as CEO as Oriad RX. I'm lucky enough to have my wife as a pharmacist as well. She's my pharmacist in charge at the store. And so she's back in Dodge City running the store today.
Okay, so long answer. So primarily here on behalf of Oriad RX, just as you
Correct.
listed from the Kansas Pharmacy. My question is, you said we need reforms. What reforms do we need? Because I don't see that in your testimony.
So in the written, there's some more information on that. I think the most important thing is protection, restoration of free market, protection of, these vertically integrated organizations are freight, training, independent pharmacy. So we need some protection there. We offer fair contracts to our network pharmacies. It's not a hindrance to the health plans when you do that. But I would also say price spread has got to be addressed simultaneously. Otherwise, you do risk raising the cost of prescriptions, potentially. What's not factored into a lot of the conversations that are had here is the margins that's built in price spread on the PBM. So you have to find a way to eliminate that while being able to provide a reasonable and relevant contract and reimbursement term to the pharmacy.
Thank you. Thank you, Madam Chair.
Other questions, committee? Yes. Representative Sutton.
Thank you, Madam Chair. I'm assuming that with your PBM, you have eliminated that spread?
Yep.
Okay.
We don't engage in that at all.
Okay.
What we find is we can pay the pharmacy a fair price. We tell pharmacies we engage with, we are not going to make you rich, but we're going to treat you fairly. And then on the backside, we don't have that margin in that claim. And so we can actually reduce the health plans. I guess to elaborate a little bit, what the pharmacy is paid and what a health plan pays has nothing to do with each other. So when we eliminate that spread in the middle, we can actually, in a lot of cases, in most cases, we're reducing the health plan's liability, mostly generic claims, by eliminating that spread.
Okay, and well, here's what I'm getting. It sounds like you've built the better mousetrap.
Mm-hmm.
Why are you concerned with the other PBMs? If you have a better model, the pharmacists should be running to you.
They are.
And the health plans, for that matter.
Yeah, they are. I mean, ultimately, this is my industry. This is what I grew up in. I mean, my dad was a pharmacist. I grew up in the store. I will tell you, it's like putting a jigsaw puzzle in that place every single day just to try to keep the doors open. And so this is more about Oriad RX than just about Oriad RX. This is about the industry that I went into for a purpose because we're providing care. So for me, this is more than just a new business model that we're offering. We offer a great product, but I want to see this industry, I want to see the pharmacist industry, the independent pharmacies in particular, I want to see them thrive. And in the current climate we have, it's just not, it's not possible.
Well, I think you could probably get the folks in the room to sign on with you, and I think you'd be okay. I mean,
yeah,
you'd be on the right track, wouldn't you?
Ultimately, they're not the decision makers. I mean, you've got brokers, you've got CEOs and CFOs that really, this is convoluted, right? This is hard to understand. And a lot of CEOs and a lot of CFOs don't grasp this, or they're not making the decisions. They're doing it, a broker is doing it on their behalf too. So yeah, we're growing like wildfire. So it's positive. We're trying to make a positive impact. But somebody mentioned 3 PBMs process 80% of the claims in Kansas. I'd argue that there's probably 1 PBM that processes over 50% of the claims in Kansas. And so I think that is another piece of this. And as these independents go out of business, it makes it harder for us because we don't have a large network of affiliate pharmacies like a lot of these PBMs do. So we rely on being able to contract with local pharmacies for adequacy and network and all of that. And what I'm afraid you're going to see is, you know, and they've been pretty, the vertically integrated entities have been pretty public in saying things like, oh, well, if the independent goes out of business, don't worry, our mail order is here to help you. But when they're the only ones, or they're one of the very few that's left in a market, these leverages and these levers they pull for their own margins are only going to get worse. I mean, that's what we call monopoly, right? So that's also a big concern for us. We want to see competitiveness across the market.
Great. Thank you.
Committee? All right, seeing none. Thank you so much. Next, we'll go to Brian Caswell, owner of the Wolker Drug.
Good afternoon, Madam Chair, Vice Chair Sutton, and members of the committee. My name is Brian Caswell. I'm a multi-store owner from Southeast Kansas, a 1987 graduate of the University of Kansas, and a lifelong Kansan. For over 30 years, I've proudly served my community as a pharmacist and business owner. Pharmacy is never routine. Every patient encounter is unique, and through those encounters, we've helped improve lives, educate patients, and at times even save lives. Patients visit their pharmacists on average 30 to 35 times each year, far more frequently than they see their primary care providers. That makes pharmacies the most accessible and most visited entry point into the healthcare system. I've been honored to serve as president of the Kansas Pharmacy Association in 2005, and later as president of the National Community Pharmacists Association in 2019 through 2021, the first Kansan in its 120-year history. In those roles, I've met with pharmacists across Kansas and the nation, and the single greatest threat to our profession and to patient care is the monopolistic and anti-competitive practices of the PBMs. These include coercive copays that steer patients into PBM-owned mail order, mandatory mail order requirements, all of which send business outside the state, and reimbursements to community pharmacies below the actual cost of the medications themselves. No business can survive under those conditions. The consequences are undeniable. In the last 15 years, 1/3 of pharmacies across the United States have closed, with more than 7,000 closures since 2019. The state of Kansas has not been immune to these closures as well, with nearly 100 in the past decade alone. These closures represent towns that lost their only health care provider, and patients were forced to travel hours for a prescription. Meanwhile, the largest PBMs and their parent companies have grown so powerful that they now rank among the Fortune 15 companies worldwide. While pharmacies shudder and patients face rising out-of-pocket costs, these middlemen thrive. Kansas has faced an access crisis before. In 2007, a state study showed that nearly 25% of our counties had 0 or only 1 pharmacy. The average age of community pharmacy owners was 57 years old. A looming crisis, an access issue, was before us. This legislature acted then, investing $50 million to expand the KU School of Pharmacy, including adding a campus in Wichita, all of that to protect access to care. And that decision worked. Today, we face a new crisis. Other states have already acted. Iowa ties reimbursement to NADAC with dispensing fees. Alabama has required PBMs to reimburse at least at the Medicaid rate. And Arkansas has passed laws to prohibit PBMs from owning or operating pharmacies. And there's many other states as well that have passed laws to work against these anti-competitive PBM practices. Kansas can and must do the same. I urge this committee to act now by addressing monopolistic and anti-competitive PBM practices and increasing transparency. You can protect patient access, safeguard rural health care, and ensure that the investments we've made in educating, recruiting, and retaining pharmacists in this state are not wasted. Thank you for your time and for considering this critical issue. I stand for questions.
We do have time for questions, and I just want to clarify, this committee does not take action on it. This is an informational only committee. Thank you, though.
Thank you.
Committee questions for, yes, Senator Murphy.
Thank you, Madam Chair. And I realize that this was all about PBMs on your part, but earlier today we heard testimony that pharmacies were getting 16% on 340B, and since you're in that business, can you address that?
Yeah, I am in that business. I actually have 4 pharmacies altogether, 3 of them in Kansas, 1 in Missouri. I have a contract with an FQHC, and I have a contract with one of my other pharmacies have a contract with a hospital. And under there are different reimbursement costs and contracts that we have there. They're kind of a blend. Some of them have a percentage fee, and then they have a set dollar fee as well. But to say it's 16%, I can't really see that. Like the example that we were giving where it was like a $1,000 drug, we wouldn't be making like $160 or something like that. It's a little bit less than that. In fact, there's many times when we are dispensing to a lot of patients who are at one of the clinics that's under the FQHC, we'll see many prescriptions that are below $10, and so we get a small fee off of that. But the idea is to make sure that we have access to affordable medications, especially those who are underinsured or have no insurance at all.
Okay, thank you.
Thank you.
Other questions? Yes, Representative Proctor.
Thank you, Madam Chair, and thank you for being here today. So appreciate you being here. We have heard a lot, not just in this committee, but in previous committees about kind of the practices of PBMs. And how hard is it for you to not work with someone if you feel like you're being exploited, by a certain PBM or whatever? How hard or easy is it for you to pick and choose who you work with as a pharmacist?
Well, that's a good question because unfortunately, as it's been stated here several times today, 3 PBMs control about 80% of the market. So when we're looking at an uninsured patient, the contracts that are before me is a take it or leave it contract. And I can leave it. And then unfortunately, until just recently, I've had to walk away from some contracts, which I've had the very difficult decision of talking to a family who's been coming to our pharmacy for 50 years that I can't fill their prescriptions anymore under their insurance. They can elect to pay for that. And that's a difficult decision for many families. So from a contractual standpoint, it's difficult at times, and it's a financial decision. We have contracts where sometimes we make a little bit of a profit off of prescription. And just yesterday, I filled a prescription where I literally financially lost $200. And I did it because this lady was a friend of my mother-in-law's, and I couldn't face telling her not to come back. If you know my mother-in-law, you would know.
Senator Owens.
Thank you, Madam Chair. So let's dig into that loss, and some would maybe call it a loss leader. Let's talk about your contract. Are you allowed to tell the patient that you're losing money on that drug?
Well, not exactly. We are restricted somewhat from what we can share. We can, for instance, if there happens to be another medication that's cheaper, we can disclose that to the patient. President Trump, in his first term, I believe, signed some legislation that allowed us to share a little bit more than what we used to be able to, because at one point in time, we could not even discuss anything with the patient. Very, very restrictive. But we are selective in our language because I have not personally been, but I have colleagues who have been threatened with the loss of their contract if they further engage into what I would say what their contracts state in saying anything negative about the PBM.
You sound like you're kind of dancing around a little bit. Are you concerned about the PBMs in the room?
Well, it's funny that has occurred to me.
It's a legitimate question.
It's a legitimate question.
It's a legitimate question.
It's a legitimate question. And I've testified here before I've never had any threatening action to me, but my audits went up.
Surprise, surprise. Thank you.
Additional questions, committee? Yes, Representative Sutton.
Can't follow up on the PBM in the room. That was a good one. Thank you, Madam Chair. Question on some of these, obviously we're going to hear about the stories where you lost money. You're never going to talk, and I don't blame you. Don't worry, I'm not blaming you for this, but we're not going to hear about the one you made a boatload on, and that's fine. But I do have a question. When I want to hear about both sides, not of the winners and losers on the drug sales, but as far as both sides of the equation, as far as reimbursement and purchase price, on the drug, say for example that one where you lost $200, do you have any idea what the purchase price by the PSAO was that then sold it to you? Was there a markup on that threw things out of kilter?
That's a great question, and because I asked myself that question as well. It's like, am I purchasing correctly? And I review all my purchasing contracts all the time. And I am a part of a group that we helped create here in Kansas that actually helped. We created a larger company nationwide to the point of where we are the fourth largest chain, and I call it a chain, it's not really a chain, but fourth largest
Careful,
conglomerate.
we all hate monopolies here, apparently.
Yeah,
so
I know.
Don't go there.
So fourth largest chain in purchasing power.
Excellent.
And yet with that, a very common GLP-1, which you guys see advertisements quite a bit, and we all understand the positives of that medication. We lost $200 on it. And I have shopped it around. I cannot find it any cheaper. What the issue was is just that the reimbursement was below that cost.
Okay, gotcha. All right, thank you.
Yeah.
Thank you, Madam Chair.
Other questions, committee? And our 10 minutes is up. Thank you so much.
Thank you.
Next, we'll have Michael Burns, CEO of Auburn Pharmacy.
Madam Chair and the committee, thank you for allowing me to be here. It's an honor. As you can see, it's complicated. There is a lot going on, and then you throw 340B into the mix, and you've got PBM reform. It's a lot. I did leave my smock at home. I am a pharmacist. Want you to know that I'm a pharmacist, and I still get behind the counter a little bit. But I'm here more as an employer. You've heard a lot about the PBM tactics and the things that they've done, and the devastating effects on community pharmacies across America, and particularly here in Kansas. So I want to come more as an employer, and I'm going to share some stories with you. And again, this is Mike Burns. I am a pharmacist and owner of Auburn Pharmacy. Been operating community pharmacies in Kansas for over 30 years. My wife, Eileen, and I also own several other small businesses here in Kansas. I'm here today to share some personal experiences as a patient, a pharmacist, and very specifically as a small business owner. You've heard a lot today about the PBMs and their practices and devastating effects in healthcare in Kansas. And you're also probably going to hear some testimony that attempts to defend those practices. And I'm going to present facts. Facts as a patient, a pharmacist, business owner, and a healthcare provider. Earlier, we heard some testimony from Dr. Popovian, I think I had his name right, and he also referenced an FTC report that talked about the vertical and horizontal integration of the PBMs and the large insurers, which resulted in an oligopoly that today works like a monopoly. And the other presenters talked a little bit about that and how we have take it or leave it contracts. We have very few options in community pharmacy. What happens then is these corporate giants, they use their models to control cost, but for whose benefit? And it's really theirs and theirs alone. In the wake of the destruction, we see pharmacy closures, limiting access to quality and affordable health care. But then they create fear by spreading the narrative that if PBM reform happens and we have some minimal and reasonable reimbursement to the community pharmacies, that costs are going to increase. It's quite the opposite. PBM reform will create transparency and increase patient access to quality health care while at the same time lowering costs but keeping providers open. In dozens of other states And by the way, I think you have the documents, I hope, in front of you that I have provided. Okay, please refer to those, because there's too much for me to get into. But if you look there, there's dozens of other states that have already taken steps. And I just feel like Kansas is way behind. And it's costing Kansas patients, taxpayers, and providers money. If you take a look at the reform in the other states, the evidence is clear. PBM reform saves money. And I can go down through those, but you've got them in front of you: Ohio, West Virginia, Kentucky. There's a whole list there. But also, if you think about the amount of profits that are within the PBM model, you know, also not just savings from the PBM reform, but if you look at, I have other documents there that talk about the PBMs that have been caught in fraud, waste, and abuse, and practices have resulted in overcharges, hidden fees, and contract violations. And in fact, in 2021, our own Attorney General Derek Schmidt held Centene liable for $27.6 million. That's what they paid to settle the alleged charges, and I think I have a link to that document there as well. So really, you know, what, and you think about what other industries in our country are allowed to behave like this, continue to get caught with that type of behavior, they can write checks and go right back to doing business as usual. There are none. And that's the problem that we have. We have almost zero PBM reform at the federal level, and in Kansas, we have basically none here. You heard them talking about the Kansas Department of Insurance, okay? Talk about what they see and what they don't see and what they can and can't do. So also, you know, what does this do? Obviously, it increases the cost of health care. And as an employer, we today employ nearly 500 people. Healthcare costs are incredibly a big concern to me. And so we're always focusing on that. I'm going to share with you a personal story. About 6 years ago, I was told those 3 words: you have cancer. As a result of my diagnosis, my team of doctors created a plan that included radiation and chemo. And it put myself in, I was in a unique situation where I was a patient, I was also the pharmacist, the pharmacy owner, and the plan sponsor. Where, just to make sure you understand, the plan sponsor is the one that's responsible for providing the health care, you know, to both myself and my employees. Along with my radiation and IV, I was prescribed capecitabine, an oral chemo drug, and it happened to be sitting on my shelf. So at the time, I was fully insured with Blue Cross Blue Shield and had Optum RX as our PBM. In preparation for my treatment, I went to fill my prescription at the pharmacy. I went to the shelf. I pulled the meds off. I went to fill it. Much to my surprise, claim rejected. Had to go specialty pharmacy. Now, let me make sure you understand who determines what's special. The PBM. And they say it's special because it's high cost, and due to the more complicated and complex therapy, it needs to go to their own pharmacy and can't be filled at my pharmacy. Again, I'm under contract to fill prescriptions for Optum at the time, and even for my own, myself and my pharmacy. So what happened, I paid attention, and you'll have the documents there. Some are a little bit blurred, but you'll have my EOBs, you'll have copies of what I actually could have paid, what was I paying for the drug. So if you look at that, my cost after all the rebates for 6 months of therapy was roughly about $2,600. Okay, if you look at the little spreadsheet. And acceptable professional fees, for me to fill those prescriptions, you know, we feel pretty blessed if we can make $15 a script. Okay, so if you look at that, and we would have made, let's go crazy and say $300 for a total of $2,900, which should have been billed to my health plan. Had I been able to fill the prescription at my local pharmacy, talk to my local pharmacist, and have immediate access, but instead it was forced to go to their specialty. And then what you're going to see, the result of that $15,000 was allowed to be billed to my plan. That's a $13,000 increase in profit. And safe to say, they were buying a little bit better than I was, so they probably were making even more than that. Ladies and gentlemen, that's a 4,000% increase. And that's happening thousands, if not tens of thousands of times every day here in our country, increasing healthcare costs. And then also, what did that allow the health plan to do? Obviously, your next year's premiums are based on your prior year's utilization. So not only were they able to pocket an additional $13,000, then they were able to the next year increase premiums, which they were. My premiums were going up an average of 10 to 12, 13% a year. And then I took action. which, by the way, I want to add too, I put in there, add insult to injury, not once did I get a phone call from the specialty pharmacy asking me how things were going. So, and obviously, you know, think about how wrong that is. But then I took action as a plan sponsor. And this is where I really want you to see the reality of when you cut out the middleman. So I created a pharmacy network, Auburn Pharmacy, where my employees get their prescriptions filled at Auburn Pharmacy. When I set that plan up, I also made sure that the professional fees were reasonable, okay? And then I went partially self-funded with stop loss. And then you're going to see what happened over the last 5 years. With average increases between 9 and 16% a year, look at what has happened to my total plan cost between medical and prescription benefits. It's flat. That is attainable. I'm not the only one that has done this. I know other employers that have done it. I just left a meeting a couple weeks ago with other pharmacy owners. They've done the same thing. We're only able to do that because we are able to cut the middleman out. Now, you know, you asked Matt earlier when he was talking about Oriad RX and, you know, gosh, it looks like he's got a great plan and why isn't this thing? You have to understand it's much more complex and there's fear. When you are considering moving from a fully funded plan where, yes, it may be expensive and it's increasing each year, for you to accept that you're going to pay all of the healthcare costs, that is very scary. If it wasn't for the fact that I had inside industry knowledge and I'm a risk taker, I could have never been able to pull that off. So if you look at that, you know, I hope you understand that the narrative that having PBM reform, having transparency, and having reasonable and relevant reimbursement terms to your local community pharmacy, it does not raise cost. It can control cost. It can actually lower cost. In my final minutes, how much time do I have? Dang it. Okay, I was going to take you on a quick history of how the heck did we get here with PBMs. I would do that at another time, but I think it's important to know 35, 40 years ago where we started, how we got here today, and how we need to take it back. So, questions? Thank you very much. Okay. Yes, I am.
So, are there any questions for Mike in our 15 seconds that left?
Okay. Thank you. Okay. Yep. And look forward to seeing you at the pharmacy again sometime. Okay. Thank you.
Hopefully not anytime soon.
Yeah, don't wish that.
Don't wish that. No, I go in and pick up some of my over-the-counter vitamins, et cetera. Jonathan, I think it's supposed to be Jonathan Buxton. Senior Director of State Affairs for Pharmaceutical Care Management Association. Mike, if I may, while Jonathan's coming up here, I did look up Centene, and you're right about that. However, Centene no longer is a PBM, just FYI. Okay, but go ahead.
Thank you, Madam Chair. Members of the committee, my name is Jonathan Buxton. I'm Senior Director of State Affairs for the Pharmaceutical Care Management Association. We are the national association representing pharmacy benefit managers. And as you know, PBMs is everyone's favorite four-letter word. I thank you for the opportunity to be here today. I'm going to summarize the written testimony. There's some more details in there that you can refer to, but I want to hit some highlights and leave plenty of time for questions. I want to start off by saying PCMA as an industry organization is actually neutral on the 340B program. We do not have a dog in that fight. It is not something we engage on. So I know we've been mentioned in reference to it, but that is not something that we would actually engage on. We focus on building the prescription side of the health benefit that plan sponsors desire. They get to pick from a smorgasbord of services. They build the plan that they can afford, that meets the needs of their patients and their employees, and that's what we administer. We really, you know, one of the diagrams mentions we never touch the drugs. PBMs do not fill drugs. We regulate the cost. We push down on the list prices, which are set by pharma, and we do that through negotiating rebates and other discounts. We also push back on pharmacies, encouraging them to compete to make sure that the patient is getting the lowest net cost drug because even if it's available, if you can't afford it, it might as well not exist. And so our job is to be the only member of the supply chain actually putting downward pressure on prices, both from the pharma side, who sets the prices, makes the drugs, sets the prices, and on the pharmacy side, encouraging competition, using large networks that are built out to the needs of this plan sponsor, and also using other technologies such as mail order. That's one of the ways we can achieve some savings. So that's what we do. As mentioned in my testimony, there are about 70 full-service PBMs. It's great to hear about another potential member back here. We'll have to talk about that later. But in Kansas, 53 are registered. The latest research from the American Medical Association actually shows that there are the top 4 pharmacy benefit managers cover 70% of the lives. And so that's showing proof that there's actual competition in the marketplace. Everyone loves using the 80% are covered by the top 3. That's claims processing. But the actual covered lives is the 70% is now covered by the top 4. That number is dropping. That claims processing number is also indicative of the fact that some of the smaller PBMs outsource their claims processing to the larger. So it doesn't necessarily reflect the accurate status of the market. So with that, I wanted to just make sure, and in my notes, I do talk a little bit about how patients pay for healthcare. Patients pay on 2 sides. They pay in premiums and they pay at the counter. And it's very important to recognize the role that those plan sponsors have in helping offset that cost. The average health plan sponsor pays over 75% of the cost for those premiums for those people that they employ. And so the employers and the plan sponsors have a vested interest in this issue, and the patients also have some skin in the game. But that's, keep that in mind as you look at anything moving forward. With that, I just want to say one more time, we have nothing to do with the 340B fight. That's a fight between the pharmacist and the hospitals and pharma. But I'm happy to answer any questions you all may have.
Jonathan, we do have your testimony before us. I'm interested in the chart that you have on page 3, looks like. It's much less convoluted than the PBM charts we often see, and I appreciate that. So could you just identify, so a drug comes from the manufacturer, and you're saying they set the price, but that's not the retail price. That would be the wholesale price, correct?
Well, that would be the price that, it's like the MSRP on a car when you're buying it. So it's what starts all negotiations. And then
Starts the
PBMs.
negotiations.
Oh, sorry.
Okay, no, then walk us through that.
So once the pharma sets the price, PBMs, one of the main duties that we do on behalf of our plan sponsors is to negotiate those rebates. We negotiate rebates based on the number of lives covered, the drug, and then also where it falls on the formulary. And so pharma wants to compete to be closer to the top of the formulary, and so they're competing on price through those rebates. We used to do discounts from pharma, but there was a lawsuit from the National Pharmacists Association several years ago that basically had to flip it on its head. It said that discounts were, I don't want to say illegal kickbacks, but basically we had to shift to the rebate program. And that's when we started doing that on behalf of the clients, is negotiating those rebates.
So let's just use a number. Manufacturer says $100 for this drug, and then explain what a rebate is.
So the rebate would be negotiated by the PBM, and it could be, let's just say $50, because I went to law school, so I wouldn't have to do good math. That rebate is used to offset the cost of providing the health care. The plan sponsor gets to choose how they use those rebates. Some plan sponsors pass those on to patients. Some plan sponsors use them to offset the premiums for the whole book of business that they're covering. Some plan sponsors use that to offer supplemental benefits like wellness programs. But that's completely within the purview of the plan sponsor to decide how they choose to use those rebates.
To define a couple of terms, so plan sponsor could be an insurance company, like United could be a plan sponsor, and if you're fully funded, but a partial self-funded or a self-funded group, the plan sponsor is the employer.
Absolutely. The state of Kansas is a plan sponsor.
Exactly. All right. So now, what happens with that? Where does that translate to the employee that says, okay, tier 1 is this, tier 2 is this, and who decides those tiers?
Those tiers are negotiated, well, I should say, we have Pharmaceutical and P&T committees, I can never remember the name. Those are panels of experts, pharmacists, doctors, others, that decide to make sure that you have the right drug on the formulary. So they're not leaving things off of the formulary. But the formulary placement is part of the negotiations for those enhanced rebates from pharma.
And pharma would love for it to be in the generic somewhere. Generic or preferred generic, because once you get into the brands, then
Right.
that could
And
be an issue.
absolutely, Madam Chair. We have actually seen, since PBMs really started pushing the generics, we've seen generic utilization skyrocket to over 90%, and that's been very great at helping keep down cost. But one thing I will say is that you only negotiate rebates on drugs that have competition. So there's a similar drug in the market that you can go, manufacturer one, manufacturer two, bid on prices, and that's the rebate negotiation process.
So if there's only one drug that addresses this condition, there's not a rebate on that drug.
Correct.
Okay? So now the rebate is $50 of this $100 drug that we said. How is it determined how much the patient pays or the employee pays for the drug?
So
for
the
that
plan-
one drug?
Thank you, Madam Chair. Keep jumping on you, sorry. The plan sponsor determines what the copay or the deductible is for the patient. They get to decide as they build out that plan what the cost sharing will be. That's the choice that they make, and it's usually to offset premium cost or other things. Some plans offer very generous zero copay, like your Kansas plan, zero copay on some of the plans.
Say with that drug, that the plan sponsor said that's going to be $10. Okay? So they pay, the copay is paid by the patient, but the plan sponsor can still pay $50 for that drug, correct? They're only charging $10 to the employee?
The plan sponsor would be responsible for the 40, the 40
Right,
additional
the
dollars.
40. Okay, so where does the rebate come in to the plan sponsor?
That is money generated. So after a series of like a quarter or a month, I'm not sure how often they do those calculations on the rebates, based on the number of scripts that have been filled. Southeast Oklahoma's coming out bad. The manufacturers would pay those rebates. We would pass them on per the contract. However, the plan sponsor wanted to get that, so they would get the extra 50 if they insisted on 100% pass
So
through.
they actually pay a rebate, or is it just that they don't charge you 100, instead they only charge you 50?
It's a paid rebate, is
They
my understanding.
pay the rebate. Okay, interesting. All right, I could go on and on with this. I'll talk to you about it privately, but additional questions? Yes, Senator Owens, I think we still have some time left for you.
Thank you. Only 10 seconds. No. Does a drug manufacturer lose money when they sell a drug?
I can't speak to that. Pharma may be able to speak to that, but my guess is probably not frequently.
Does the PBM ever lose money when they're selling a drug? Can you give me some examples of that?
Sure. So one of the conversations about spread pricing. There are PBM reimbursement models that plan sponsors can select where we would set a certain amount that the plan sponsor would be responsible for to cover the cost of a drug. And in the fully insured market is a great example. They're just paying premiums. And so if the drug price spikes and we don't have some manufacturer rebate built in to say if you spike your price, we're going to get that money back from you, then there is a chance that under that fully insured situation, the PBM could lose money by paying the contracted price for that drug.
Okay, I want to dig in a little bit deeper, and I don't want to steal all the time, but you said there's a chance and could, but do they? And this is my question, because you know what I'm driving at, because I know for a fact my local pharmacist has lost money selling a drug. And so if pharma's not losing money and the PBMs aren't losing money, then tell me why my pharmacist has to sell it at a loss and then can't disclose it to their patient.
Well, thank you for the question. I will say that gag clauses have been banned in the United States for over a decade, or almost a decade. And so they can disclose to the patients information about the other drugs that are available and things like that.
And taking a loss?
They can, it's part of the drug pricing. Okay. That's my understanding. The PBM if they told the plan sponsor they were only going to have to spend X on their drug spend for a year, and it ended up being X plus Y, then yes, the PBM could lose money on that situation. I can't speak to specifics because I don't have those.
Thank you very much. Our time is up, but Senator Owens, I could speak to the fact that with self-funded plans, there can be a large loss to a PBM because the premiums are steady, and they can say that's why your rates are going up 20% because there was a huge loss on how much was paid on pharmaceutical drugs compared to how much premium came in. Okay, I'm sorry. Can we do something at the end? We want to make sure we get our other people in.
Absolutely.
Remind me. Okay. Okay, so Caitlin. I'm sorry, and Caitlin is virtual. Caitlin, you have 10 minutes, including questions and answers.
Well, good afternoon, Madam Chair, members of the committee. Thank you for the opportunity to speak with you today. My name is Caitlin Lucarello, and I'm representing the Pharmaceutical Research and Manufacturers of America, or PhRMA. I want to just start by saying that PhRMA is committed to the 340B program and to making sure that it supports safety net providers and underserved communities in Kansas as originally intended. That said, the 340B program needs reform, and that reform should happen at the federal level. We are proud to be part of a coalition supporting federal reform. From the manufacturer's perspective, the 340B program was designed as one of few mechanisms that pharmaceutical companies have to provide medicines at a steep discount directly to eligible providers, with the goal of making sure underserved patients of safety net providers have access to affordable treatment. Some safety net providers have stayed true to that intent, and we've heard from some of them today. Others are using the program in ways that generate revenue without a clear link to improve patient affordability. And while the discounts that manufacturers provide on 340B medicines are significant, around 50%, there is limited transparency into how those revenues are used and whether they consistently reach patients in need. On the contrary, recent data shows that the safety net program has become so large it's having the opposite effect, driving up costs for patients, employers, taxpayers, who all now bear the burden of 340B hospital markups. As you've heard today, the CBO also pointed to contract pharmacies as a major factor in the program's rapid growth. That's because contract pharmacies allow providers to increase their prescription drug volume, increasing utilization in the program. And what the CBO found was that 20% of 340B spending growth came from drugs dispensed through contract pharmacies. We have seen bills introduced in many states, including in Kansas last session, that aim to require manufacturers to provide 340B discounted drugs to an unlimited number of contract pharmacies. Those proposals, they're currently being litigated in several federal courts across the country, would significantly expand the program's reach. Expanding contract pharmacy networks is not about where patients can access their prescriptions. Patients of 340B providers have always been able to fill their prescription at any pharmacy. In fact, as we've heard today, most patients don't even know they're receiving a 340B drug because over 98% of the time, the discount isn't making its way to them. If you have seen a 340B provider, if you've gotten a prescription from them, you could have been dispensed a 340B drug and similarly wouldn't know it. Expanding contract pharmacy networks is really about increasing volume of drugs dispensed through the program, and maximizing profit. Even as manufacturers have tried to place reasonable limitations on contract pharmacy participation, the program has continued to grow 20% year over year. And in 2017, several years ago, there were about 52,000 unique contract pharmacy relations with 340B providers in the US. In 2024, that had expanded to over 220,000 unique contract pharmacy relationships. Nearly 800 of those are in Kansas. If contract pharmacy use isn't expanded, it doesn't mean that manufacturers get back any 340B dollars. That revenue captured goes on 340B drugs goes to providers. This is a program that does not need to be further expanded. It needs transparency and accountability, and we would suggest that happen at the federal level so that we can ensure that this program does indeed work for the patients that it's intended to and for the system as intended. Thank you very much for spending so much of your time today exploring the ins and outs of this really important issue, and I will yield the remainder of my time to questions.
Committee questions. Representative Proctor.
Thank you, Madam Chair. Thank you for your testimony. And I'm just trying to wrap my head around this idea of, you talk about the some providers using this program in a way other than how it's intended. I'd like you to expand on that, but also how would limiting the number of contract pharmacies that they can use address that issue? How does that fix the problem?
Yeah, absolutely. Thank you very much, Representative, for your question. So we have seen a number of reports that describe how these entities, large hospital systems, may not be using discounts as they're intended to be used by the program, right, to reduce costs on treatments for patients. And I think you heard a couple of examples of those today, albeit not out of Kansas. We have also seen reports of 340B revenues being used for things that are not direct patient care, right? And this goes back to looking at charity care as a proxy for 340B providers, actually putting those 340B revenues in the right place. When we see really low charity care levels, it raises red flags, particularly amongst large providers that we know are getting a large share out of 340B revenues. So some of the things that 340B funds have been reported to be used for include things that are just not direct patient care, right? Things like compensation for board and executives, things like marketing, things like lobbying activities. And as I said before, there are many providers that are using 340B revenues to actually lower the costs that patients are paying for their medicines. And then there are many others that are not.
Madam Chair, if I could, so that was the first question. The first part of the question. The second part of the question is how would reducing the number of contract pharmacies that a provider can use, how would that fix that problem?
Thank you for your question. So we're not looking for a reduction in contract pharmacies. These bills would expand contract pharmacies, but not passing them doesn't mean that there's going to be a reduction from what we see today.
Maybe I'll just restate it, but not necessarily in a different way. Is it the pharmaceutical companies that are restricting the number of pharmacies that can be contracted with, or is that the PBMs, or is that federal regulation?
Thank you for your question, Madam Chair. So restrictions placed on contract pharmacies are individual manufacturer decisions. So, and those restrictions are in response to a proliferation of contract pharmacies in the program, that massive growth that I described in my testimony, from 52,000 contracts to 220,000 contracts just a few years later. But I'll also remind you that contract pharmacies aren't just about which pharmacies a 340B patient can get their medicine from. They can take that script to any pharmacy and they will, in 98.5% of cases, pay the same price. So restrictions on contract pharmacy networks are not restrictions on patient access, and manufacturers are permitted to impose reasonable conditions on their participation based on federal 340B statute.
Representative Proctor.
Thank you. So I'm just trying to unpack this. if the problem is that you've got a bunch of big hospitals and big hospital networks that are using this 340B program that was intended for underserved populations and rural hospitals, how does limiting the number of contract pharmacies fix that problem? I mean, shouldn't we be looking at the problem of big hospitals getting a benefit meant for little hospitals?
Murphy's.
Yeah, I mean, thank you so much for that question, and it's a great question. Yes, so again, we're not looking to pull back the amount of contract pharmacies. Like although the contract pharmacy bills that are passed in many states would expand the networks, not passing them won't decrease the networks. But yes, absolutely, we want to see the 340B program on a sustainable path for the true safety net providers that depend on it. That is part of our federal principles, and the principles that we support at the federal level include protecting rural health providers' access to contract pharmacies, while also establishing clear criteria for contract pharmacy arrangements for other providers.
Thank you so much. We're out of time, committee. Just verifying, there are vouchers that are going around, and some people are just signing whatever one was handed to them, but it may not have matched your name. So. So I am not Michael Fagg, so I will return now. Okay, we're getting this straightened out. While we're doing this, we'll keep moving along. Thank you so much. Caitlin, will you be available later for questions?
Yes, I'm more than happy to make myself
Great,
available.
thank you so much. We're going
Thank
to
you.
try to wrap up other questions after we hear from all of our conferees. Next, we'll move to Sean Greminger with the National Alliance of Healthcare Purchaser Coalitions.
Good afternoon, everyone. Can you hear me?
Yes, please go ahead.
Thank you very much. So I'm Sean Greminger, President and CEO of the National Alliance of Healthcare Purchaser Coalitions. We are a nationwide coalition of individual regional employer purchaser coalitions around the country, including the Kansas Business Group on Health. Taken together, we represent mostly self-funded employers or plan sponsors, representing about 90 million covered lives, so a majority of the employer-sponsored insurance in the United States. I'm here to talk particularly about 340B, although I do also have opinions on PBMs. I want to address sort of three major areas, which is the impact of 340B and its significant growth on self-funded employers and purchasers, and what that means for working families. Two, concerns about the underlying problems with how 340B is currently structured in terms of who actually receives the benefit. And then three, sort of what the path forward might look like. So as you've heard, this is clearly a well-educated committee. For individual plan sponsors, we are directly paying for the health care for our families, for employees and families. When we purchase drugs, most of the time it flows through our PBM, through the PBM contract that we have. And I don't in any way want to defend the practices of the big three, big four PBMs. We have real concerns there. But we are getting a discounted price on those drugs, right, through the rebate structures that have been developed by our PBMs. When a drug is filled through 340B, in general, we do not get access to those rebates. Instead, the hospital or the community health center, the covered entity, gets their 340B discount. Manufacturers have to provide that discount by the law. They then do not provide the rebate that would otherwise be provided through the PBM to the employer or purchaser. So there is a direct impact on our overall drug spending. Effectively, anytime we have a person who is a 340B patient, which could be anybody who has been seen by a 340B covered entity, the employer is paying full price, the full list price for that drug. When you look at, we've done research looking across the country, about $6 billion in money that would otherwise come back to employers, self-funded employers and purchasers through their PBM rebates no longer come through. So our costs have been raised by $6 billion. I want to be very clear, plan sponsors are not just big employers. They are small employers that are self-funded. They are cities, counties, states. So the state of Kansas today is paying more money for your healthcare or the healthcare of employees of the state of Kansas than they otherwise would, uniquely because of growth in the 340B discount program. That's the direct impact on us. The indirect impact is comes from some of the distortive behavior that we've seen by 340B covered entities as the program has grown significantly over time. So there is very strong evidence to show that in general, 340B covered entities are more likely to prescribe more drugs than non-340B covered entities or the non-340B providers. They're more likely to prescribe higher priced drugs because they get the discount, right? They get the rebate or they get the 340B rebate. And they're more likely to mark up the price of their drugs more than a non-340B hospital or health system. In addition, 340B is a major driver of health system consolidation. If you're an independent community oncologist, you don't get access to 340B no matter what you do. You could be serving all low-income or uninsured patients. You're still not in the program. But if you're a 340B covered entity, you get access to those discounts. So there is a profound interest in purchasing certain providers where a significant portion of their revenue comes from drug prescriptions, bringing them into 340B, and then making that margin. 340B is effectively designed as a government-mandated arbitrage program. Buy low, sell high, and then the money flows into the covered entities. That's where we see, when we looked at the relative difference on those sort of unknowable or very difficult to calculate impacts of consolidation, distorted prescribing patterns, et cetera. We did a study. What we found was that across the country, 340B hospitals are about 7% more expensive, not just on drugs, but on all services than non-340B hospitals, and about 20% more expensive on the outpatient side, which is where 340B exists. You take all of that difference, that 7% more across the board, combine it out across the entire employer-sponsored population, and employers are paying about $30 billion more than they would be if they were all going to non-340B covered entities. So when some folks argue that this is not having an impact on taxpayers, this is not having an impact on employers, it's factually false. We know that this is substantially increasing our costs. Now, I want to say I am, whether I like it or not, a 340B subject matter expert. I've been working on this program since 2005. I represented children's hospitals and then public hospitals for many years. I know a lot about 340B. The program, as originally designed, is one that we can all commend. When Congress originally passed 340B all the way back in 1992, they assumed about 100 hospitals would qualify. Today, 2,700 hospitals around the country qualify. The program is much larger than it used to be. And the underlying problem is that most of the savings or the revenue that comes from 340B, to be totally frank, are going to the wrong people. We've heard a lot from rural hospitals, community health centers, Ryan White AIDS clinics combined. Those are all the kinds of people, the kinds of organizations where we think this subsidy should go, right? It makes sense. We all know that those are places that are difficult to keep open. They disproportionately serve a low-income population. They're serving hard-to-access places in like rural areas. The problem is that there's almost no transparency in where 340B dollars actually flow. The state of Minnesota, last year, the legislature passed actually 2 years ago, passed a law that requires covered entities in Minnesota to say how much money they're making on 340B. So take the acquisition price, how much did you mark it up, pull out any of the money that ended up going in the hands of contract pharmacies and PBMs, and tell us what your net is. What we found in Minnesota was that a single hospital called M Health Fairview, it is the teaching hospital for the University of Minnesota, made $130 million just on that arbitrage in 1 year. When you look at the responses from all of the state's rural hospitals, community health centers, Ryan White AIDS clinics, and other HRSA grantees, all of them combined, they made $80 million. So one hospital was making 50% more than all of the organizations for whom we would agree should be in 340B. I don't have that data for Kansas because you guys so far have not required that level of transparency. My strong recommendation to the committee, and I understand that you're a discussion committee, not one that's necessarily going to take action, but as members, would be to say, we need to understand what's going on in this program. Where is this money actually going, and what are the hospitals doing with it? And that's going to get me to my very last point, and then I'll take questions if there's time. 340B has been poorly managed by the federal government, unquestionably. There is no requirement that hospitals or community health centers say how much money they're making on 340B. And at least on the hospital side, there's no requirement that they say what they're doing with that revenue. Now, for grantees, for community health centers, AIDS clinics, all of the others, they have underlying statutory requirements on transparency. So they have to say what they're doing with the revenue they bring in, and they're required to make sure that any revenue they bring in is going back out into the communities. For hospitals, that does not exist. So you could ask any hospital in Kansas or in the country and say, I want to know how much money you made in 340B, and I want to know what you did with it. And they will not have an answer, at least not one that is more than just puffery. That's an underlying problem that we all need to solve. The state of Indiana just passed really meaningful transparency legislation. It hasn't obviously gone into effect yet, but we will now have better information about what's going on in Indiana. And I think that Kansas should be the third state to pass meaningful transparency legislation so that before you make further policy on the growth of 340B, the lack of growth in 340B, or anything else, you at least know who's getting the money and what is going, where that money is going. Thank you, and I'm happy to take questions with any additional time.
We have 1 minute and 30 seconds for questions, committee. Yes, Representative Ruiz.
Thank you for your presentation. Sean, although I can't find it now, in your presentation, you talk about the charity care and not knowing how that's being used, right? And there's nothing in regulation that says, that actually defines charity care. Am I correct in that?
If I said that, I maybe miswrote it. So there are underlying federal law that says hospitals have to report how much charity care they provide. And charity care is pretty clearly specifically defined. It's basically, did you offer free care to somebody who's uninsured, right? But community benefit, which is sort of a broad term for anything that a hospital is doing that they think is to the benefit of the community, there are virtually no regulations there. And a lot of times when hospitals will say, well, all of our money is going back to the community and community benefit, they can add in things like, we sponsored a Little League team and we got to put our logo on, on their jersey. That's nice, nothing against that. I don't think that's community benefit, and I don't think that that's necessarily where 340B dollars should be going.
But there's nothing to say that they can't do that.
No, and that's one of the challenges is under federal law, there is no requirement whatsoever what they do with the money. They don't have, not only do they not have to report it, but they don't even have to do anything with it. They theoretically could use that money to build a brand new patient tower in an upper income community. And I think there's reason to believe that at least for some hospitals, that is exactly what's happening.
Okay, thank you.
Sean, our 10 minutes is up, but will you stay for us to have questions after the next two conferees?
Be delighted to. Thank you.
Thank you. Thank you so much for staying available. Next committee, we have Kevin Mills, who is the Dr. Kevin Mills, President CEO of Ad Astra Bio.
Thank you, Madam Chairwoman, and thank you to the committee for the opportunity to share my thoughts today. I did provide written testimony, and you'll see some of the details in that on those written remarks. I'll keep this brief. I think what I will have to say really reinforces a lot of the testimony that you've heard from a number of the folks who I will recognize as bigger experts in this complicated space than I am. So my name is Kevin Mills. I'm the president and CEO of Ad Astra Bio. We are an industry trade organization that represents bioscience and life science companies. That means that we count among our membership pharmaceutical manufacturers, pharmaceutical industry, but also the healthcare systems that receive and prescribe those drugs to patients that are manufactured by those manufacturers. So we have members who are really on all sides of this complicated issue. So from our perspective, I want to echo the comments of Caitlin that, as a 340, and I'll keep this mainly around 340B, the 340B as a federal program has been poorly managed at the federal level, and we think the fix to many of those management challenges really need to come at the federal level. So I would like to sort of echo those remarks. But I think, as you just heard from Sean a moment ago, there are some ways that the state of Kansas can really go a long way towards ensuring that 340B functions as it's intended to function for patients in the state of Kansas. So sitting in this complicated place, this is an issue that is complex, partly because Kansas, in Kansas, we have large hospital systems that are serving very large patient populations, and we have rural hospitals, rural healthcare centers, safety net providers that are under-resourced and really depend on 340B funds to keep the doors open and the lights on. And so any fixes to any of the potential abuses or potential inefficiencies in the system cannot be kind of one size fits all sorts of solutions, because we don't want to see any reforms that might limit or discourage potential abuses by larger hospitals wind up affecting the ability to deliver care in those rural settings, or make it more difficult or more costly to deliver that care. So I think where that leaves us is that we really favor, I think, a couple of simple ways of ensuring that the program continues to function in the way that it's always been intended to function. And I would like to echo Sean's remarks just a moment ago, that we think this really begins with transparency. One of the biggest challenges in 340B, as you've heard, I think very clearly described throughout today's testimony, one of the biggest problems is that the money that flows in that program is very difficult to track. It's very difficult to be able to follow the dollars from the manufacturer discounts through the PBMs, through the hospitals, and then ultimately to patients. And as a result, that means that there are opportunities to abuse or take advantage of the system. Doesn't mean every healthcare provider is doing that. Doesn't mean every hospital or pharmacy is abusing the intent of the program, but the potential is there. And without the transparency, it's impossible to track those dollars. So there's really two elements to what we, representing both the manufacturer side and the healthcare side, would like to see. The first is very simple transparency. We would like to make it easier to track the dollars from in to out, with an ability to evaluate the extent to which those discounts or price support is actually arriving at patients. We also want to make sure that it's possible to track that the funding and the support that comes through 340B is actually supporting rural hospitals and, as I said, keeping the doors open and the lights on. To that second point, the other area where we think that there's simple provisions that can continue to honor the intent of the program is related to some of the things that Caitlin mentioned a few moments ago around the use of contract pharmacies. This is also a complicated issue because the expansion of contract pharmacies is essentially an incentive to abuse the system and use 340B provisions to pad bottom lines. So there's a high profit motive to expand contract pharmacies. However, contract pharmacies are also a critical element in delivering care and access to medications in rural locations, in healthcare deserts, and sort of in that safety net setting. And so we are also very much in favor of preserving the ability to use contract pharmacies, especially in rural locations. We don't want to make a patient have to drive 100 miles to the pharmacy to get their covered medication. So we want to see the use of contract pharmacies preserved and potentially even expanded, but expanded in a way that increases the availability and the delivery of drugs to patients in those healthcare deserts and rural settings. So this is a complicated issue. I think where we as a trade association stand is that when this functions correctly, patients benefit, the healthcare systems benefit, and particularly rural and safety net hospitals can continue to deliver the best quality care. And ultimately, when this functions correctly, manufacturers benefit as well. The manufacturers that we work with, the pharmaceutical companies, want to see 340B work because when it's working correctly, their drugs, the products that they're making, are arriving at patients. They're arriving at the patients they're intended to do and helping them in their healthcare. And so I think all the parties that we represent are motivated to see that 340B is working as originally intended. And we think using some common sense transparency practices and ensuring that the pharmacy usage, contract pharmacies, are being used in a way that ensures that drug availability reaches patients. Those are two steps that we would like to see Kansas take to ensure that all patients in the state of Kansas are really reaping the benefit of the 340B program. I will stop there. Madam Chairwoman, I will be available for questions at the end.
Excellent. Well, it turns out that you were concise. We have 2 minutes left, so we can fire questions at you quickly. Committee, any questions? Yes, Representative Carpenter.
Thank you for being here. I see in your page here you're talking about finally we would like to increase transparency by banning gag clauses. We had someone testify earlier that that's been banned for a lot of years, but are there still non-disclosure agreements and gag clauses in these contracts with the PBMs and the contract pharmacy?
Yes, thank you for the question. So that's the answer to that is complicated. I'll try to be concise around this. So over gag clauses, and I also will defer to the other experts on the people that are really boots on the ground to deal with this on a day-to-day basis. Over gag clauses may have been banned some time ago, but I think as you've heard in some of the testimony, there are still contractual provisions that limit what information can be transacted between a pharmacist and a patient. And there can be some fairly threatening language around potential violations of some of those non-disclosure agreements or kind of informational clauses. Ultimately, what we want to see is the best information being made available to patients so that they can make the best decision for their healthcare. And whether it's a gag clause or a non-disclosure agreement or something else that puts pressure on the pharmacist or the healthcare provider to withhold information, we think that's what's bad.
Thank you for that. On that same line, we asked for a copy of the contract, and we received back from our insurance department that they could not give us a contract that the PBMs fill out for the insurance department. So talk about transparency.
Well,
yes.
I believe they oh, I'm sorry, you are back.
Thank you so much. That is our 10 minutes. And if you can hang around for a little bit, Kevin, we may have some more questions for you.
I will be available.
Thank you. And lastly, we have Christopher Chastain, Public Policy and Advocacy Director for the National Alliance on Mental Health Illness, Kansas. Is Christopher with us?
Yes, I am.
All right. And do you prefer Christopher or Chris?
Chris will be just fine.
Okay. I prefer Beverly over Bev, so I like to call people what they want to be called. Thank you very much, Chris, and welcome to committee.
Thank you, Chair and members of the committee, for the opportunity to provide written and verbal testimony today. My name is Christopher Chastain. I serve as the Public Policy and Advocacy Director for NAMI, Kansas, the state's largest grassroots mental health advocacy organization. I appreciate the opportunity to provide testimony on the 340B drug pricing program and its impact here in Kansas. The original purpose of the 340B program was essential and straightforward: to ensure that low-income and uninsured patients many of whom live with severe mental health conditions, could access essential medications at affordable prices. Unfortunately, the program has strayed far from this original mission. Instead of prioritizing patients, large hospital systems and contract pharmacies have increasingly used 340B to generate revenue without accountability or transparency. Here in Kansas, we see the consequences firsthand. Higher cost to families and taxpayers. Patients at 340B hospitals often pay more for prescriptions while hospital systems pocket the savings. These inflated costs ultimately fall on Kansas families, small businesses, and our state's Medicaid program. Threats to the rural and community-based care. As contacts, pharmacies, and hospital networks consolidate in wealthier urban areas, rural providers are being left behind. This puts Kansas rural hospitals and independent providers, often the only point of care in underserved communities, at real risk. Lack of transparency. There is no explicit requirement for hospitals or contract pharmacies to demonstrate how 340B savings are used, or whether those funds are reinvested in patient care. Too often, those dollars are pocketed without measurable benefits for Kansans in need. For people living with mental illness, access to affordable medication can mean the difference between stability and crisis. When the system fails, the burden falls on families, local communities, and already stretched safety net providers. NAMI Kansas urges the legislation to assure 340B returns to its original mission, helping patients, not padding profits. Any expansion of the program must include safeguards for transparency, accountability, and reinvestment into patient care, especially in the rural and underserved areas. We believe Kansas can lead by making sure that healthcare dollars are used responsibly and not vulnerable patients truly benefit. Thank you for your time and your commitment to improving health and well-being in Kansas. Respectfully, Chris. And I will stand for any questions.
Committee, we have time for questions. Do we have questions for Chris? Yes, Representative Ruiz.
Chris, thank you for your testimony. We've heard over and over and over today about that hospitals in particular, somehow they're being singled out, that there's a lot of profit to be had, and that's the whole point of them being in the 340B program. But I've not heard any data that specifically tells us that for all the hospitals in Kansas. Have you seen any data like that?
Yes. So I think I understand your question. I got some statistics here pulled up. So I'll just read through them real quick. About $44 billion in 340B drug sales nationwide in 2021, with 78% of being DSH hospitals. That came from the Kaiser Family Foundation. About 69% of the 340B DSH hospitals provide charity care below the national average. That is 2.5% of cost. That is from AIR 340B report 2023. And 36% of 340B hospitals provide less than 1% of the operating cost as charity care. That was also from the AIR 340B report in 2023. 85% of DSH hospitals earned more in 340B profit than they spent on charity care. That was AIR 340B 2022. Top 20% of hospitals generate about 9.92 in profit for every $1 of charity care. That was the Strategic Health Report in 2023. 25% of 340B hospitals provide 80% of the charity care. Health Equity Collaborative of 2024. The program size grew to $66 billion nationwide. 2023 Congressional HRSA data. Kansas 937 covered entities in the 340B of September 2024. That was the Kansas Legislative Research Department. Kansas hospitals hold up to 1,123 contract pharmacy agreements, 59% of them, which are out-of-state pharmacies, AIR 340B Kansas report. 80% of the Kansas 340B hospitals provide below average charity care, AIR 340B Kansas report. The University of Kansas Hospital devotes just 1.6% of the operating costs to the charity care, AIR 340B Kansas report. And Kansas 340B hospitals earn up to 2.3 times more in profit than they spend on that came from AIR 340B Kansas report.
Thank you, Chris.
And is that our timer that I'm hearing? 3 minutes. Okay. Additional questions, committee? I have a question. In the report that you were reading to us, and thank you that you had that at your fingertips for a question that was asked. I'm sorry. Yes, I have his testimony, but I don't have that additional information. So is that in your testimony, Kevin, or Chris? I'm sorry.
It is not. I was doing some late night research because I'm a little passionate about this. I kind of got dumped the opportunity to do the testimony.
You meant given. You meant given the opportunity?
Given, yes, my bad. My bad. Given the opportunity with about 6 hours to kind of put something together. So I wanted to make a little bit more effort and come up with some statistical stuff to present to the committee as well.
Well done. We appreciate that very much. Yes, if you were about to say, if I can forward that to you, that would be very helpful. If you
Yes,
could send that
100%.
to Elizabeth, where all
Yeah.
the testimony was sent. Great. Thank you so much. Committee, here's the intention, in that there were some of the conferees we didn't have time to ask any questions of, and therefore, I'd like to spend the next 20 minutes for you to be able to call somebody up, and if someone does call someone up to ask a question, if anybody else on the committee has a question for that conferee, so that we don't play popcorn and somebody's popping up 4 or 5 times. So I'm going to start with my dear Vice Chair, Representative Sutton, who had a question for Jonathan Buxton, and no, I did not forget.
And actually, Jonathan, this wasn't really a question for you. I was actually going to explain something that you talked about. And so if you want to either cheer me on or tell me I'm wrong if I'm wrong, that would be great. Now, when we were talking about spread pricing, and that was one that confused me for quite a while too. And so I wanted to try to figure out a good comparison or a good way to describe it that everyone gets, and that would be your energy bill. When I know Evergy will do this, I don't know if everyone's will do this, that you can pay a flat rate every month, all right? Some months, you're coming out like a bandit because you used more than you're paying for. Some months, not so much. Like in the wintertime, I'm always paying way too much because I don't use it in the wintertime. So that's kind of what the benefit to it is that I'm able to budget because it's a predictable price. And that's exactly what spread pricing is too. I very often hear people complain that that the PBM, in this case, the PBM is making money because, you know, I'm paying more than the purchase price. I very rarely hear people talk about how angry they are that the PBM's losing money because the price is higher now. So that's where that comes from. And Jonathan, did I describe that about right? And that's an option that companies have, and it's more often used by smaller companies because of the budgeting ease that it then creates. But did I describe that about right?
I think thank you, Madam Chair, for this opportunity. I think that's an excellent analogy. I actually made a note to use it. I do just think everyone should turn off the lights when they leave a room. But you are correct, and that spread between, what's paid to the pharmacist and what the plan sponsor pays is the compensation the plan sponsor offers to the PBM for providing the whole suite of services.
Very good.
Oh,
Oh, sorry. Thank you, Madam Chair.
yes, and that's what I was about to say. Do you have a question, Senator Owens?
Yeah, so I'm just wondering if the PBMs like Evergy could just get a rate increase to the tune of $180 million that we all have to pay. Now, a little sarcasm there, just based on the news headlines of recent. So
Yeah, I almost didn't say Evergy for that reason.
I understand. Thank you.
We heard from testimony after your testimony about how employers are having to pick up the difference in that if they have one of their employees who's going to get a 340B drug, then but because they're on an employer plan, the employer has to pay full price for this drug because it is not the 340B has taken away from the rebate that they would normally get. Is that accurate?
Yes, ma'am.
Any other questions while he's up here with us? Seeing none, thank you.
Thank you.
Anybody else would like to call someone up? Representative Proctor.
Thank you, Madam Chair. I was hoping that Mr. Brian Caswell could come back up. And it's just because you're in a white coat. And so we've heard a lot about, not necessarily today, but in previous hearings on PBMs about increasing the transparency on the prices and the rebates and where the rebates go. Today we heard quite a bit about increasing the transparency on where the 340B proceeds go in hospitals and how they're spending the money. Why is it not reasonable for us to also ask pharmacists because I think that the eminent chairman of the House Insurance Committee raised this issue. We never hear when you make out like a bandit, as he said. We hear when you lost money filling a prescription. Would you guys be open to having transparency on your own kind of cost-benefit analysis?
Absolutely. I think we've advocated that transparency is important. And one of the reasons why you may not hear of the big wins is because there's not any. That could be part of the answer, is that we don't make like $160 on a prescription very often. I mean, it is rare. But I lose $35, $50, $100, $200 quite often. As a matter of fact, I think the latest NCPA study was showing that a lot of independents were reporting that around a third of their medications that they were actually dispensing was at a loss. So obviously there's going to be some wins because if you can't do that and sustain a business. So there are some winners and there are some losers, but predominantly we're seeing closures across the state and across the nation is because the losers outweigh the winners quite often.
And I think I just want to clarify for the committee, when the statement was made, I went back to look it up about the $16 on every 100 or the 16%, they were referring to the amount that the PBM would make or the middle marketer, not necessarily the pharmacist. So wanted to clarify that for you. I do have a question for you, and then we'll see if anybody else does. Was this for this conferee? Okay. And that is you have 4 different pharmacies, is that right?
Yes.
Okay, and are they all in the state of Kansas?
3 out of 4.
3 out of 4 in the state of Kansas. Where's the 4th one?
It's in Carl Junction, Missouri, which is right across the line, if you're familiar with that southwest Missouri area.
Great. Okay, any other questions for this conferee? Seeing none, thank you for being here.
Thank you,
And Representative Oropezzo, you have a conferee you'd like to call up.
Yes, Madam Chair, thank you. If Melissa Hall is still here? Thank you, Madam Chair. So my question is, you said you just recently did the paperwork for the 340B and had the cyber attack and all those things happen. Was there a reason, since this hospital's been open since 1931, like what delayed or what made this year the year for 340B for you?
So truly, When I first took over, I took over the CEO position about 2 years ago. We had been previously told that we wouldn't qualify for 340B over and over because we were not critical access. I will tell you, I worked very hard to try to get critical access designation, but because of our location and our proximity to Wichita, we're not able to do that. But then we had a company come in and actually do an analysis for us, and because we qualify for DISH, we were able to actually qualify for 340B.
Okay, so then my follow-up question is, who told you wouldn't be eligible?
Multiple times our auditor.
Auditor, okay,
Yeah.
thank you.
Additional questions for Melissa? Seeing none, thank you so much. And committee, is there another conferee that you would like to call up? Senator Owens.
Thank you, Madam Chair. Is Bryant Anderson still with us? Bryant. Your testimony provided a lot of information, but there was one thing I didn't get a chance to ask you about. You were talking, and you mentioned, I think, twice during your testimony, this shipping/delivery issue and the drug manufacturer currently doing something that we need to prohibit. Can you be more specific about what you were referring to in that drug delivery piece?
Sure. I think what you're probably referring to is, there's been 2 attempts at a bill to protect contract pharmacy arrangement, the contract pharmacy arrangements. And so probably what I was talking about is the fact that, they've, as you heard from the PHRMA rep, they've placed restrictions on the pharmacies. So they've restricted it to, if you have an in-house pharmacy, some drug manufacturers say that you must use that pharmacy. So let's say, for instance, like Prairie Star Health Center in Reno County, which is one of the biggest counties by landmass. I think we have 9 contract pharmacy arrangements spread all around to, make it easy for patients to get the drugs. And so what pharma has done, of the 37 letters we've received, one of them might say you have to use your in-house pharmacy. So that's it. So the only place the patient can get the drug is our in-house pharmacy. Other manufacturers have said, well, if you have an in-house pharmacy and you have contract pharmacies, you can pick one. So you could pick your in-house, or you could pick Dillon's on 5th Street or the mom and pop in South Hutch, clear on the other side of Hutchinson. So it just depends, but generally it's either use your in-house pharmacy, you get one contract pharmacy, or you can use your in-house pharmacy and have one contract pharmacy. That's it. I've seen no other variation on that. So what we had asked legislators to do was simply at least not expand. You keep hearing the word expand today. There's no expansion. We're just simply saying, can you just reinstate what is statutorily protected? And the courts have decided that. And the reason you don't see pharma continue to hammer away at the contract pharmacy thing is because they know that they've lost that battle. They're not going to win that. It's done. It's like they can continue to spend millions of dollars on that, and they're not going to win. So I don't know if does that help?
Yeah, so what is I'm just curious, what's the benefit to the pharmacy manufacturer? I mean, they've got to have a reason that they only want one.
Right. So I know Representative Proctor was trying to, and I was kind of chuckling because I wasn't hearing the answer, but you're talking about the benefit of them restricting us down to one. I have to take her at face value that the intent is to get it like the large health systems, so they don't have a whole bunch of contract pharmacies. But to be completely honest with you, you might be able to make the argument that someone would go without their drug because they won't drive the distance to get it. But is that what we want? It's not what we want. So the whole point of the contract pharmacies, at least in the rural areas, is it puts it closer to the patient for when they're not in or they've taken the RCAP bus that we paid for them to take. Well, she couldn't answer the question. I mean, just respectfully, guys, she couldn't answer the question as to what restricting it down to one would do. Well, what it does is they know they can save some money because some patients are going to go without their drugs. That's just what happens.
I thank you for your straightforward approach. Your testimony
and you guys are
was really
welcome to
informative.
come
Thank you.
to Prairie Star and see how it operates.
Brian, I have a question for you in that KU has its own pharmacy in-house, but they have 222 contract pharmacies. Could you explain that?
So I honestly, until you just told me that, I had no idea they had 222 contract pharmacies. The only thing I could wrap my head around that to say is, you know, at one point they owned the Great Bend Hospital. At one point, I think they were in the Hayes Hospital. So their footprint is so large across the state that probably what's happened is they have assumed pharmacies as their footprint across the state has grown. And so they probably control some, they probably have contracts with pharmacies across the state where they operate. That's probably the only thing I could, you'd have to ask them.
And I'm just asking because it seems like as part of the ACA, that instead of just in-house or just one, that's when it was vastly expanded, that you could have more contract pharmacies. So
actually, it wasn't expanded under the ACA. And I can get you an intervener on the Arkansas case, and I can also get you the Federal Register. The fallacy that it's been only one pharmacy, one contract pharmacy, Congress considered that. There were some recommendations made, and they were rejected. So actually, multiple contract pharmacy use has been in place before the ACA.
Okay,
So if whoever told you that, which that's why I went through, I know my thing was probably boring, but I get so tired of hearing the spin, and, you know, I just want you guys to know the truth.
Brian, can I just tell you? I chair 8 different committees. They're all health related, not boring to me. So
Okay, great. Well, we can keep talking.
right in my track.
Okay,
You know,
great.
thank you very much. We will have other questions for you, so we'll go with okay. Pointing to Senator Murphy. Okay, go ahead, and then Representative Ruiz.
Okay, thank you, Chair. Bryant, so what is this restriction? What has it done to Prairie Star?
It has reduced our contract pharmacy savings by, I don't remember the exact amount, but we've had to work things around and try to get patients to our pharmacy in-house, you know, pay for RCAT transportation, run a shuttle service to get the medications to them. So it has reduced our savings, which, again, as you heard, the program was not originally intended for just low-cost medications to patients. It was scarce resources. In other words, right now, our community health needs assessment says that we need to do something about dental oral health care in our community, so we are. And how do you think we're doing that? We're using 340B net savings. Without them, we couldn't do it.
All right, thank you. And in full disclosure, this is mine.
I'll claim him as well.
Representative Ruiz.
Thank you so much. I've learned a lot from you, and I may go and spend a day with you and try to learn more.
Yeah.
So one of the things that the hospitals have really been a focus.
Yes.
And then the transparency with the 340B. What I haven't heard is, do we need transparency reform for big pharma and for, you know, the PBMs?
Thank you.
I mean, I haven't heard anybody say we need transparency there, because it seems like we need it.
I'll try to answer that, because that's a lot. But thank you for that, because I keep hearing, well, you know, the hospitals and the health centers need to do this and this and this on transparency. We would love to see transparency on the part of the big pharma and the PBMs, because I'm here to tell you, 340B statute clearly protects what we're asking for, the safety nets, which is just protect our contract pharmacy arrangements, right? That's all we've asked. All this other stuff today is irrelevant to what Kansas can even do. But the thing is we when they did this, when they started restricting our contracts with our pharmacies, you know, shipping drugs to these contract pharmacies, they required us to put our data into a system called ESP. It's one-sided. There's no neutrality. So it's a condition. It's basically you put your data in there. If you don't put your data in there, we're not going to ship the drugs. Some just said it doesn't matter. We're not going to ship the drugs. So they even have a way to get at our information, but we don't have a way to get at their information. So here's the thing. There's a thing called a neutral clearinghouse, and I've been working on that federally, and I'm here to tell you that if you guys wanted to mandate a neutral clearinghouse, there's your solution. and then it require the drug manufacturer to report into it, require the state to report into it, and then there's a company that can actually pull all that together. You can run a port, and you can find out what's going on.
Senator Proctor, we have time for one more for this conferee.
Thank you, Madam Chair. So you said something that sort of re-triggered that conversation. If they limit you to one contract pharmacy, it doesn't mean that customer can't go to another pharmacy. It just means that you don't get the 340B benefit. Isn't that correct?
Correct. Well, so there's a few things that could happen. The patient doesn't get the drug because of distance, travel, whatever. But yeah, basically, yeah, what's going on is any of those pharmacies that they've restricted, no 340B transactions can happen at those pharmacies. So any transaction that happens at Dillon's on, say, 5th Street or the Ashcraft Pharmacy out in South Hutchinson, if those are restricted, which they are, if a patient of ours lives out there and gets their script there, there's no 340B transaction on that. You're absolutely correct, which is why they're restricting it, because
they still get their medication and it still gets covered by the insurance. You just don't get that spread.
Exactly. And if it's a patient that is uninsured or, patient that's going to get a discount on the med, then we've got to somehow get it, at the one pharmacy that they can get it at. And I did want to say, I used to be in hospitals, critical access hospitals, so I can just quickly say on their behalf, I was in a town of 2,242 people, Anthony Medical Center, and I'm here to tell you, the facility wouldn't have been there without the 340B program. So,
Actually makes me wonder how we had any hospitals before 340B started.
it's the reimbursements has continued to go down.
Thank you.
So.
Thank you so much. Next, what I'd like to do is, Caitlin, if you're still there, I'd like to give you an opportunity to address what was just said about the reasons for the restricting the number of contract pharmacies. Are you still available?
I am here.
Okay.
Thank you, Madam Chair. So the reason why I didn't talk about individual restrictions is because I represent the trade organization. All manufacturers' restrictions are individual company decisions. So I can't speak to what individual restrictions actually look like. I think if it is helpful, I can maybe try to answer Representative Proctor's question in the inverse a little bit, which is going back to the point in my testimony that contract pharmacies are a major driver of utilization. That was just shown in the recent Congressional Budget Office report. It has been shown in other studies, other recent studies, one which found that it was 100% the driver when you look at 340B discounted drugs. If there are more contract pharmacies, providers can dispense more 340B discounted drugs. And what we see from some of the prescribing patterns and the data on prescribing patterns that was discussed earlier today is that, particularly with 340B hospitals, because that's what they've looked at, they are dispensing more expensive medicines. So if they are dispensing more expensive medicines and more of them from contract pharmacies, that drives up utilization of the program, which leads to growth in the program.
Thank you. And are you still here, Jackson? Could you address, are you aware of any of the, and Caitlin, I'd like to ask you this too while Jackson's coming up. Are you aware of any of the pharmaceutical companies that only allow one contracted pharmacy?
Do you
Caitlin,
want me to start? Thank you,
Yeah.
Madam Chair. I appreciate that question. Like I said, I can't speak to individual company restrictions, but I do want to kind of correct the record on contract pharmacies in particular. So that is a word that does not appear anywhere in the federal 340B statute. It first appeared in HRSA's guidance, which does not have the force of law. So there was one contract pharmacy, they were expanded, and then in 2010, they were expanded to remove any limitation on contract pharmacies in guidance, not in statute. So it's a fundamental change to how the program was actually operating in 1992. And again, not in statute, in guidance. So we've seen litigation on the federal statute in at least 2 courts, and that have found that the statute is absolutely silent with how drugs must be distributed under the 340B program in regard to contract pharmacies, which supports which, is, what you would expect to see, given the fact that we don't actually see the word contract pharmacy appearing in federal statute.
Thank you.
340B statute, absolutely. Thank you very
Okay,
much.
thank you, Caitlin. Jackson, did you have something that you wanted to add?
Yes, on top of the fact that it leads to further growth in the program, which for the pharmaceutical manufacturers is a problem because it costs them a lot more money. That means it's costing R&D a lot of money. It's money that's not being spent on drug development. This is also an issue with the more contract pharmacies there are, as Representative Proctor said. It just means that the hospitals don't get the discount. They can still prescribe to any pharmacy in the state that's near that patient. The patient should not be going without that drug simply because they can't get the 340B discount. Additionally, more contract pharmacies creates additional layers and difficulties in determining if there are duplicative discounts, particularly in the Medicaid program. It makes it much hard. It adds more actors into this very tangled web, make it much harder to suss out where if there is any improper behavior in that. And so the bigger the program gets, the more difficult it gets to do oversight.
Thank you so much for being with us, and thank you to all the conferees that were here today. And committee, I think we still have time. I know that some of our House members will be leaving at 3, so that's why we intended to dismiss at 3. We are going to open it up to the committee to talk about your thoughts on today and then any recommendations. Senator Diedrich.
Thank you, Madam Chair. I would just like to say thank you to all the conferees that came to visit with us today. I think that some of you traveled from far away, and I really appreciate that. You've given us a lot of great information. I chair the Financial Institutions and Insurance Committee in the Senate, and I've got committee members here today. And honestly, I just really appreciate all of the facts, charts, testimony, conversation. You've answered questions. There's a lot to digest, and I'm glad we're not a committee that's going to take a lot of action here, because I think there's a lot that we need to understand and to grasp. So even though we did cover quite a bit of this in the Senate last year with the 340B bill that we had, I do appreciate you taking the time to visit with us, and you know who we are, and we now know who you are, so I hope you'll stay in touch. And as legislation might move through our chambers, it would be great to make sure that you use us as a resource and we use you as a resource. So thank you so much. Thank you, Madam Chair.
Committee members, what you have in front of you was the citations that were given by Eric Turek from the Department of Insurance, and he said that he would give these to us. So that's what you have before you. Any recommendations, committee, or any other thoughts? Representative Ruiz.
Some thoughts, or one thought, and I just mentioned it a minute ago. We had just tremendous amount of information, and I'm very thankful for everyone that came, almost everyone that came, to give us information. It was really good. It was very in-depth. People knew what they, their information, and they could answer some very direct questions that we had, and I'm really happy about that. It still seemed to me that the focus was on the hospitals, and there were some direct attacks to some of our local hospitals, and I really did not like that, and I felt I had to defend our hospitals. And this piece of transparency, that even though there is nothing in statute that really defines what charity care is, but yet there seems to be some data out there saying that hospitals in Kansas are not utilizing all of their savings for charity care, but then they're saying They couldn't prove the data. So that was very confusing to me. This whole issue of transparency, absolutely. We all need the transparency piece, but it all seems also to be that pharma didn't need to have transparency, that PBMs don't need transparency. All the fingers kept getting pointed to the 340B, and yet what we know is that 340B is essential. It's an essential program. And so I just felt like I needed to say that. But yeah, thank you for all of the information.
Yes, Senator Owens.
Thank you, Madam Chair. Along those, some of the lines that have already been talked, though, really, while I know we're not a policy-making body, we really should do something in that transparency, accountability piece. I think regardless of what side you are of this issue, we heard it from both sides all day that transparency in the 340B program would truly help us make the best decisions. An example of that I will use was about 5 years ago when we were digging into civil asset forfeiture. And the first thing we passed was a repository at the KBI to gather all civil asset forfeiture data. And then we took all of that data after we received enough of it, and it was very, very clear the abuses that existed and exactly what we needed to do. And what that did was force even the opposition to the table because the data was so clear. And I think in a lot of ways we can get there with this program as well if we have all the information. Thank you.
Other questions or concerns, thoughts? Representative Sutton.
Thank you, Madam Chair. I agree on that, on the transparency piece, on the 340B program. I agree with it 100%. I am very leery, however. I mean, I would certainly I would push that one. I've got no problem with that. I would be very leery with getting too much tinkering under the hood, however, when we know that there are bills currently floating around on the federal side, and they made this mess. They should be the one cleaning this up. I know the odds of that are not massive, but nonetheless, as a federal program, here's what I worry about. I worry about every state going to try to fix a federal program and creating this mismatched quilt of ridiculousness in the process that ends up, just it'll all end up in court anyway, and most of it is currently. So I'd be very hesitant to take massive steps on this. I think adding the transparency piece, similar to what Minnesota did, sounds like a good idea to me. But that's really the only thing that presents itself to me that I'd get real jolly about right now. Thank you, Madam Chair.
Representative Ruiz.
I just wanted to add something about the transparency piece. I agree there is we need that, but not just on the 340B. But I also don't want I don't want you to use that as a distraction and as a way to stall any kind of state support that we really should put in place for the 340B. Because it's something, we did have the Senate Bill 284, and it got stalled, and it just, I don't want this transparency piece to just be a distraction and stall any legislation that we might be able to move forward with.
Representative Turk.
Actually, I was giving you baseball signs to look over to Representative Proctor, but yeah, I should have been more clear with the signals.
Representative Proctor.
All right, I can't follow that. No. First of all, Madam Chair and staff, thank you for having me on this committee, and thank you for holding this committee. I know how hard it is to assemble something like this, and thank you to all the conferees. I've been watching this 340B question bounce around the Capitol for several years now, and because it's never come to the House floor, I never really waded into it like I have over the last 2 days, and I appreciate being educated on the problem. I'm 2 days old on this, but what I see is that the major, from my perspective, and I'm clearly not an expert, my perspective is that the elephant in the room is that you've got these giant hospital networks that are now floating in the 340B pool, and in a way that it was never really intended. It's supporting hospitals it was never intended to support, and whether it's transparency, which I'm dubious about because of the fungibility of money. You can say, yeah, I use my 340B money to, serve my uninsured population, but that just means it freed up money for you to go do something else that's not subject to transparency because you didn't spend the dollars on that. Or if it's, forcing manufacturers to allow for more, contract pharmacies, I think are all kind of nibbling around the edges of the real problem, which I agree with as I frequently agree with the chairman of the House Insurance Committee, that really the Fed should be fixing. And so I'm really, really, really dubious about any state solution here, though I do see that if we at least had some numbers, we could make some more informed decisions about what to do next, but I'm not sure after we get the numbers we'll want to do anything next. Thank you, Madam Chair.
Let's see, Senator Murphy.
Thank you, Chair. Yeah, this has been a very enlightening day. A lot of information. I think we've had a lot of we've got a big issue, of course, between the cities, like Senator Dietrich has mentioned. We've got 5 counties who maybe get the bulk of this and everything, but then we've got 100 counties that rely on it. I think it's important that we kind of continue to try to work through this. I think it's really critical for Kansas, especially for our rural areas. And I don't know if are we doing motions here or anything? No, okay. But I just think we should continue this into the next session. I think we should be looking at this in 2026 and see. In other words, I don't think we should say, okay, well, we looked at it and call this good. I think we need to keep looking at it.
Hand, Representative Tarwater. Nope, that was another baseball signal. Okay, I gotta get better with these. Okay, other comments, thoughts, Senator Starnes?
Thank you, Madam Chair, and I appreciate the fact of lots of information and continue to glean through it. And I'm a one-timer here, so I came in to bat cleanup, by the way, and bottom of the ninth. So I think the things continue to look at it, but I think we also need to remember what our state responsibilities are regarding the local contract, the situation with those that are specific to contract pharmacies and as a state. And then the federal, as you said, make recommendations, or as others have said, make recommendations maybe to our state legislative body about what we see and how it can help Kansas. But remember to stay within the guidelines of what our responsibilities as a state are. Thank you.
Senator Carpenter.
I'm on the transparency bandwagon. I see no problem. A lot of this money is state tax dollars, federal tax dollars. I think that we have every right as a state and a citizen to know where our money is going and how it's being spent. So I'm with that. Several of us were on this same committee, 3 years ago, and we asked for how much money they were making in 340B. 2 hospitals returned the amount that they were making. Many of them told us no, and not just no, but they didn't return. So this has been kicked around a long time, but I fail to see anybody that would have any opposition to transparency. It just blows my mind that we wouldn't want to know that we're doing a good job and that this money's going where it's supposed to be. So that's where I'm at on this. Thank you.
Representative Ruiz.
Thank you so much, Madam Chair, for entertaining my questions, or my statements. I want to second Senator Murphy with this, and I know we're not doing motions, but I just want the committee to know that Senate Bill 284 passed in the Senate, 34-6, so that was really good, but it never came to the House. And I would like to see this committee, you know, if we have make a solid recommendation that that's SB 284 move on, that we get to have a hearing in the House. And, you know, if we want to talk about transparency, that would help us. If we bring it on to the House and have a hearing on it, then we can have people come and give us some information regarding transparency. It would open that up at least. Thank you.
Any other thoughts? I'll just share with you a couple of things. Of course, I've been aware of this program since its onset and have seen it expand. And because I work in private health insurance and for employers and individuals and states, one of my greatest concerns is watching the cost that has been escalating to employer plans. You heard money, dollars thrown around in Kansas of $64 million. It has taken away some of the rebates that employers have had because now we have a two-tiered pricing system. I think that's something that definitely needs to be addressed, but I feel that it needs to be addressed in the federal level. This is, again, just the gospel according to Beverly. But I do feel like I agree with what Representative Proctor said about the fungibility of funds. I could say I use it for this, but maybe it just freed up money for us to do these things. But I think it would be good for the legislature to know how much money are we talking about here. Would you be surprised if one hospital in 1 year got $45 million just from 340B alone? Is that important for us to know how much money came in from this program? So, and I have a real problem with we as a legislature, as a state legislature, when you have a federal program, and I can't speak for all of you, maybe because I'm now chair in the Senate, but when I have folks that come to me and say, do something about Medicare, what's the first thing I'm going to say? It's a federal program. But I also say, well, I do write Medicare. I do help people with their Medicare. As a person over here, set that aside from being your senator, I'd be happy to take a look at, see what your issues are and see if I could try to help. I think we all do that with the areas of expertise that we have. If somebody is maybe having difficulty with a program and that would require a social worker, I might direct them in this direction over here to Representative Ruiz, or somebody has an issue with something that I know that there is a legislator that can handle that. I have been in strong conversations with our federal legislators, and I'm glad that Senator Marshall has responded with some things that they are working on. I'm glad that the Trump administration is looking at it. We're not saying, hey, this is a horrible program, we need to get rid of it. Nobody ever thought it was a horrible program. But do we really know how it's being used? Are we really sure how it's affecting employer plans? And then when it comes to PBM and pharmacists, what we have to be careful about and why this is ending up in courts in some states is that imagine if a vendor who sold stuff to their product to Walmart came to your office and said, they aren't paying me enough for that product I'm selling them, make them pay me more. Again, that's not our role. That's not our job to get involved in private contracts. And I know we can say shipping, but I don't think that's the kind of shipping that Kansas would oversee. Also know that, you know, PBM oversight, as you heard, very little oversight in the state of Kansas on PBMs. And should we not? You know, that's a discussion that we can have. But I do think that, you know, they're basically wanting to kind of overhaul how subsidization is happening with our rural hospitals and make sure it gets where it needs to go. And I'm pleased with the fact that, we have, you may have heard of $50 million, I believe, that is going to be distributed among some of the rural hospitals, and Kansas is applying for some of those funds, which would be direct subsidies to our rural hospitals. We also have heard about, if you don't know what provider fees are, basically it's a money laundering scheme, if you will, that you have, the state can so-called collect fees from hospitals and providers and then turn that in as part of their fees that they're submitting for Medicaid. And then they get back not only that, but then more. That comes back to them, and then they just reimburse the hospitals what they took from them and then some. And it has been 3%, has been the amount that we have used in the past. The federal government, prior to the Trump administration, had said that they would allow possibly 6%. Kansas is still kind of in limbo right now because they requested the 6%. That's a lot of money that goes back to the hospitals, a great deal of money that we really don't have a lot of transparency on, but yet we can through our Medicaid department. So I think before we as a legislature are jumping on the train, of course we're all for transparency. I am definitely for transparency, and it would be good to know, as Senator Owen said, how do we know what we're talking about unless we know how much monies are being spent here? How much money is being taken in by these plans? And might we then, once we have that transparency, decide what, if anything, a state should do? But I also would encourage all of you to reach out to your federal legislators. I've told my friends that are pharmacists, I'll go with you. This is the wrong capital for some of the things that you're wanting to have done. I'll walk in there with you to our federal legislators about some of the things that are happening and let them know what's going on, with some of the program and some of the concerns that you have. I thank all of our conferees that are here today. I want to say thank you for the committee and the time that you've taken and invested in this and that you've watched that. I'm sorry. Okay, great, thank you. Yes.
I do have some.
Yes.
A little bit more information on HCAP, which is what you're talking about, the provider tax. Ours was approved. It's in the process. We got in just under the wire. And I, too, believe that it's kind of a scam, but quite frankly, we're competing against all the other states that have it. And if we don't apply for that federal money at 6%, our hospitals are at a disadvantage. I realize that if everybody did away with it, I'd be fine with it too. We're competing with all of our surrounding states. Our little hospital, Melissa's the CEO of it, it's about $1 million a year. Quite frankly, we're struggling until the payments are dispersed. Not we're, but the hospital is. And it's a lifeline for a lot of these little hospitals out here. The critical access hospitals and them are sharing in it this year.
And those are dollars that don't need we know how much is going to your hospital.
Right.
And it's $1 million this year, it could be $2 million next year if the 6% is approved. And that was my point. This is direct funds that are going to these hospitals.
Exactly. And that's the way these things should work. Thank you.
All right, committee, we were just about 6 minutes under the wire. Want to be able to get you out of here on time. Thank you so much. And committee, we are adjourned.